during the pediatric appointment, there is a 1 month period for neonatology. So it's very important for you to know these interventions before starting the internship. Now, everybody, when we talk about neonates, most of the junior doctors actually were very scared to handle a neonate. That is due to there's a widely shared but mistaken idea that improvements in newborn health requires advanced technologies and highly trained staff, which is not true. You need to have a lot of skills and a lot of technologies to manage a neonate. So when you talk about the basic newborn interventions, now as a pre-interns, it is your responsibility, adhering to these interventions. One thing is antenatal steroids and giving prophylactic antibiotics for a premature upper membrane, and delayed cord clamping, which is a rather new thing, and skin-to-skin contact, and first breastfeed within 1 hour of birth, and prevention of hypoglycemia, hypothermia, vitamin prophylaxis, and all the newborns has to undergo newborn examination before discharge, and kangaroo mother care, and reducing the healthcare associated infection, which is very important. You know, our neonatal mortality, I think higher percentage is due to the neonatal sepsis. So if you adhere to the and inpatient care for sick or small newborns, and also development care, and you should know about the danger signs and what advice to be given to mothers. And at the end, as a house officers, you are supposed to enter all these data into the database. Now we have a island-wide perinatal database, so it is your duty to enter this data into the database. So when you talk about antenatal steroids, you know, in out of our total number of deliveries, 10 to 15% deliveries are due to prematurity. So you know that giving antenatal steroids reduce mortality and morbidity, and also the surfactant deficient lung disease, and also it reduces intraventricular hemorrhage by about 50%, and also in preterm babies reduce the risk of neck. So available drugs in the hospital, we have dexamethasone, so 8 milligram intramuscularly every 12 hours. That is actually 4 doses, not 3 doses. Or if you have the betamethasone, it's a long-acting one, 12 milligram intramuscularly every 24 hours. So it's very important for you to, give in timely, because the optimal benefit, and when delivery occurs 24 hours after completing the therapy. There's no point in giving a steroid dose just before delivery. So optimal benefit will occur if you have given in timely 24 hours before the completing the delivery. So other important thing, as interns, you are responsible for giving prophylactic antibiotics to mother. So that is with the mother with a premature rupture of membrane. And as I told you, the sepsis is a very common problem in newborns. So prevent early onset sepsis if you have seen. But the NICE guideline says erythromycin and ampicillin, that is due to the available sensitivity pattern of this organism. So once you start internship, go and see what is the protocol. That depend on the unit. Can ask the seniors what antibiotics to administer. So it's, in Sri Lanka, it's very, we are fortunate, more than 90% of deliveries take place in an institutions. So, that means attended by skilled healthcare workers, midwives, nurses, and doctors. So that is great achievement that we have to take the advantage of it. So, anybody who is dealing with the neonate and the mother during delivery need to have a basic resuscitation skills and early newborn care skills. So resuscitation skills, there's another separate lecture for you to go through in this program, how to do the neonatal resuscitation. So before, it's very important, you have to prepare for a delivery. So, for a baby to deliver, you need a warm environment. So around at least more than 25 centigrades, best is around 28 centigrades. So yeah, you have to stop all the functioning air conditioners, fans and windows. And if there's a warmer, it's better to keep the warmer on. And as a obstetric house officers, you have to make sure the mother is wearing a suitable clothes, which we can place the baby in between my mother's breast for facilitate the skin-to-skin contact. And you need to have sterile kit to tie and cut the cord. And out of all, the hand washing is very, very important. And you are supposed to wear double gloves, because when you are wearing a single pair of gloves, so perineum is a very contaminated area. So if you want to do a sterile procedure with that contaminated gloves, you are introducing infection to the mother as well as the baby. So if you are wearing double gloves, you can remove one before cutting the cord, which is a sterile procedure. So so now it has been recommended at delivery to have a companion of choice. This companion could be either husband. The problem is in our setup to keep our husband. There's no privacy in our labor room sometimes. So if that is the case, it's always better to have either a close friend or a mother or the mother-in-law. But if facilities are available for this to protect the privacy of the other patient, you can keep the husband. So it has been shown by studies, it reduces the need for analgesia for mother. So now from the WHO, they have put forward 10 steps at birth in an essential newborn care package. That is, in first one is the call out for the time of birth. I think it is very, very important in our society and our culture, because the time of birth is very important to our mothers. Depending on the time they make, horoscopes, and they take that time to send the child to school and marriage and everything done according to this birth time. So its mothers are very anxiously waiting to know the correct time of birth. So it's your duty to call out the time of birth. So now we have this. We have set the standards to even to cut the cord and clamp the cord. That is from 2 to 5 centimeters from the baby's abdomen. And after cutting the cord, you have to dry the baby with warm, clean towel or a piece of cloth and wipe eyes. And there are no special eye care in our babies, because infections like gonorrhea and other infections are rare in our setup. So while you are drying, you have to assess the baby's breathing. Yeah. So at the time of birth, you have to start the stop clocking and delay the recently introducing is a delay the cord clamping for 1 minute. Why? So the placenta had to pool blood for about 150 ml. So unless if you just clamp the cord soon after birth, that blood will remain inside the placenta and the cord, and the baby can be hypotensive. And because of that, even term and especially the preterm babies, it's very useful, because they have shown the number of transfusions that the baby would need during the stay will be less if we have done this delayed cord clamping. And necessity for the maintaining inotropes to maintain the blood pressure is also low if you have done this delayed cord clamping for 1 minute. So keep in mind. And if your registrars, SOHs who are doing the sections and delivering the baby to the nurses and midwives, please remind them to delay this cord clamping. And you have to collect the baby and place it under the warmer in a cesarean section. Or if it is normal delivery, you can keep the baby. You have to deliver the baby onto the mother's chest and keep the baby in between the breast. So meantime, you have to assess the baby while crying. That is, you have to assess the color, tone, breathing, and heart rate of the baby. So delayed cord clamping, at least you have to do for 1 minute. So it is very advantageous for especially for the preterm baby, but they talk about it's a must for a term babies as well. So the nursing care, once your baby get into the warmer, you have to check the cord clamp and dry the cord. We use the dry cord care, and you don't apply any antiseptics, including surgical period. And after that only you have to check the weight and OFC length. You have to do in a hurry to do these things because the baby can become hypothermic. Again, from the WHO, they have put forward the 10-step at birth. The fifth one is the deliver the baby onto the mother's abdomen, as I said, after the cord clamping, and cover the mother and baby with warm cloth. Baby remains between the mother's breast, skin to skin contact, and put a hat on the baby's head because that is the area baby lose large amount of heat, and place an identity label on the baby. Now, the mothers are very anxious to see whether the baby, has mistakenly given to another mother. So before that, show the tag and show the mother that we are applying this tag on the baby's leg. So it's very important. And encourage first breastfeed within 1 hour of birth. Immediate skin-to-skin care is very important, and put naked between the mother's breast, and that prevent hypothermia and increase the bonding. And the baby will be colonized with the mother's friendly flora, not the flora inside the labor room, which is a very nasty organisms inside the hospital. But if you keep the baby straight away to the on the baby mother's breast, baby will colonize. First colonization will take place mother's friendly with mother's friendly organisms. So establishing breastfeeding is very important. Now it is a must that the baby should be fed within first hour after birth. Now usually once they born, they are a little tired. If you put the baby onto the mother's breast, can you see that the baby is just resting on the mother's breast for a while? But after some time, say about 10 minutes, now they started to sort of move around and look for a opening the mouth, and the baby himself that trying to latch onto the breast. These are the hunger cues. So if you see the hunger cues, baby has to be, you have to facilitate and help the baby to latch onto the breast. It's very important. So for successful breastfeeding, mother has to be very more motivated, and my baby has to have an active sucking reflex. So no point in talking about the reasons for breastfeeding, lot of advantages, those things. And about the cord care, I told you that we have the standards. We have to cut the cord 2 to 5 centimeters from the baby's abdomen and put nothing, and observe the, at the same time when you're cutting, you can see the number of umbilical arteries. The conditions associated with the single umbilical artery. So it is important for you to notice that. So vitamin K administration is, all the babies has to get vitamin K. And weighing, you have to use the digital scale, and scale maintenance is important. You have to calibrate daily and clean the scale between each weighing. You should not sort of use the same this thing before cleaning. You have to put the baby after cleaning the scale. The growth measurements should be done by the midwives, but you have to be supervise these whether they are doing it correctly. Otherwise, always it is 36 and 54, which is not the case. So prevention of hypoglycemia is very important. So hypoglycemia is something preventable. Symptomatic hypoglycemia causes neuroglycopenia. So prevention of hypoglycemia as well as hypothermia is very important. Neonatal examination, I think there is a separate lecture. I need not to go into details of that. And before transfer into the postnatal ward, dress and wrap the baby soft, dry clean. And the neonatal examination usually we will be doing before discharge. And these are the things, skin to skin contact, and usually we check the baby's temperature, but not using always the thermometer, but you can always feel the baby's feet and see baby's hypothermia. So at the postnatal ward, you have to maintain the temperature more than 25 in the postnatal wards, and check the temperature on admission, but it's better to check the temperature on admission to the postnatal ward or to the neonatal unit, and keep the baby in the same room with the mother, ideally in her bed, and assess warmth every 4 hours by touching the baby's feet by mother. You have to tell the mother, touch your baby's feet every 4 hours and see whether it's not cold. And avoid bathing for 24 hours, and establish and strengthen the breastfeeding. So these are the mechanisms of heat loss. You can remember radiation, large amount of heat will be lost due to radiation from the scalp. That is why soon after birth and after drying up, we have to put the hat on the baby's head. And by convection, that's why we have to keep all the doors and windows closed. And to stop by heat loss by evaporation, we have to dry the baby very thoroughly. Otherwise, even a single drop of water on the baby's body will reduce about 120 kilojoules from the baby's body. And if you keep the baby on the surface area which is cold, say usually this metal trolley in the labor room, there will be a heat loss by conduction as well. That's why it's very important for you to deliver the baby onto the mother's abdomen or to the chest. So hypothermia, so body temperature should be maintained at 36.5 to 37.5. So, so prevention of hypothermia, now the kangaroo care is the best practice. It has studies have shown it is better than keeping a baby inside an incubator. So now definition and degree of hypothermia, normal range is 36.5 to 37.5. We say it's cold stress if it is between 36 to 36.5, and moderate hypothermia, that is 36 to 32. But severe hypothermia is less than 32. If that is severe hypothermia, I think moderate is very high, about 80%. So diagnosis of hypothermia is not a very, if you need not to keep the thermometer and check. You just touch the trunk and extremities. If the trunk and extremities both are warm, that is normal. So trunk is warm, extremities cold. That is what you call cold stress. That is a temperature between 36 to 36.5. If the trunk is cold as well as extremity is cold, that is hypothermia. Yeah, so skin care. So we have to wipe amniotic fluid, meconium blood at birth, dry scalp and hair, because our babies are usually hairy. So there's a lot of fluid in between the hair. So you have to ask them to dry the hair thoroughly. Do not rub vigorously the wipe away the vernix. Now they thought the vernix is again for a natural mechanism to protect the baby from getting hypothermic. So don't remove the vernix, let it be. So after some times it gets sort of dried up and removed automatically. Bathing has to be delayed for about after 24 hours. High care, we don't have that problem, so we need not to take special attention for the high care. And bathing baby, usually warm room, warm water, and dry and quickly and thoroughly, dress warmly, and after that you have to give the baby for a breastfeed. So prevention of hospital-acquired infections, hand washing is the most important thing. I know during the COVID pandemic, you have got very good idea about hand washing, and breastfeeding. Early breast milk is the other preventive, because the mother's colostrum contain a lot of immunoglobulins and antibodies which can protect the baby from infections. And skin-to-skin contact to prevent the baby getting colonized from the nasty bugs in the labor room or the NICU. So skin-to-skin contact, keeping the baby in a kangaroo position is very important. So remove unnecessary IV lines, minimize skin pricks. So aseptic procedures and handling of IV lines, clean cannula habits. So you take all the precaution for a universal precautions too when you are doing these things. So hand washing, I need not to talk about. You have got a very good idea about hand washing. Now this is a graph which shows that the alcohol-based hand wrap has that is 70% alcohol has, clears about 99% of the organisms in the hands. So then now we do some screening. One is the thyroid screening, and we also do the pulse oximetry for detect the duct-dependent congenital heart diseases. If the preductal, that is the right hand, and the lower limbs or the left hand, if the saturation is different, more than 3%, after 24 hours, we have to send that baby for a echo before discharging. Yeah, so now you should know what is normal and abnormal. Now you can see the baby with the umbilicus in the upper picture is a normal, healthy umbilicus, but you can see the lower down one, you can see the ring of erythema around the umbilicus. That may be a possible serious infection. So you have to identify these very early. And you can see these babies, one is jaundice, the other baby is normal baby. And danger signs, if there's any bleeding, jaundice, early, extensive or prolonged, failure to pass meconium or urine within 24 to 48 hours, persistent vomiting, poor feeding, undue lethargy, excessive crying. I think I got to know about these things. Danger signs and conjunctivitis. You can see that there is some erythema around the umbilicus and purulent discharge, and the other one is a candidiasis. So this pustule, if the pustules more than 10, is something to be treated. And the other picture on the right hand is erythema toxicum, which is a non-specific rash. Most of the babies do get. So danger signs, not feeding well. So this pustules more than 10. Umbilicus draining pus, so the umbilical redness, bleeding from umbilicus, fluffy or stiff in the convulsions. And prevention of hypothermia during transport also very important. And document temperature and take appropriate actions if you have to transfer the baby. So the best way is to, if possible, kangaroo position is the best way to, if the baby is stable, can keep the baby in a kangaroo position with the mother, you can transfer. So advice on discharge, you have to advise them how to keep the baby warm, hand washing, minimize handling, restrict visitors, immunization, home visits by the public health midwife has to be arranged, and ensure baby check done, and CHDR has to be given to the mother. So discharge criteria actually depends on the unit. So once you start to work, depending on the unit, you can get an idea. So preparing for discharge, feeding well. If the baby is feeding well, sucking effectively 8 to 10 times for 24 hours, day and night, and there are no danger signs, and mother confident of taking care of the baby, you can discharge. So follow-up visits has to be arranged for assessment of growth and development, weight gain, and we have to educate the mother for exclusive breastfeeding for 6 months. Now our breastfeeding rates has gone down after the COVID, but you have to encourage them continue the breastfeeding practices for exclusive breastfeeding for 6 months and starting complementary feeds after for 6 months. And the last but not least, very important for you to enter this data into the perinatal database. Thank you. Any questions?
විනාඩි 5කින් ජොයින් වෙන්නම් කිව්වා. තන්ද මැඩම් ඉන්නේ.
Right. Next lecture is by Dr. Sandhya Dolavira, madam. It's on establishing breastfeeding at birth. So she will join shortly. Madam, we have given the introduction. Madam, you can start.
Yeah. You can see the slides.
Yes, madam, can see.
All right. Okay. Good morning. Good morning. So with the next half an hour, I'm going to talk about breastfeeding, how to ensure a good start. Breastfeeding is a very important topic of discussion because not only it is taken as the best way of feeding a newborn, but also the problems related to breastfeeding is commonly encountered in our practice. Actually, studies have shown that about 70% of lactating mothers experience various difficulties. Yet, the solution is very simple. It's just counseling and education with some kind of a practical assistance is all what is needed, right? So, as medical professionals, irrespective of your specialty, I think you may encounter these cases at any time, be in the hospital setting or your GP practice or even in your personal life. Therefore, it is very essential to have a thorough knowledge on this topic. So what is the current policy in Sri Lanka? Exclusive breastfeeding for first 6 months of life. What do you mean by exclusive? That means an infant's consumption of human milk with no supplementation of any type. No water, no juice, no non-human milk or any food except for vitamins, minerals, and other medications. And the other policy is to continue breastfeeding together with complementary feeds up to the age of 2 years and beyond. So, to achieve this target, it is important to ensure a good start. To have a good start, you need to counsel and education the mother during the antenatal period. Start from the antenatal period and then you have to continue throughout the postnatal period as well. So during the counseling session, you will have to talk about the benefits of breastfeeding, disadvantages of giving formula, and how the breastfeeding process happens in the way that can be understood by the parents, and also the problems that they may encounter. So all these things have to be addressed during the antenatal and postnatal counseling. Not only the mother, I think the whole family has to be addressed. Then the next step of ensuring a good start is to initiate breastfeeding within the first hour after birth. You will realize why I am telling this, to start the breastfeeding within first hour after birth. And then there should be continuous support throughout the period of breastfeeding. So as I told you before, being a medical professional, I think we have a very important role in helping the mothers to establish good breastfeeding practices. So why breastfeeding is so important? So what are the advantages to the baby? Firstly, it has the ideal biochemical composition for digestion and absorption and provision of nutrition for the optimum growth. It has immunoglobulins you are aware of, right? So which will protect them from infections like diarrhea, respiratory infections, UTI. In preterms, it will reduce the risk of sepsis, necrotizing enterocolitis, right? And the other thing is its unique composition optimizes the neurodevelopment. And it is found that breastfed infants have a better IQ than the formula-fed babies. And the other thing is it will protect them from chronic diseases like diabetes, childhood cancers, obesity, inflammatory bowel disease, asthma, allergy, right? So many advantages to the baby. So what are the benefits to the mother? It will reduce the risk of hypercholesteremia in the mother. The things like diabetes, hypertension, cardiovascular disease, breast and ovarian cancer, they are reduced, right? Then the hip fractures because of the osteoporosis is reduced, and they quickly return to the pre-pregnancy weight. And again, the lactation amenorrhea can give a partial contraception as well. In addition, because of the effect of the oxytocin, it will reduce the incidence of PPH also. What are the advantages to family? It improves bonding with the baby, the family and the baby. So no cost, right? And it is very convenient, no preparation need, and it's fresh. So chances of contamination is less with breastfeeding. Right. So we will go back to the anatomy because the knowledge of breast anatomy is very important to get an idea about the breastfeeding process. If you can remember, the breast is composed of mammary glands surrounded by a connective tissue stroma. The mammary gland consists of series of ducts and secretory lobules. And each lobule consists of many alveoli which are drained by lactiferous duct. And these lactiferous ducts then converge at the level of nipple, and they are lined by milk secreting cells which are under the influence of prolactin. Right? So that is how the milk secretion is happening. Then these alveoli are surrounded by the myoepithelial cells, and under the stimulation of oxytocin, these myoepithelial cells can be contracted, and thereby the milk will be ejected into the lactiferous ducts, and through the ducts will drain into the lactiferous sinuses where it is stored. So these lactiferous sinuses are actually situated beneath the areola. So generally, the number of alveoli in any female breast is constant. What does that mean? That means any mother can secrete the same amount of milk because this the alveoli are constant. The connective tissue stroma is the supporting structure. It has a fibrous and fatty component, and it is this fatty component that gives the shape of the breast, right? So never mind it's a small or a large breast, irrespective of the size, the ability of a mother to secrete milk is the same. So when it comes to physiology, there are two hormones involved in lactation. One is prolactin, which will help to produce milk, and the other thing is oxytocin, which causes ejection of milk. So physiological mechanisms in the baby include some kind of a primitive reflexes, rooting reflex, sucking reflex, swallowing reflex. All these are important in the mechanism of sucking. And it is very important to understand this mechanism to find the solution to most of the feeding related problems and to counsel the mothers. So let's learn about these physiological responses. So as I told you, prolactin is the hormone necessary for the secretion of the milk. So the level of prolactin in the blood increases markedly during pregnancy, and it stimulates the growth and development of the mammary tissue in preparation for the production of milk for the baby. However, this milk is not secreted then because progesterone and estrogen, which are in high level during the pregnancy, will inhibit its action, right? So after the delivery, the level of progesterone and estrogen falls rapidly. So prolactin is no longer blocked, and the milk secretion then starts to happen. The main stimulus for prolactin secretion after the birth is suckling. So when the baby suckles, the nipples get stimulated, sensory impulses pass to the anterior pituitary to secrete prolactin. So therefore, early initiation of breastfeeding is important to establish breastfeeding. The more the baby suckles, the more prolactin is produced, and therefore more milk is produced. And if the mother stops breastfeeding, the milk secretion also will stop. The other important thing about the prolactin is its levels are highest about 30 minutes after the beginning of the feed, right? So after the 30 minutes of after the feed only, the prolactin, the highest level of prolactin will be, the mothers will be getting the highest level of prolactin, right? So generally, what's the kind of a duration of the feed? It's something like 20 to 30 minutes, isn't that so? So which means the effect of the prolactin that are secreted during the feed will prepare the mother for the next feed, right? The other important thing about the prolactin is it's mostly secreted in the night. So this is why the night feeds are important for breastfeeding establishment. Remember, only during the period of breastfeeding established, when the baby is sort of older, like 9 months, 10 months, during that period, you should not allow or recommend giving a night feed. So during the initial period, until the breastfeeding is fully established, it is very important the mother to encourage on night feed. Right? Then when it comes to oxytocin, the oxytocin reflex we call the later is the let down reflex, right? So oxytocin secretion from the posterior pituitary too is stimulated by suckling. But this is produced more quickly than the prolactin, right? So it works before or during the feed. So by contracting the myoepithelial cells, it makes the milk that is already stored in the lactiferous sinuses to flow for the current feed. So there are certain factors that stimulate prolactin secretion in addition to suckling. So those are the mother's sensation, the feelings such as touching, smell of the baby and seeing her baby, also hearing the baby's cry, or even thinking lovely about the baby also will stimulate oxytocin. In addition, if the mother is very confident of having successful breastfeeding, the good thoughts also will stimulate oxytocin, right? So all these factors will stimulate oxytocin, thereby eject the milk. So if a mother is in severe pain, or if she is emotionally upset or stressed or whatever stressed, or if she has any kind of a doubts on successful breastfeeding, the oxytocin reflex may be inhibited and her milk flow can become less. So it is very important to understand the oxytocin reflex, and it also explains why the mother and the baby should be kept together, skin to skin contact. So most of the problems the mothers are encountering are due to the problems with the oxytocin reflex. The milk production is also controlled by a substance called FIL, feedback inhibitor of lactation. So which is a kind of a polypeptide present in milk, and that will inhibit secretion of breast milk the production, right? So you may have heard some of the time the mothers are complaining that they have less milk or no milk in one breast, right? Especially if the baby suckles only from one side. So it is due to this FIL. So if the milk is not removed from the breast, the inhibitor collects and it will stop the cells from secreting any milk. This is actually a protective mechanism to protect the breast from being too full. So if this milk is removed, then the inhibitor also will be removed and then secretion resumes. So this is why you have to advise mother to express and remove milk regularly. Even though baby cannot suckle, especially even a sick baby who is in NICU, you have to advise the mother to express the milk regularly to get rid of these inhibitors. So in other words, there's a local control of milk production independently within each breast. So let's look at what are the reflexes in the baby that are involved in breastfeeding. Firstly, the routine reflex, which means when something touches the lip, baby would open the mouth and puts the tongue out. Then the suckling reflex means when something touches the baby's palate, he would start to suck it. The third one is a swallowing reflex, means when the mouth is filled with something, maybe milk, baby will swallow it. So those three reflexes are very important for the baby to have a good feed. So you can see everything is determined by the nature. But the skill the mother needs to learn is how to position the baby to have a good attachment to the breast. And then baby will learn to have a good attachment. Baby will attach to the breast in the proper way. So how can we help a mother and baby to establish breastfeeding? So as I told you before, it is very important to start the feed within the first hour after birth. And you have to make sure that they are getting continuous support throughout the hospital stay. And it is important to check on the feeding adequacy before discharging all the mothers. So how can you do it? You can measure the weight before the discharge. If the weight loss is less than 10%, that means the chances of feeding inadequacy is not there, right? So in any baby who is having a more than 10% weight loss, you have to suspect some kind of feeding problem. Therefore, you have to sort of attend to that before discharge. And the other thing is they need support after discharge, which is very important because this is the time most mothers face feeding difficulties. So let's talk about a practical way of supporting the breastfeeding. So early skin-to-skin contact, at least until the first feed is completed, is very important. And this will help to establish a breast crawl. So I'll show you what the breast crawl is. And you have to always advise the mother to wait for the hunger cues. Because if the baby is not hungry, he won't show any interest for a feed. And then mothers will misinterpret this as the baby is refusing her milk. So we should make her really upset, and that can hinder the oxytocin and will hinder the breast milk, but the injection too. Then whenever you see an effort on breastfeeding in a mother, even though it's correct or wrong, you have to always congratulate her and encourage her to continue the good work. So this kind of encouraging words are very important to build up the positive attitude towards the breastfeeding. So this slide shows what the breast crawl is. You can see if the baby is ready for a feed, he or she would first open the eyes, start to look around and move, right? Then baby would open the mouth and search for the feed. So this is the breast crawl. So this is the time that we should help the mother to position the baby and help the baby to attach to the breast. Not the time that we think that this baby should get a feed now, right? And the other thing is you have to always keep keep your mind the importance of colostrum also. So about the timing of breastfeeding, what we have to encourage is feeding on demand. So you have to feed when the baby is hungry and shows the hunger cues. And then continue feeds until he or she is satisfied. So you have to strongly discourage feeding according to the clocks. Some of the mothers are just having the habit of giving a feed like for 20 minutes and wake him in every 2 hours to give the next feed, right? 2-hourly feeds, and every 20 minutes. Some of the mothers actually, they just stop the baby giving feeding, even though he is sort of continuously sucking, because the 20 minutes has gone. So that kind of a practice has to be thoroughly discouraged. Actually, these values we have to give just to give a kind of a rough guide. Otherwise, mothers may not know for how long they have to give a feed. So we just say it is something like 20 minutes will be the duration of the feed, and generally the babies will sleep for about 2 to 3 hours. So once they wake up and then ask for the feed, then give the milk, right? So when you talk about hunger cues, they are coming in 3 stages: early, mild, and late. So early signs are kind of stirring, mouth opening, turning the head sideways. And the mid cues are when they are really hungry, showing the increased physical movement, stretching, putting hands to mouth, things like that. So it is important that the mother should identify these signs. So mild and moderate signs would be the time to start the feed. So in case if this time is passed, then they will be really agitated. They will start to cry, will be blushed, right? So when these late cues appear, it is very important, very hard to give a feed. So you have to calm them down before giving the feed. So mother should be able to identify the mild and moderate hunger cues. The other important thing is you have to encourage mother to spend some time to do the things to stimulate oxytocin production before offering the breast to the baby, like cuddling, taking the baby to the talking to the baby, then giving a skin-to-skin contact. So things with those things, the oxytocin, oxytocin reflex will be stimulated, and more oxytocin will be produced to have the good ejection. Rooming in is very important during the hospital stay as well as at home. That means keep the mother and baby together 24 hours a day to identify the early hunger cues. So baby's cot has to be kept actually by the side of the mother's bed, not at the foot end, as most of our hospitals are having. The kangaroo mother care is probably a best way to keep them together, as this will allow the mother to engage in other household activities as well. So next we will move on to the very important topic, how to position the baby, right? So what are the steps of good positioning? Baby's head and body has to be straight in a straight line. The face has to be opposite the nipple and the breast. The nose has to be opposite the mother's nipple. Remember, it's not the mouth. The nose has to be just opposite the mother's nipple. So baby has to be held close to the mother and the whole body has to be supported, not only the head and the shoulders. Mothers actually can adapt whatever the position convenient for her, maybe sitting, standing, or even sleeping. But it is important to have all these components of the good positioning in the baby. So holding the baby also can be done in different ways. The previous slide showed the cross cradle method, where the mother was holding the baby with the opposite hand. Here, the first picture, it's the cradle method, holding from the same hand. The other one is what you call the underarm method, and babies are sort of kept under the arms. And this underarm position is very particularly useful when feeding a small baby, or if a mother is having flat nipples or large nipples. So you can see the twins are being fed together, keeping them in the underarm position, right? So if the mother is tired or sleepy, she can lie on the bed to give the feed. But the most important thing is to adhere to 5 key points of good positioning. So what are those again? Baby's head and body should be in the straight line. Face has to be opposite the nipple and the breast. Nose has to be opposite the mother's nipple. Baby should be held close to the mother, and baby's whole body should be supported. So what are the key points of good attachment? If there's a good attachment, baby's mouth has to be wide open. So generally we tell things like for the mothers to understand A kata and U kata. A කියනකොට කට ගොඩක් කරලා තියෙනවා. U kata කියන්නේ නිකන් උල් වෙලා තියෙනවා. So U kata is generally with the nipple sucking. It should be the A kata that has to be there in the baby. Then the baby's chin should be touching the breast, and lower lip is curled outwards, and usually the lower portion of the areola should not be visible, and it should be inside the mother's mouth. So this is the reason why you should direct the nipple to the nose, not to the mouth. Then the baby opens the mouth, she can get most of the part from the lower part of the areola. So why it is important to have a good attachment? If you look at this picture, the first set, if you see the baby from outside, and the second pair is visualizing a bit of anatomy. So concentrate on the first picture. It shows the signs of good attachment, right? So you can see the mouth is wide open, chin touches the breast, lower lip is everted, and the lower portion of the areola is not visible. Now look at the comparable picture on the right side. Right? So the third one from the left, right? So you can see all the lactiferous sinuses where milk is stored is within the oral cavity. So with the suckling movements of the baby, the milk will get into baby's mouth, and with the swallowing response, reflex, baby will swallow it. Now look at the second picture, which shows signs of poor attachment, or you call nipple sucking. And compatible picture is the last one. You can see all the sinuses are outside the baby's mouth. So baby will not get enough milk. So this is why proper attachment is very important. So when a baby suckles with the good positioning and attachment, what will you see in the baby and the mother? The baby will take several slow, deep sucks, followed by swallowing, and then baby may be having pauses. Remember, it is not a kind of a continuous sucking throughout the process. So these sucks are very slow and deep. So you have to convey this message to the mothers too, that it's not a continuous sucking, because otherwise what will happen is mothers will misinterpret this as pauses or sleeping and tend to do various things to wake up the baby, which will sometimes irritate the baby as well. And the other thing is, you may be able to hear the sound of the baby swallowing. If the baby is relaxed, after the feed, the baby will be relaxed and happy and satisfied if it is a good feed. And also the mothers also will not feel any kind of a pain, especially nipple pain. So how do we ensure adequacy of breastfeeding? So generally, baby will go to sleep for 2 to 3 hours after each feed, if their tummy is full. And they will pass about 6 to 8 times urine per 24 hours. So remember, but this is only after the 3rd day, right? During the first few days, mothers will not be having a lot of milk. So even 1 to 2 times would be enough. After the 3rd day, there should be a good urine output in the baby. The most reliable factor is the weight measurement. So within the first few days, less than 10% weight loss is ensuring a satisfactory breast milk production, breastfeeding. After that, they should gain about 10 to 15 grams a day after day 5. And generally, they crosses the birth weight by 2 weeks. This is why we should check the weight of the babies in 2 weeks' time. So let me highlight some of the problems that they can encounter. I don't think I can talk much in detail about these problems, but all these problems can be rectified if you counsel the mother and support the mother to ensure correct positioning and good attachment. So just think about breast engorgement and blocked duct, right? So why can they have a breast engorgement? That is because of the infrequent breastfeeding or improper breastfeeding, the improper attachment, right? So all what we have to do is counsel the mother. This is why your problem is happening, and all what we have to do is to give more frequent feeds to the baby with the proper attachment. And also, if the suckling is not really satisfactory, mother has to empty the breast with expression. Right, so all these factors are related to the incorrect positioning, attachment, and the suckling. The other thing is, every mother needs to know how to express milk and how to feed with a cup or a spoon. So this is especially useful if the mother is working, but even otherwise, in the real life, there are instances where mother has to be separated from the baby, maybe for a short period of time. For example, she may have to accompany an older sibling to school, go to the shop, like that. So in such a situation, the caretaker can feed the baby with the express breast milk rather than giving formula milk. So every mother needs how to express milk and also how to give a cup feed. Right? So remember, the feed should be given through a cup or a spoon, not the bottle with the teeth, because the mechanism of suckling the breast is totally different from the sucking the teeth. So the baby can get nipple teeth confusion if they are using the bottle, right? So this slide shows how to express, and giving a cup feed and giving a spoon feed, right? No bottles. The other thing is, which is helpful for the working mother, how to store express breast milk. You can see in the room temperature, breast milk can be stored or kept in the room temperature for 4 hours. But in the refrigerator, in normal compartment, 4 degrees centigrade up to 3 days. And in the deep freezer, even up to 6 months, breast milk can be stored. So when you are giving milk to the baby, yeah, it has to be taken into the room temperature by keeping the bottle inside the container filled with hot water. Yeah, but remember, once it is thawed, you should not refreeze again. So, the other thing is you should know how the mothers can get help when they are having feeding problems, especially after they have been discharged, right? You know, most of the hospitals, they are having the lactation management centers, and they have a hotline. In some of the hospitals, they have a hotline as well, and there are dedicated lactation nurses available in the community, and the person is a public health midwife, right? So whenever a person is having a problem, if you are not in a position to give the correct feeding, the counseling, you should remember to direct them to one of these resources. So, in summary, as medical professionals, we have an important role in helping mothers to establish good breastfeeding practices. The country policy is to exclusively breastfeed for first 6 months and continue breastfeeding together with complementary feeds up to 2 years or beyond. We can achieve this target with proper counseling, starting from the antenatal period, then early initiation of breastfeeding within 1 hour after birth, and by providing continuous support throughout the period of breastfeeding, addressing their concerns and timely management of any complications. And the other thing is correct positioning and attachment and feeding on demand are the keys to the success. So the take-home message is, using the knowledge you gain, try as much as possible to help breastfeeding mothers whenever you encounter problem, the feeding related problems, rather than just simply starting on formula milk. Thank you.
Thank you, madam, for that detailed comprehensive lecture. So if you all have any questions, you can unmute and ask, or you can type in the chat box. Okay, so if you all have no questions, we can go to the next lecture. Next up is another interesting lecture by on preterm and low birth weight management, hypoglycemia management by Dr. Priyanka Dematavava, consultant neonatologist at Teaching Hospital, Preterm. Over to you, madam. You can start, madam.
Yes, I will. Can you see the slides?
Uh,
So I'm trying to share the
okay,
presentation.
we can't see it. You're not sharing, madam, yet. Okay, now it's coming. Need to make it full screen, that's all.
For sure. Okay. Good morning. For the next 45 to 30 minutes, so we are going to discuss about the preterm and low birth weight neonates, mainly the practical aspect in the early neonatal period. So if we like, we are just going to see who is a preterm and a low birth weight, and just briefly touch the causes for the prematurity and low birth weight. And we have to concentrate the problems of preterm and low birth weight babies and understanding the early problem, because that will decide the morbidity and mortality. So we are going to discuss about hypothermia, hypoglycemia, and feeding problems. Now, low birth weight baby is a baby who is born at less than 2,500 grams, irrespective of the gestational age. And a preterm is a baby born below 37 weeks. Now, why you should know about this? One thing, it's common, and there's a higher morbidity and mortality among this category. And the nicer thing is appropriate care with adequate attention improve the survival and the long-term outcome. Now, we have taken less than 2.5 kilos as a low birth weight baby, and we subcategorize it to very low birth weight, that is 1,000 to 1,005, and less than 1 kilo, that is less than 1,000 grams, the extreme low birth weight. A baby who's born with low birth weight can be either preterm baby, born a little early, or a small for gestational age baby. Intrauterine growth retardation baby can come out as small for gestational age. So there may be two. And we know the preterm babies are less than 37 weeks. But if you consider, can anyone tell what is the lowest gestation that we resuscitate in our setup? It's the 23 and above. Now, 23 weeker and 36 weeker, both preterm, but they don't behave the same way. The problems are same, but when it comes to the severity, lower the maturity, higher the risk. So we subclassify these preterm babies to late preterm, moderate, very preterm, and extreme preterm babies. Now there may be some maternal causes, fetal causes, and placental causes for the prematurity and the low birth weight. Now, whatever the cause, you are going to go and accept a baby born either prematurely or low birth weight. Now, as the attending doctor, probably most of you have to cover the neonatal units with the pediatrics, especially the peripheral hospitals. So you may be the one who's attending these deliveries. Now, identification of a preterm baby is very important, especially the periviable period, that is around 20 to 25, and sometimes they might say this baby is 35 weeks to see, doesn't look like 35, or they say it's a preterm to see this baba is term baby. So it is the responsibility of the attending doctor to assess the clinical maturity and document. Now, for that, we normally use the new Ballard score, which is very cumbersome, the neurological assessment. The easy way is to go with the physical features of prematurity. If you can remember your student life, where you have learned how to identify the prematurity by physical signs, we can use the breast nodule where there is no growth of the breast nodule and the mature with the pigmentation. And the genitalia, the male without much rugae and much pigmentation, and the normal when it comes to term. And the preterm female, where the labia minora is more prominent compared to the majora. And when it becomes term, yes, the majora is prominent and covering the minora. And you can go with the skin creases, especially the crease, the scroll creases, and the ear recoil. With that, you can decide. It's a rough assessment, and which is a subjective one, but you can have a rough assessment of the clinical maturity. So start applying these physical features from the beginning. Now, what are the problems of prematurity? They have late problems, they have early problems, late problems, and intermediate problems. So what are the common early problems? This is common to both low birth weight and preterm babies, the hypothermia, hypoglycemia, and feeding problems. Apart from that, they can have respiratory distress. They're both prone to infections and apnea. Apnea is their respiratory center is immature, so they might not have the regular respiration. Later, they can develop jaundice, intraventricular hemorrhages, cardiac problems like patent ductus arteriosus, and though a little less, but significant problem is the necrotizing enterocolitis, which goes after which can occur early, but it's much common after the second, third weeks. So I told these three problems common for both preterm and low birth babies, and it's quite significant because it can affect the survival and the long-term outcome of the baby as well. Now, what is hypothermia? In any baby, temperature less than 36.5, we take them as hypoglycemia. So you should know what is the normal temperature. It is 36.5 to 37.5 is the easiest to remember. So it's anything below 36.5, you take it as hypothermia. And depending on the severity, you can have mild hypothermia, moderate, and severe. Why do they prone or more common to develop hypothermia? One thing is neonates have larger body surface area and they lack subcutaneous tissue and they have less brown fat as well. One thing you have to remember is hypothermia per se can kill the baby. So it's very important to maintain the normothermia. And the other thing is hypothermia can aggravate your respiratory distress, your tendency to hypoglycemia, the prone to infection. So it's very important to maintain the normothermia. Now, how do they lose their heat? They can lose by all means, either radiation to the nearest equipment, the convection, conduction, and evaporation. So what are the things you can implement at the time of delivery to prevent hypothermia? We all the time try to keep the delivery room warm by switching off the fans, adjust the AC for a desirable level, roughly 24 to 26, and close the windows, keep the baby under a radiant warmer. So those are the measures that you can take. And especially in a term baby, we try to wipe them thoroughly soon after birth. But we are not going to do the same for a preterm baby, especially less than 30 weeks, less than 1 kilo. You deliver the baby directly to a plastic bag. So we don't have sterile bags. We normally use either clean bags. It may be just a grocery bag, or sometimes some do take the polythene cover of the mother's catheter. But make sure your bag is very clean. So there you keep the baby without wiping directly in the bag. But this baby should be kept under the radiant warmer without covering. So our target is to have a nice micro humidified environment around the baby, which could further prevent the heat loss. So how long you are going to keep this baby in the bag is you have to maintain the temperature throughout. Once you take the baby to a unit, and in the unit baby is becoming the normal temperature, you are going to remove the bag. What are the equipment that you use in the unit to keep the baby normothermic? So you can use an incubator for a preterm baby or a radiant warmer for a term baby. When they become bigger, the preterm, you move the baby from the incubator to the radiant warmer somewhere around 33 weeks. And when they become bigger, you can keep them in a cot with nicely swaddled. Any baby can keep with skin-to-skin contact with the mother. The skin-to-skin contact, what you call the kangaroo mother care, it's not only for the thermoregulation, it really helpful for the regulation of the respiration and the heart rate in a preterm way. So you can use the same methods even at home. Having said that, sometimes mothers do keep baby wrapped even in the warm environment, plus when they become bigger as well. So when to really remove this multiple layers beyond the neonatal period, you can advise them. You don't have to swaddle all these babies the same way, even at their second or third month. So how are you going to manage hypothermia? Yes, it's a warm room, adequate cover, kangaroo mother care, the skin to skin contact, and in the unit you can use the radiant warmers and the incubators. If it is severe hypothermia, you manage accordingly in a unit. A second problem is the feeding. Why do you have feeding? One is they are immature to suck and swallow from the mother, and they have the immature gut motility, and there's an entity called ideas of premature. The motility is less, and you have to decide the initiation of feeding by two methods. You have to consider two aspects. One is the feeding ability of the baby and the clinical condition of the baby, whether this baby is clinically stable or not. So what you can do? Now, deciding the initial feeding method, you are going to see whether this child is stable or not. How are you going to recognize an unstable baby? If baby is tachypneic, with severe respiratory distress, with multiple episodes of apnea, high oxygen requirement, convulsing baby, hypo or hyperthermic baby, and abnormal consciousness, significant abdominal distension, now you have to consider. Okay, for this kind of baby, better to start with the intravenous fluid. Then, how are you going to decide the initial feeding method? With the ability. Now, if it is a baby more than 34 weeks, they have mature sucking and swallowing reflex. So you can try breastfeeding. So this is the maturity. If this baby is otherwise healthy, there you can keep the baby with the mother in the postnatal ward. The others, okay. Depending on the baby. So first you have to exclude all the possible unstable signs. After that, you are going to decide the feeding method. 32 to 34, probably they might not be able to suck, but they can have oral feed. The express breast milk. For the other babies, 28 to 31, probably you have to go for the tube feeding to start with. Extreme preterm, we have to start them on parenteral nutrition or the intravenous fluid, and you gradually build up the feeds in this group of baby. We start. One important thing is for all the babies, we try to start breast milk as soon as possible if they are otherwise healthy. But how to give it is the one we are going to decide depending on the maturation. Now, the best is to go for the mother's milk. And if mother doesn't produce enough, you can look for the donor breast milk. For the time being, we don't have the established milk banks in Sri Lanka, and you can decide on IV fluid and parenteral nutrition. As I said, the maternal milk is the first and foremost, but for extreme preterm baby, you can gradually establish the feeding. Now, how are you going to decide what to do is the same in a flow chart, it depending on whether baby is clinically stable or not. Yes, baby is not stable, probably you have to go with the sick baby management pathway. Now, baby's weight is very important. It's a low birth weight, tiny baby, probably you have to start with the intravenous fluid and gradually build up the feed. And healthy baby, more than 34, you are going to go for the breastfeeding. Healthy, but sucking and swallowing not developed, you can go for the oral feed via a cup or a spoon. The same where you gradually come down in the IV fluid and start increasing the oral feed. I think it's clear. But what you have to decide is whether your baby is stable enough to start with the oral feed. Then please encourage the mother to express milk as soon as possible. Now, even you can try, especially for the extreme preterm babies, even before delivery, you can express from the mother. Sometimes it's available, and to keep and give after birth if baby is otherwise healthy. And one important metabolic problem is hypoglycemia. This is the most common metabolic disorder, and it has long-term detrimental effects as well, and it's easy to manage. What you have to do is you have to anticipate and prevent and go for the early treatment when it's needed. Now, for the definition of hypoglycemia, we don't have a clear-cut definition. We go with the optional threshold. We take the threshold as 45 milligrams per deciliter, that is 2.6 millimoles per liter for a neonate. And you have to keep in mind three values. One is the 45 milligrams per deciliter, the other one is the 36, and the other one is the 18, that is 2.6, 2 and 1.1 millimole per liter. So how are you going to do it? Now, as we said, we know the risk factors, the preterm and low birth weight. But other than that, in the postnatal ward, you might encounter babies born to diabetic mothers, where they have the transient hyperinsulinemia and prone to hypoglycemia, and mothers who have been on treatment for the pregnancy-induced hypertension on beta blockers, where they have the tendency to develop hypoglycemia, and any sick neonate. So all these babies should be kept under the hypoglycemia prevention pathway. So what you do, you feed the baby as soon as possible, and you check the blood sugar before the next feed. What they say is that within 3 to 4 hours, that is pre-feed, before feeding. And if that, you are going to regularly monitor if it is normal. So the guideline is given in the Family Health Bureau. So you can follow it as well. And now there are two categories. One is a baby you recheck, where the baby has low blood sugar but clinically not symptomatic. That is asymptomatic hypoglycemia. Or you can have a baby less than 45, any value, with the clinical features of hypoglycemia. It is very easy to remember all the time. Tell all the features that you feel in this time, where you have the, what are the features you have? Sleepy, lethargy, poor feeding. Okay. Apart from that, you can have neurological manifestations, the jitteriness, irritability, and some secondary effects on the heart, the tachycardia. All these features can be a sign of hypoglycemia. Now, how I know? Its prevention is better all the time. So how are you going to prevent? You have to commence feeds early, preferably within first 30 minutes to 1 hour after birth. If it's a preterm baby, stick to the golden hour of the newborn, where you are going to stabilize the baby within first hour. One part is to commence IV fluid within that period. And try to give the skin to skin or somehow to maintain the normothermia, which will prevent or reduce the incidence of hypoglycemia. Now, how are you going to manage without clinical features? If it is more than 45, yes, you are going to continue to monitor. It is less than 45, but more than 36, that is within 2 to 2.6, you can support feeding and you can recheck. If your second value is also marginally low, you have to start the baby on additional sugar supplement. If it is in between 1 to 2, that is 18 to 36 milligrams per deciliter, then again for them you are going to start IV fluid. Here you recheck little early. There, if it is above in 36 and 45, you can wait for the second pre-feed as normal. But for the 18 to 36, you are going to check the second blood sugar value early. Any baby less than 1 millimole or any baby with clinical features of hypoglycemia, you have to give the dextrose bolus. That is 2 to 3 ml per kg over 1 minute. And your bolus all the time should follow by an infusion of 10% dextrose. Otherwise, they can develop rebound hypoglycemia. And you have to repeat your sugar in 30 minutes and see whether you are in the right direction. This is something, intern who's going to go to the antenatal ward. Make sure you try your best to minimize the complications of prematurity by giving antenatal steroids timely and the magnesium sulfate for the neuroprotection. So you can discuss with your seniors and apply the measures to prevent complications of prematurity. This is something should happen in the antenatal ward. And one important I want to tell you, out of all these chronic problems, the osteopenia of prematurity. Because clinical features manifestation will take time. We have to catch in the asymptomatic phase. That is when you have the biochemical derangement. So you are going to check the second week and decide. So you are going to do on the second week of life the bone profile, where you're going to do the serum phosphate, calcium and alkaline phosphatase and decide to start on supplements. So it's your duty as the pediatric house officer who take care of these newborns to send the blood or to remind to send the blood for these babies. And the follow-up of preterm babies. We get them down in the clinic, especially to assess the development and the growth, and to see whether we have done the screening. One important thing, the practical point here is, for the growth and development, you go with the corrected gestational age rather than the actual age of the baby. And your vaccination you take with the actual age of the baby. So your growth and development assessment and the plotting of the growth should be done in the relevant preterm chart. So the same for the small for gestational age babies. They are, so you can see they look mature but emaciated, but you call the old man appearance with the loss of subcutaneous tissue with loose skin folds. One important thing at the time of delivery is to decide whether this is an asymmetrical or symmetrical IUGR baby. Symmetrical means probably from the early till it can be constitutional, but you have to exclude the possible secondary causes for the IUGR in a symmetrical IUGR baby. Asymmetrical, the late onset, probably with the placental insufficiency. So you have a normal head growth with the compared to the body size, and they catch up very easily. Now, if you are called to delivery room to attend a small for gestational age baby's delivery, what are the problems you are going to anticipate? Especially now they are with the chronic hypoxia, so they can have acute on chronic, so that their withstanding ability may be less. So you might encounter hypoxia and ischemia. Sorry for the wording, the birth asphyxia. It's hypoxia and ischemia at the time of delivery, and they might pass meconium with the distress. And we have already discussed about the hypothermia and hypoglycemia. And because of the low oxygen intrauterine, they born with polycythemia. So later they can develop jaundice. So you have to keep an eye on them and the infection. So in summary, the prematurity and low birth weight causes increased morbidity and mortality, and timely intervention, especially for the hypothermia, hypoglycemia, and the early commencement of feeding improves the outcome. Thank you. Do you have any questions? If not, I can log off. So I'm going to hand over the control back to the moderator. Yes.
Thank you, madam, for that comprehensive lecture. So anyone having questions can take the opportunity to ask questions on the chat box or by unmuting.
Yep.
Right. If you all have no questions, we go to the next lecture by Dr. Taranga Jayatunga, consultant neurologist at TH Jaffna on respiratory distress. Over to you, madam.
Good morning. So we are going to discuss about the respiratory distress in the newborn. I'm Dr. Taranga Jayatunga, a neonatologist from TH Jaffna. Can you all hear me? Moderator, please respond. Can you all hear me?
Yes, sir.
Right, thank you. And can you see my slides?
Yes, I can see, but
Yeah,
your voice is a little bit faintish. Can we increase the volume from your side?
yeah, I'll do that. Thank you. Can you hear me now?
Yes,
Is it clear now?
now clear. Yeah. Over to you.
Okay. All right, thank you. Right. So my slides are moving, right?
Yes.
Right, thank you. So respiratory distress in the newborn. So I'm going to discuss about this topic, and the overview of this presentation will be to identify the respiratory distress, what are the clinical features, the history points, and the examination, and the principles of management, and followed by, I will discuss some case scenarios. So first of all, why this respiratory distress in newborn is important? Because it's an important topic in neonatology, because that is one of the main reasons for a neonate to admit to an ICU. So the incidence-wise, term babies, they develop to respiratory distress in around 2.3%, and 1/5 of preterms, they developed respiratory distress. Delaying things can cause detrimental things. So that's why it's very important to identify this respiratory distress early without any delay, and start in the appropriate management. So what are the signs and symptoms? So how can we identify them? Because you all are going to be you are going to start your internship very soon, and some of you might have a chance to do the PBU appointment, or you might be a pediatric house officer. So you might be the first contact person for that. And then it is very important to identify a sick baby, a baby with the respiratory distress. So what are the signs and symptoms? Respiratory tachypnea, we say, and for a newborn, we call tachypnea when the respiratory rate is more than 60 beats per minute. And they may develop severe chest inroving and recessions, and the recessions can be subcostal, intercostal, and substernal, and grunting. So grunting is a sound produced by the newborn that is expiratory sound, expiration against the partially closed glottis, and which may help the baby to provide auto peak in expiratory pressure, that is to alveoli collapse in the newborn. And nasal flaring, that is dilatation of the nares. Apnea or gasping. Apnea in newborn is cessation of breathing for 20 seconds or desaturation and associated with bradycardia. They may have features of cyanosis, or their oxygen saturation might be low. So this video will provide you some features of respiratory distress. Can you appreciate? So there are, you can see subcostal recession and mild degree of the nasal flaring, and here the tracheal tug, and baby's obviously tachypnic. It's more than 60 beats per minute. I will play it again. Right, so baby is working hard, head bobbing also there, and subcostal recession, mild degree of intercostal as well, and nasal flaring, tracheal tug, you can see. Right. So what are the common causes of respiratory distress? So not only identification, it is important to differentiate from pathological conditions. So the respiratory distress, it's not only from pulmonary system or the respiratory system. There are other systems also. They may have the baby may present with features of respiratory distress. So what are the pulmonary causes or the respiratory system causes? Transient tachypnea of the newborn. So the name applies, the transient, it is condition which is transient. So tachypnea of the newborn. So I will discuss one case from this. Respiratory distress syndrome, which is specifically in newborns, preterm babies. And that is the hyaline membrane disease or surfactant deficient lung disease. Pneumonia, it can be congenital pneumonia or acquired, community acquired pneumonia. Meconium aspiration syndrome and air leak syndrome. What are air leak syndromes? That is pneumothorax, pneumomediastinum, etc., and pulmonary hemorrhage. So what are the other symptoms where the baby will present with, when the other symptoms are involved, the baby will present with respiratory distress. So you have to suspect that. So there can be metabolic derangement, especially hypothermia, which is a killer in newborn. Probably the previous speaker has highlighted the importance of hypothermia or the prevention of hypothermia in newborns, and the hyperthermia as well, and as well as hypoglycemia. So those might have, those babies might present with respiratory distress. And metabolic acidosis, obviously, as a compensatory mechanism for metabolic acidosis, there may be the compensated respiratory alkalosis, then baby will breathe fast. Anemia, polycythemia as a compensatory mechanism. So they may have features of respiratory distress. There can be cardiac causes like cyanotic or acyanotic heart disease as well, especially duct-dependent circulation and features of heart failure. They may present with respiratory distress. And persistent hypertension of the newborn, that is we call PPHN. So you know that during the neonate, the intrauterine life, right ventricular dominant circulation is there, which will be a change over to a left ventricular dominant. So we call that neonatal transition at birth. So some babies might take little longer because of persistent hypertension of the newborn, right ventricular hyper, and other pathological causes also there for that. And neurological causes, obviously, HIE, hypoxic ischemic encephalopathy, or even meningitis, they may initially present with respiratory distress. So what are the anatomic abnormalities which may, where the baby might have respiratory distress? So upper airway obstruction, obviously. And airway malformation, tracheoesophageal fistulas, and cystic adenomatoid malformation, congenital lobar emphysema, diaphragmatic hernia, diaphragmatic paralysis. So those will have that. Those are the conditions will have features of respiratory distress in the newborn. Right. So what is the approach as you are the pediatric house officer? How should we approach when you, so now you know what are the clinical features and you know how to identify them, and you know a little bit about the differential diagnosis as well. So once you have identified the patient, so what I'm going to do, because the very first slide I said that delaying things can cause detrimental causes the increase that will increase the morbidity and mortality. So we have to detect things very early. So what are the history points? So how are we going to evaluate? So first of all, you need to get a quick history with relevant to the targeted history, which you say, so which relevant to your the future management. So the gestation, very important. So what gestation the baby born? So because if it is preterm, so the differential diagnosis it would be different. And the onset of respiratory disorder, whether soon after birth, sometime after birth, or a few days after birth. So those things will lead, give clues to regarding the. So soon after birth might be transient tachypnea of newborn, so might be congenital anomalies, and so few hours after maybe still transient tachypnea of newborns, surfactant deficient lung disease, and pneumonias. And the late onset after 3 days, it might be hospital-acquired infection. And whether mother received antenatal steroid prophylaxis, we give dexamethasone, especially if the fetus is less than 34 weeks to mature the fetal lungs. So we give dexamethasone whether mother received antenatal steroids, and when was the last dose. And so because sometimes we may give partial cover, so whether it is completed and when was the last dose, and whether there's any risk factors for sepsis. So risk factors, so probably somebody might have discussed about this topic. So the risk factors would be prolonged rupture of membranes and foul smelling amniotic fluid, maternal fever, and the maternal tachycardia unexplained, and UTI during the last trimester, and multiple handling of the mother during the near to the delivery, that is number of vaginal examination, instrumental delivery, etc. And whether the like was stained with meconium, because meconium passed when the baby is under stress, when the meconium pass during the antenatal period, when the baby is under some form of stress. For some form, so when the stress there, so then the meconium, it's a kind of a chemical, so which might so baby might aspirate those meconium stained lico and might cause chemical pneumonitis kind of a picture, and developing meconium aspiration syndrome, perinatal asphyxia, maternal diabetes, and poor feeding, lethargy, convulsions, and excessive frothing in the newborn. So sometimes that may be the only clue to diagnose or to suspect tracheoesophageal fistula. So the examination, again, targeted approach, a quick examination. So severity of the distress, I will discuss this in detail in coming slides. Cardiovascularly capillary filling time, skin colors, blood pressure, and the neurological status of the baby, axillary temperature, very important. And the baby might be very lethargic and less active and no response to stimulus. So then the baby might be very sick. So you need to do things very quickly. And any dysmorphism as well. Sometimes a dysmorphic baby, a Down syndrome, trisomy 18 Edwards syndrome, or Tau syndrome, or any other dysmorphism. So that might give a clue to this respiratory distress. And how to assess the severity of the respiratory distress. I said in this slide, so assess the severity of the distress. There are many calculators or scoring systems, and this is one of the useful assessment criteria, Down score, which is in the neonatal guidelines as well as Sri Lankan guidelines. So where there you are assessing 5 component: respiratory rate, cyanosis, air entry, and grunt, retractions, and then you will give clues as 1, 0, 1, 2. So depending on the accumulated value, calculated value, you will score them, whether it is mild, moderate, or severe, or impending respiratory failure. So if it is 0 to 3, score is 0 to 3, mild respiratory distress, 4 to 6, moderate, more than 7, so then that means severe. Then you have to do some things to secure the airway, most probably the invasive ventilation. So what are the investigations you are going to do in here? Now you have identified a baby with respiratory distress. You have clues for the etiology, and you took a detailed or targeted history and you did an examination. Now you are there, right? So what investigations you are going to do? So first of all, you are going to stabilize the airway. And before that, you may airway, and as well as you may insert a cannula. So with the first cannula, so you may take blood culture under steroid precautions, and subsequent bloods will be taken for full blood count. In the full blood count, you will see whether there are any features of white blood cell count, leukocytosis with neutrophil leukocytosis, and leukopenia with neutropenia, and the hemoglobin level, and as well as platelets. Sometimes that there may be associated thrombocytopenia in severe sepsis, and CRP, that is C-reactive protein, which is an inflammatory marker. And if it is a ROS, and then that might give a clue that acute inflammation is going on, so might be sepsis. And blood culture, as I said earlier, and it'll take 24 to 48 hours to get the report. And blood gas, so which is very important. If significant respiratory distress is there, you should do a blood gas from the first sample, and which will give an idea regarding the acid-base status of the body. So they may have respiratory acidosis or mixed acidosis or isolated metabolic acidosis with compensation. And the chest X-ray, which will give a good idea regarding the baby's condition. So you may diagnose the condition as well. Ideally, the chest X-ray we do after 4 hours of birth, provided baby is stable and not deteriorating. And but if you have any concerns, a deteriorating baby, or you are clueless and you need the diagnosis very soon, then and there you need to do the chest X-ray. Why we delay the X-ray? Because sometimes it might be transient tachypnea of the newborn. So there we give the chance to the baby to aerate the lungs. Then the obvious pathology might be very prominent. So management, how are I going to manage? There can be a specific management and the supportive management. In specific management, you will manage the baby's airway first, airway and breathing. You are going to secure the airway. And so for that, you can get the help from the down score. If it is mild breathing difficulty, like down score 1 to 3, and if the saturation is less than 95, you may observe the baby, right? So if less than 95, you may administer oxygen and see whether saturation is improving, and you will continue the oxygen for a while. But if the saturation is not picking up, if it is not going beyond 95, especially a term baby, and within 4 hours, then that baby need an admission and further evaluation, and need to start the management quickly as possible. But you are not waiting for a preterm baby with mild respiratory. Preterm baby is less than 37 weeks. So it's always better to start the respiratory support, even if it is mild and oxygen requirements there. So you may start some pressure support. That might be the early presentation of surfactant deficient lung disease as well. So in term babies, you can give some oxygen and do the management. And as we discussed earlier, so we do the investigation and antibiotics, and you may consider continuing feeding while on oxygen or while observation. So we may offer the breast to the baby for breast initiating or breastfeeding, or you may get express breast milk from the mother, and you can provide it to the baby. So if the distress is moderate to severe, down score 4 to 10. So you need to start, then you need to check the saturation. Obviously, you need to give some oxygen, then followed by, you may have to start non-invasive respiratory support. So non-invasive means without ET tube, endotracheal tube. Invasive ventilation is when you insert an endotracheal tube, we call that invasive ventilation. So there are various ways of providing non-invasive ventilatory support. Heated, humidified, high flow nasal cannula. You will see those things when you are starting your career. and the CPAP machine, so continuous positive airway pressure machine. So via that, so baby is breathing, but we are supporting each breath with this heated, humidified high flow nasal cannula or the CPAP to provide a peak end expiratory pressure to prevent the lung collapse or the alveoli collapse. So that will ease the breathing for the baby. And obviously, if the score is more than 7, and then you can't wait, so you need to intubate and start the invasive ventilation. Depending on the circumstances and the history and the examination finding. So if the baby is preterm and depending on the oxygen requirement following non-invasive ventilation, you may have to administer surfactant for the baby, especially if they are preterm. And as well as term babies, we may consider surfactant in meconium, severe meconium aspiration syndrome, and as well as babies born to diabetic mother. Sometimes even term babies born to diabetic mother, they may present with features of surfactant deficiency. And then you need to monitor the vitals of the baby. So there are respiratory the monitoring charts in the NICU. So this is kind of an acute situation, and so high dependency unit or neonatal ICU setup. So specific charts are there with regard to this, all the system monitoring and the vital monitoring. So specifically the respiratory vitals would be saturation, respiratory rate, degree of respiratory distress, and what form of invasive ventilatory support, whether it is invasive or non-invasive or just the oxygen, and blood gas values, and all the ventilator parameters, and the cardiovascular wise heart rate, capillary filling time, and the blood pressure. So usually we measure non-invasive blood pressure, but if the baby is very sick, we may have to go for invasive blood pressure monitoring. That is, you are putting a cannula, or you may use umbilical arterial catheter. Then you via the monitor, there are a special gadget for that, arterial blood pressure monitoring. Then you may do arterial blood gas arterial the invasive blood pressure monitoring. And then the central nervous system wise, you need to monitor the activity of the baby, anterior fontanel status of the anterior fontanel, and the neonatal reflexes, tone, and etc. And the abdomen wise, again, the features of abdominal distension, bowel sounds, and the any other obvious pathologies, whether baby is tolerating feeds, what sort of feeding we are giving, and how much we are giving, etc. And sometimes you may insert an NG tube and decompress the abdomen, but you are not practicing this routinely. If you have given a feed and baby is having significant respiratory distress, and if you suspect that this might cause issues if it is aspirated, you may decompress the abdomen. And you need to start the antibiotics, the specific antibiotics you need to start. So initially we start prophylactic, not the prophylactics or tentative antibiotics initially. So we suspect earlier, if it is depending on the clinical scenario, if it is early onset means less than 72 hours, late onset means more than 72 hours, because for those early onset sepsis and the late onset, the organisms are different. So you have to cover those organisms, and so you suspect presumed sepsis and you start antibiotics depending on your suspicious. So you should give a gram positive and gram negative cover. And for the gram positives, the first line would be C penicillin, and then followed by the gram negative cover, you will start gentamicin for early onset sepsis. And the late onset sepsis, depending on the clinical circumstances, you may start flucloxacillin, because we need to cover Staph aureus here. And with gentamicin, the negative cover, you may start cefotaxime as well. And if you are suspecting meningitis, then you may start with third generation cephalosporin like cefotaxime. And then you may change your antibiotics depending on the culture sensitivity, and as well as if the baby is not responding to your treatment. So you may do serial CRPs, we would say. So you do another CRP in 12. If the first CRP is negative, you may do another CRP within 12 to 24 hours. We call a serial CRP. So then if it is CRP is rising, even the first CRP is negative, the CRP second CRP is rising, you may consider continue antibiotics, and you will chase the blood culture. Depending on that, you may change the antibiotic combination. And for the feeding, so similarly, depending on the distress and the severity, you may have to keep the baby nil by mouth for a while. And if the baby is improving afterwards, you may consider starting NG feeds or the orogastric feeds, where you can administer express breast milk from the mother. And once the baby is improving and stabilized, even while on high flow nasal cannula or the CPAP, you may consider offer the breast to the baby as well. So other normal supportive management, so I already discussed, so it's very important to maintain the normothermia of the baby. So the normal temperature in newborn is 36.5 to 37.5. And you may use incubators for a preterm baby or warmers, infant warmers, to maintain the normothermia of the newborn if they are having features of hypothermia. And as I said earlier, vitals can be monitored. So target saturation would be more than 90 or 91 for a preterm baby. And for a term baby, you should target at least 95%, more than 95. And the fluids. So basically, if baby is stable, you may consider feeds, as I said earlier, but sometimes very sick babies, you may have to start IV fluids. So the first fluid you need to start is in day one is 10% dextrose, because that 10% dextrose is enough for the initial days, and we are not adding electrolytes for that drip, because still the renal are immature. When we consider adding electrolytes after day 2 to day 3, when the baby is getting, when the baby is losing weight, and as well as when the baby is having diuresis or the passing urine. And you may have to start cardiac support with inotropic drugs. So those are supportive measures. So we will discuss some cases. And so this is a 3.2 kilogram female infant born via elective cesarean section at 38 weeks. And baby had APGAS of 999. And baby developed tachypnea and subcostal retraction with nasal flaring at 1 hour of life. And rest of the physical examination normal. And this is the chest X-ray of the baby. Any ideas? Any ideas? Well, what could be the diagnosis considering the background history and the chest X-ray features? You can unmute yourself, or you can put it to the chat box. Anything? Any ideas? No ideas? Given the background history. So it's following elective cesarean section for a 38, and at 1 hour life, baby developed respiratory distress. So this is an X-ray of looks like hyperinflated lungs, where you can see anterior ribs about more than 8, right? So then we call anterior hyperinflated, where the right diaphragm also a little bit downward as well, and streaky appearance of the lung fields. And so this is actually kind of diagnosis of exclusion, where babies are not requiring much respiratory support. They will spontaneously improve, or else with mild degree of respiratory support, they will improve with time. So quick improvement. So then you can label them as transient tachypnea of newborn. So this patient with transient tachypnea of the newborn. Classic history is born via elective cesarean section, and they develop respiratory distress at 1 hour of age. Case 2. So again, 2.9 kilogram male infant born via vaginal delivery at 39 weeks. Mother had rupture of membranes for 22 hours, and APGAS scores were 899. And baby required oxygen of 40% of oxygen in the delivery room. And he had features of respiratory distress with tachypnea and acrocyanosis, co-scripts and noted bilaterally as well. So, and baby subsequently needed intubation, invasive ventilation, because the down score was very high, and because of progressive increased work of breathing. So following that, they have done the chest X-ray. This is the chest X-ray. Any doubt? Any Any guesses considering the background history? You can type in your chat box or you can speak by yourself. You can unmute yourself. Right. So this is again, consider the history. So risk of, if the membranes are ruptured more than 18 hours, then you need to suspect neonatal sepsis or the congenital pneumonia. Yeah, good, congenital pneumonia. And here this X-ray is again reticular pattern and ground glass appearance as well. Sometimes it's mistaken for the surfactant deficient lung disease also, and the inflammatory shadow is also there. But you have to think of the background history to come to a diagnosis. You need to start antibiotics and the respiratory support very soon, otherwise consequences are very detrimental. And so this is a patient with congenital pneumonia. So third case, again, a preterm baby delivered at 33 weeks with 1.5 kilograms and had ABGAS of 7, 8, 9. And baby required a CPAP immediately after delivery for the stabilization, and then noted to have subcostal retraction, grunting, and nasal flaring. And the auscultation revealed decreased air entry in the lung fields throughout, and baby required oxygen of 40%. So this is the X-ray again. So what do you think? A preterm baby and having significant respiratory distress. So yeah, so any guesses here? So this is kind of ground glass appearance, right? So X-ray, and yeah, you can see clearly the AR bronchograms, right? And the reticular pattern, right? So this is the typical X-ray of surfactant deficient lung disease or the highly membrane lung disease. So then you need to, yeah, surfactant deficient lung disease, right? You need to start the respiratory support followed by the other supportive management. And you may have to give surfactant for this baby as well. So respiratory distress syndrome. So the case for 4.4 kilogram female infant delivered by a cesarean section at 41 weeks, and this baby born through meconium stain LICO, and baby was cyanotic at birth. Central cyanosis were noted, but minimal distress, and ABGAS were 2, 7, 8, so needed some resuscitation according to this ABGAS score. And however, the baby had marked increased work of breathing with nasal flaring, subcostal and suprasternal retraction, and a barrel-shaped chest, and coarse bronchi and bilateral lung fields were noted. So this is the X-ray of that lung. So any guesses for this one? Any guesses for this X-ray? So this is a, yeah, good, meconium aspiration syndrome. So the history also suggestive, and it's barrel-shaped chest clinically. AP diameter is increased, and there's hyperinflation of lungs. And you know that there are 4 mechanisms, 4 pathological mechanisms there in the meconium aspiration. That is here the meconium act like a ball valve mechanism, and so hyperinflation can happen. Diaphragm, right side diaphragm is flat, and the more than 8 ribs visualized, and as well as meconium you can see in the X-ray as well. So this is very severe. So you need to start the management immediately. Otherwise, baby will deteriorate quickly. So you may administer surfactant also for this baby, depending on if it is severe meconium aspiration, and you may consider starting nitric oxide if the associated complication of PPHN, persistent pulmonary hypertension newborn, is developed. And if it is not responding to oxygen, then you may start a nitric oxide, which is a treatment modality available in Sri Lanka now. And the other, so yeah, this is X-ray with meconium aspiration. I think probably the last case this is, no, these are some X-rays I want to show you. So here you can see a patient with a right-sided pneumothorax with mediastinal shift, where the lung is collapsed, and you may see, and the lung, the pneumatic lung right? So the pleural space, the air in the pleural space. So you need to do the emergency needle aspiration followed by, you may have to insert a intercostal drainage for that baby. So the middle picture shows, and the middle and the same patient, the lateral. So the features of pneumomediastinum is there, and where the lung collapse and the surrounding the heart also there, you can see, appreciate the air, pneumomediastinum. And the left hand side, you can see a baby with diaphragmatic hernia, where you can appreciate the diaphragmatic border in the left side, where the gastric bubble also towards the left side, and all the small bubble loops are in the thoracic cavity, and associated mediastinal shift to the right side, and lung hypoplasia. So this baby should be immediately intubated without providing CPAP for the normal newborn resuscitation. This is one instance where straightway you need to intubate. If you are clinically suspecting, it's difficult sometimes, but if it is antenatally diagnosed, if features of respiratory distress is there, you need to immediately intubate the baby. And this is a baby in the right hand side picture, baby with tracheoesophageal fistula. Can you see? So here the NG is coiling. So unable to pass the NG through the esophagus. However, there's a gastric air bubble. So that's why esophagus end is there, but again, the fistula is there connected to the respiratory system. That's why the gastric bubble is there. These babies will present with respiratory distress sometimes because of the aspiration, or else the frothy mouth, frothy as the phlegm, and the feed is not tolerating as well. So that's it. And any questions you want to discuss? And so these are my references. And in summary, newborn respiratory distress is very important topic. So as I said earlier, so it's very important to early identify and start the management. Otherwise, the consequences will be very detrimental. Right. If you have no questions, I will hand over to the next speaker. Thank you very much. Moderator, can I leave now then? As there's no questions, maybe the other speaker is awaiting now.
Really. Thank you, sir.
Can you all hear me? Good morning. Can you hear me?
Yes, madam.
Yeah, okay. So I am Dr. Kumudini, pediatrician at Isabel Hospital. So I'm going to talk to you all about the kangaroo mother care, right? So it's a humane, evidence-based approach to care for the low birth weight babies. Okay, so what is kangaroo mother care? So it's a care of newborn infant secured skin to the mother. So this is a tool used to give the care for the babies who are low birth weight. That is, birth weight is below 2,500 grams, either low birth weight or preterm babies. And it can also given to term babies as well. Why is it called kangaroo mother care? Because when the kangaroo baby is born, he is born premature. And rest of his life is spent inside the mother's pouch, kangaroo pouch, right? So until he matures. So while he is there, so he gets the enough warmth from the mother's body because he is very close to the mother's skin. Right? And he gets protection because of the pouch, protection for the baby from the predator, right? And also the mother's breast nipple are within this pouch. So he has easy access for breastfeeding. So that is nutrition. So by giving kangaroo care, so we are also going to achieve the warmth, protection and nutrition for the newborn low birth weight or preterm baby. So protection, in our case, we don't have a pouch, we have to create a pouch. So we use a bind, right? And protection, and we keep the mother, baby and mother skin to skin care. So thereby keeping the premature baby or the low birth weight baby warm, right? Because you know, as after the delivery, we recommend to keep the babies on skin to skin care because it will protect the babies getting hypothermia because mother's skin is very warm. Right? And the other hand, the baby is exposed to mother's commensal. While on the mother's skin, baby is exposed to mother's commensal. Because that is not harmful for the newborn baby because baby gets antibodies to mother's commensal from breast milk. Okay, so mature baby is kept skin to skin care with the help of a binder. So if you take the history of kangaroo care, so this practice was first introduced in 1979 in Colombia by two pediatricians because they are at those days, their neonatal mortality was very high, their neonatal units were overcrowded, and the many babies died due to sepsis, right? So then and lack of facilities because it's a developing country, there were no enough incubators and other facilities. So they started practicing this skin to skin care. And then later they have found that it has improved the survival of the newborns. Then the many research have been done. Then they actually studied on the birth weight, improved outcome for low birth weight infants, and it's a humanized gender care because that rather than separating the newborn baby from the mother, it's always good to keep the baby with the mother, right? And they have found that it has decreased the hospitalization time and therefore less overcrowding, less abandoned infants because maternal baby bonding is very much more, and it improves staff morale because their survival rate is going up. So then later on, this spread onto the other parts of the world, and they have, in 1999, they have made a Bogota Declaration. So then this was accepted by the UNICEF also in 1984, and
many people visit this Colombia, Bogota, and done many research, and they have then recommended this care for the low birth weight and preterm baby. Right? There are four components of kangaroo mother care. So kangaroo positioning, kangaroo nutrition, kangaroo discharge, and kangaroo support. So kangaroo positioning is you keep the preterm baby on mother's skin in between breasts. So here the idea is to keep the baby skin to skin contact. Baby should be covered only with a head and a nappy. And as you can see in this picture, the baby should be kept in frog position, right? And in between bare skin of the mother's breast. And then cover the baby with a binder. That's a wrap, right? And then mother can wear her bed jacket on top of the binder, right? So here a few things we have to consider. So you have to keep the baby's head in such a way that slightly extended position to prevent flexion or the hyperextension of the neck, just to keep the airway open. And that will facilitate mother and baby's eye-to-eye contact, slightly extended position, right? And the baby's hands and knees should be flexed like a frog, right? And then secure the baby with a binder, right? And you can tie the binder on top of baby's ear, as you can see in this picture, right side picture. So when you tie the baby like that, so it keeps the baby very secure, okay? And when the baby's abdomen lies on top of the mother's epigastrium, so when the mother breathes, the baby is also stimulated. This is very helpful in premature babies who will develop apneas. That's a constant stimulation going. So there are different types of binders you can use. So you can make binders, right? Or you can just use mother's clothes. So every mother has a clothes. You can fold it into three pieces, and you can prepare a binder like this from the mother's clothes, right? Or you can have special binders like that. That also you can use some long pieces of clothes. And this is what we have made at one time, right? To wrap the baby. So then the second component is kangaroo nutrition. So while mother is giving kangaroo care in the left corner picture, so mother can give NG feeds to the binder. Or she can express some milk and she can take the baby out of the binder and feed via the cup. Or if the baby is able to breastfeed, mother can breastfeed the baby. Then kangaroo discharge. Kangaroo discharge, once mother and baby is discharged from the hospital, mother can continue to give kangaroo care at home. She can do small housework like making a cup of tea, right? So she can engage in herself in some like her hobby or watching TV or reading books, anything. Or she can use kangaroo care to take the baby out, like if she's visiting to clinic, she can continue to give kangaroo care and take the baby wherever she wants, right? So kangaroo support means the staff, as healthcare staff, we support the mother while she is at hospital, and we train them how to give kangaroo care, right? And how to feed. And then when she is discharged home, also we can, like our health visitor can visit home and see whether mother has any problem, and she can do the weighing, right? And see whether the baby is gaining weight while giving kangaroo care. So once the baby is discharged home, the other members of the family, like the grandmother or the husband, can help mother to continue kangaroo care for the small baby. Right? If the mother wants to go for her need, so then either father or the grandmother can continue. But they should be clean without any chronic illnesses, and especially the father should not be smoking, because otherwise this premature baby will be exposed to persistent. Okay, so there are so many studies done. Studies done on mortality, temperature, breastfeeding, weight gain, and infections. So if you take a small baby, what we do is when we admit to the baby to the PBU, we keep them inside the incubator, right? In the like left chart, temperature chart shows the swinging of the temperature, body temperature in the baby who is inside the incubator. The right-hand chart shows there's less variation of temperature. That is the baby who has received kangaroo care. So from this study, they have shown that rather than the conventional care for a preterm baby, if you give kangaroo care, they have a better temperature regulation. And if you find a baby who is hypothermic, what we usually do is we keep them under a warmer or inside the incubator. So, but instead of that, if you start giving kangaroo care, they have proved that the babies who have given kangaroo care, that is the blue graph, have shown that they achieve the body temperature faster and better, with which less time. Okay, so that is a better care rewarming the hypothermic baby. And then the effect on breastfeeding. So, you know, there are so many problems, especially in the other countries, when you keep the baby, skin to skin, what happens where the mother's oxytocin secretion is enhanced. So therefore, the mother has a very good initiation of breastfeeding. Similarly, by giving the kangaroo care, the mother-baby bond is developed much more. So therefore, her breast milk, supply will be okay, and the mother's emotions, everything will affect the breastfeeding and the secretion of oxytocin, prolactin. Then this mother can go on breastfeeding for a longer time. So the studies have shown initiating and the duration of breastfeeding is more with babies who have received kangaroo care, right? Then they have studied the weight gain. So weight gain has shown the babies who receive kangaroo care have a much more better weight gain than the conventional care, because they are less stressed. They are mostly these babies are less stressed, and their activities very stable. They don't when they are in the incubator, we have seen that the babies are moving, crying, they are very sometimes distressed, right? So that will lose more energy from them. Okay? So, but by giving kangaroo care, the baby is more stable. So therefore, energy loss is less. So their weight gain is ultimately much more better than giving incubator care. Then the infection rates. They have found that the infection rate is also low, and the serious illnesses are also low with babies who received kangaroo care. Right? So Cochrane studies also have proven that nosocomial infections at 41 weeks, severe illnesses, lower respiratory activities at 6 months of age, and not exclusive breastfeeding at discharge, and maternal dissatisfaction. All these parameters have increased in babies who receive kangaroo care. Right? So finally, the mortality is also less. So what are the benefits of kangaroo mother care? So we can say the benefits to the baby, mother, and hospital. So what are the benefits to the baby? So baby is more stable. His cardiovascular and respiratory systems are more stable. So they will have less episodes of apnea of prevention, right? And then if the baby has less tendency to develop respiratory distress, if there is respiratory distress in preterm babies, and they have a better outcome than giving incubator care by giving kangaroo care. So you can give kangaroo care while the baby is receiving respiratory support like CPAP. Even the ventilated babies, you can give kangaroo care, because then their oxygen consumption will be low and they will improve fast, right? And it has been shown that they improve gastrointestinal function and they are better digestion of milk, higher initiation and duration of breastfeeding. Then what are the benefits? That we continue to see the benefits of the baby, and because of the reduced expenditure, I told you previously, baby is more stable, less stress, less crying, less distress. So therefore, they get more weight gain. Okay? And also, it's very good in poorly equipped units because it has been shown that incidence of infection and serious infections are very much low, right? And then the effective thermal control, right? So the baby develops a thermal synchrony with the mother because always on the top of the mother's skin, right? So less variable temperature. And also because baby is less stressed, there will be less steroid secretion. So that will help in improve neurodevelopmental outcome of this baby, right? And they will have more organized sleep patterns that also help in babies having good neurodevelopmental outcome, right? And they have shown more mature and organized electrical brain activities seen in these babies who receive kangaroo mother care. So let's see the benefits to the mother. So you know that when there's a preterm baby, it's like sometimes the mothers are very scared to handle these small babies. So if you start giving kangaroo care very early days, then the mother gain confidence. Now she feels that she is part of the newborn care, and she learns how to handle the baby, how to feed the baby. So by the time of discharge, mother is like more confident in caring for her preterm or low birth weight baby. And it also, because the mother and baby are always together, so it improves bonding. So therefore, less chance of babies being abandoned by the mother. You know that when we separate the mother and baby for a long time, sometimes it keeps them inside the incubator for 1 month, 6 weeks, or maybe more than that sometimes, right? Then their bond is very much less. Okay, so they empowered to play an active role in the care of their infants, right? And breastfeeding is promoted. So those are the benefits to the mother. As a hospital staff, we also have a number of benefits, and it's cost-saving method because this method doesn't need high-fi equipment, very like, you know, expensive equipment. It's a very simple method, and you can train the staff, and you can make use of the locally available things for the binders and all, right? So, so therefore, it's less costly, and also by giving kangaroo care, we can reduce the hospital stay because these babies, because when preterm baby is born, the big problem is their weight gain and when to discharge the mother and baby home. But their feeding is improved and they are more stable and their energy loss is very less and their weight gain is very good. So therefore, all these factors will contribute to less hospital stay. So therefore, less expenses for the hospital. And also, when the newborn babies are going home, well, that will improve the morale and quality of care of the neonatal units. Then it will ultimately improve the statistics of the hospital. There are two types of kangaroo care, that is intermittent and continuous kangaroo care. Intermittent kangaroo care is you provide kangaroo care for at least more than half an hour per day or few hours a day. That is intermittent, right? So you can start this practice when still the baby is in the incubator. So if the baby still need oxygen therapy and all, so you can initially start with intermittent kangaroo care. Then the other thing is the continuous kangaroo care. That is over the 24 hours period, mother can provide kangaroo care for the baby. Only she can discontinue only if she is going for her personal need. Right? So for that you need a the bed which the head end can be propped up, or even the normal bed you can keep 2 pillows and just keep the baby mother's head end elevated And then she can keep the baby on kangaroo care for 24 hours. So these are pictures of few mothers who are carrying out kangaroo care in our hospital setups. Right? For twins, even for twins, we can see there's a middle picture, this mother, right? She is giving kangaroo care for twins. That's a very good way of keeping them warm. Right? Mother is very happy because she's caring for both her infants at the same time. So kangaroo care is a proven, effective, easy method of care for the preterm and low birth weight babies. I think that's it. Do you all have any questions? So if you think about how long you can give this kangaroo care, so you can continue kangaroo care for a preterm baby who is 40 weeks of maturity or until they are 2 kilos. Okay. Thank you.
Thank you, madam. Then now tea break. Please come 11 noon. Then now start lecture.
Start the so I'm Dr. Srira Alisilla. I'm going to speak to you on physiological basis of resuscitation at birth. So the lecture outcomes or aims of the lecture is to understand the on physiological basis of resuscitation at birth. So the lecture outcomes or aims of the lecture is to understand the physiology of birth of asphyxia to provide a logical approach to the resuscitation, and also try to give you the importance of the strategies that is based on the physiological phenomena. Now, if you consider the main causes of collapse in adults is the heart problem, because the heart is disease. So therefore, the heart failure is the cause for the collapse in adults. But in children, it's not the heart problem because the heart is healthy. Heart is young, heart is healthy. Therefore, collapse in children is due to either ventilation or poor oxygenation or hypovolemia, shock. But when it comes to newborn at birth, the collapse is mainly due to the collapse of the alveoli causing poor oxygenation and aeration. Therefore, the collapse at birth, if patient is not breathing, it's due to alveolar collapse and no ventilation, alveolar collapse and ventilation. So therefore, that is what we need to address in the newborn resuscitation. So therefore, adults have cardiac arrest. The children have respiratory arrest. And so much so, the newborn is also having at birth the respiratory arrest rather than cardiac arrest. Now we consider the important factors about the babies at birth that will affect resuscitation. When you consider the baby inside the womb is covered by amniotic fluid, and the temperature is high because of the body temperature. So what happened at birth? At birth, this amniotic sac ruptures and the baby comes out through the vagina to deliver the baby. So therefore, what are the factors about the baby at birth that might affect resuscitation? In other words, when the baby is inside the womb, covered with intact amniotic membrane and the fluid, baby is not breathing actively. But the moment the baby comes out, baby has to start breathing. So that's a natural thing. So we will see what are the factors that affect the resuscitation at birth. So one thing is baby is small. So therefore, everything is we need to tailor-made for that small baby. Second thing is baby is wet. The baby is covered with amniotic fluid at birth and maintain normal temperature with the mother. So when the amniotic membrane ruptures and the fluid leaks, the baby is still covered with fluid. And the baby gets exposed to hypothermic environment outside. So baby can get cold very easily. That will prevent the baby establishing breathing. So baby may not breathe when the baby is exposed to cold. The other important issue is inside the womb, the alveoli are filled with lung fluids. But when the baby comes out through the vaginal canal, the lung fluids get cleared and baby has to establish breathing or ventilation at birth. So the lungs should be cleared of fluids. If the lungs remain wet, then baby can't start breathing on its own. So those are the factors that affect resuscitation at birth. Small baby, maybe sometimes preterm, maybe 1 kilo or less than 1 kilo, baby is wet before birth with amniotic fluid, and the lung or the alveoli are filled with amniotic fluid. So therefore, at birth, these babies are more prone to hypothermia, cold. The babies get cold, and that will affect their morbidity and mortality. And babies have unexpanded lungs. Alveoli are not expanded completely, so that baby get ventilation is poor. And if you check saturation, it takes 10 minutes to reach a saturation of 90. So they are born blue, and their saturation gradually increases up to 90% in 10 minutes. So this is because of the change in the from fetal circulation to the adult circulation. Then baby has the capacity to breathe using agonal gasping breathing. Even if the respiratory center is inactive, these babies can still breathe from the stimulus from the spinal centers. So babies, we told you baby's heart is healthy. Therefore, they have high glycogen stores, and the heart can keep going even though the baby is not breathing. Baby is not breathing. So they have high glycogen stores. So these are these issues can keep the baby going until the heart stops and until the heart stops due to poor ventilation. Now we take about the aeration of the baby. So this is the baby when the baby is inside the womb. You can see the baby alveoli is filled with fluid. The bronchioles are filled with fluid. What happened during vaginal passage? Only about 35 ml of fluids gets excreted through the vaginal passage. But still, there's about 100 ml of fluid inside the alveoli, which again needs to be cleared. And then what happens is after birth, soon after birth, what happens is when the baby takes a deep breath, or what we call high negative pressure breathing in the form of crying, the alveolar fluid get absorbed or get pushed into the bloodstream and lymphatics, and the alveoli get cleared. So the message is, the baby is crying at birth. You have to allow the baby to cry. Don't suck the baby at that particular time. If you suck the baby, you are trying to take the pressure out, and the alveoli are not going to get cleared. And baby will have respiratory distress, which we call as transient tachypnea of the newborn. So in practice, what you should do is, when the baby starts crying, let the baby cry and don't start sucking. And then the alveolar fluid get pushed into the blood and the lymphatics, and alveolar get aerated. Then with this first few breaths, baby start getting pink, especially you can see the pink color around the mouth. But having said that, still the hand and feet are pale and bit blue. It takes little time for these to get the normal color like in the face. So what do you call this condition? We call this condition as acrocyanosis. We condition this condition as acrocyanosis. No oxygen is needed. Let the baby cry, and this will turn to pink with time. The one other thing is what stimulates baby to take a first breath outside the womb. When the baby is born outside, baby has to breathe on its own. What are the stimulus to breathe? The one thing is cord compression. So when during the vaginal delivery, the baby's cord gets compressed, and that stimulates the baby to breathe. So that's because of cord compression. So you have seen probably during your appointments, that sometimes when the cord prolapse before the baby is born, we call it cord prolapse. Sometimes baby can start breathing because cord get obstructed. So therefore, cord obstruction is one of the stimulus for the baby to breathe. The second thing is temperature change. Inside the womb, temperature is high. And when the baby is born outside, the temperature is cold. Therefore, the sudden drop of temperature also stimulates the baby to breathe. The third stimulus is the physical stimulation. When the baby is born, you tend to wipe the baby well, and then you rub the baby hard, both the head and the limbs, and the back of the chest. So this stimulates the baby to take the first breath. So therefore, stimuli for the first breath is cord obstruction, temperature change, and the physical stimulation. Then we'll consider what happens with the first breath. What happens in the first breath? As I said before, the lung fluid get pushed out. Lung fluid get pushed out, and that establishes resting lung volume. Okay, thanks. Resting lung volume. So lung fluid gets pushed out, and that establishes resting lung volume. So when the resting lung volume is established, the alveoli are ready for the gas exchange. Now, if you take a series of X-rays, this is before birth, you find alveoli are filled with fluid here at 0 seconds. When the baby comes out through the vagina, some of the fluid get cleared, 0.3 seconds. When the baby is out, baby is crying hard, and lungs get cleared. So this also clarifies that the effective ventilation or effective breathing or crying is important for the baby to establish aeration in the alveoli. Now we will take you through a small experiment that was done on fetal lamb. The lamb was taken out of the womb with the amniotic sac intact, and then dip it in the water and rupture the amniotic fluid. So baby is exposed to the water in the bucket. And what was monitored during this, soon after opening the sac, is this fetus lamb's breathing changes, level of consciousness, blood pressure, heart rate, oxygen, and carbon dioxide. Although this is a bit unethical, but this gives a lot of information what happened when the baby get hypoxic or asphyxiated. Now, this arm is all the parameters. This arm is the time scale. So this is the 0 time, 10 minutes, 20 minutes, 30 minutes, and 40 minutes. What happens when the baby gets hypoxic? When the baby can't breathe, exposed to water again inside the bucket, baby start breathing fast, and the oxygen saturation drops. So this comes from the respiratory center and quite active breathing. Active breathing. They tend to breathe fast and try to improve the oxygenation. But since they are still in the water, they won't get oxygen, so the oxygen drops. Then what happens? After a while, baby develop apnea. And then baby develop breathing, which we call irregular breathing, ineffective breathing. This is called spinal cord induced breathing. The oxygen saturation remains low. And then after a while, baby stops breathing again. So this is what is called primary apnea, and this is what is called terminal apnea. And you appreciate the oxygen levels remain low during primary apnea and terminal apnea. So there's an occasional gasping breathing here, and now baby no breathing apnea. So the respiratory center contributes to the normal breathing. And there's no spinal breathing here. But with time, after primary apnea, spinal respiratory center get inactivated because of hypoxia, and the spinal center stimulate and causing gasping, ineffective type of breathing for a while, and then stops and resulting in terminal apnea. So we said oxygen is low in both during primary apnea and terminal apnea. What happened to the carbon dioxide? It's gradually accumulating. What happened to the heart rate? So heart rate of 140 goes up to about more than 160, and then it drops, but it doesn't drop to 0. During primary apnea, it stabilizes around 50 to 60. And this is the gasping type of breathing, and this is terminal apnea. You find heart rates can drop to 0. In fact, patient can die during terminal apnea when the heart rate is low. So what do we learn here? We learn when the baby, after birth, if the baby's heart rate is 40 to 60, then we are not breathing, baby's in primary apnea. If the baby's heart rate is less than 40, dropping towards 0, then that is baby's in terminal apnea. So that is one of the clinical signs that that you might appreciate when you go for baby resuscitation. What about the acids? Because of the carbon dioxide accumulation of carbon dioxide, the acidosis gradually building up. And by the time baby develops terminal apnea, there is acidosis in the baby. So therefore, what we learn here is during primary apnea, the circulation is maintained by shutting down the circulation to non-essential areas. What do you mean by non-essential areas? Skin circulation and the gut circulation. Skin circulation and the gut circulation. Now we will see what happens if the baby is born here, or baby is born here during the gasping stage when the baby is born in the terminal apnea. Now here the baby is born in the primary apnea. So what happened here is heart rate has dropped, but maintained on 40 to 60, blood pressure is maintained, but baby is hypoxic. Baby is hypoxic. therefore, what happens is when there is hypoxia here, the baby has to breathe on its own. So when the baby breathes on its own, what happens? Oxygen saturation goes up, acid comes down, and the heart rate goes up. Heart rate goes up. So what do we need? Active assistance during the primary apnea when the baby is not breathing? No interventions. But we have to make the airway pattern. So if the baby is in primary apnea and you don't need any active resuscitation of the baby, only thing is you have to make the airway pattern and the baby start breathing. How do your baby is improving? Again, when you look at this chart, you can find oxygenation is improving. That is color. It's a late sign. When it comes to the skin, it's a late sign. Earlier than that, what is the most important sign? Before this, you can appreciate heart rate is dropping. Therefore, it is important that you auscultate these babies. And then if you find the heart rate is increasing, that means baby is improving. So more than the color that you appreciate, if they think heart rate is increasing, that means baby is recovering. So you have to maintain only the airway patency. So how do you maintain airway patency? Baby is in neutral position, and then do the head tilt and chin lift and see whether the baby is improving. Otherwise, we do jaw thrust. And see whether the baby is improving. Airway patency. You make the airway pattern by neutral positioning, then head tilt and chin lift, and then probably jaw thrust. And that's a longer duration. Obviously, that's a longer duration of gas. Longer duration of gas. Again, you appreciate more than the oxygenation, the heart rate increases soon after that. So that means increasing heart rate means baby is improving. Baby is improving. And then the color improves after that. Therefore, you have to have your stethoscopes around your neck when you go for resuscitation. And then check the baby's heart rate on the chest, in the apex, to see whether the heart rate is improving. Then what happened? The baby is born in the terminal apnea here. So this is gasping breathing, terminal apnea. The terminal apnea, you go for a resuscitation, you do the airway intervention as I said before. Make the airway neutral and head tilt and chin lift and see whether the baby is improving. Otherwise, you do jaw thrust. So if you don't do that interventions, what will happen to the baby? Baby will die because the heart rate drops and the blood pressure drops and baby will die of the baby will die of shock. Therefore, what do you want to do? You want to aerate the lungs. You want to use bag wall mass ventilation here, lung aeration. So with lung aeration, you are trying to create ventilation. So when you do the ventilation, the heart rate improves, baby is improving. So that's a good sign. But in certain circumstances, so here the baby cannot breathe, you try to inflate the lungs, and then with the inflation, the ventilation improves, heart rate improves, and color improves, acid goes down, carbon dioxide goes down, baby improves, and comes back to normal breathing here, and establishes normal breathing, blood pressure going up, and the heart rate comes back to normal. So this is what happened with lung aeration and ventilation. The baby is born in terminal apnea. But it is not always so. Some of the babies born in terminal apnea need lung aeration. We call it lung inflation or inflation breaths. And then go on for about 5 inflation breaths. And then you continue with your ventilation breath and you find you have to identify whether the baby needs chest compressions. How do you find out whether the baby needs chest compressions? With ventilation, you find chest is rising. So that means air is moving into the alveoli. And the second thing is you find baby's heart rate is not improving. If the heart rate is dropping or not improving, in spite of the ventilation, effective chest rise, that is the indication for chest compressions. So in other words, the two indications for chest compression is heart rate is low, less than 60 and dropping or dropping. With ventilation, there's a good chest rise. That means lungs getting aerated. So those are the two indications for chest compressions. So with chest compression and ventilation, then baby will start improving, oxygenation improves, heart rate improves, it comes back to normal breathing and normal heart rate. Here, we do the chest compressions, 3 compressions to 1 breath. We call it 3 to 1. When we resuscitate, we give 3 breaths here. But out of these few the baby is effectively takes little while to improve. Color takes little while to improve. So those are the two signs to go by during the resuscitation. So you need to have your stethoscopes around your neck to appreciate that the increase in the heart rate. Otherwise, it takes a while for you to get the stethoscope from where it is. And color, don't wait till the color improvement to see the baby is improving. Right, okay. So this is the basis of the physiological parameters, physiological changes that is helpful to identify whether the baby is improving with physiological changes. So about another 5 minutes, I will tell you the little things that you might need later on. So here, when you do lung aeration, we use the bag valve mask ventilation. Now we discourage bag valve mask ventilation and we encourage ventilation with neopuff. I don't know whether you have had a chance to look at how the neopuff works. So neopuff is a gadget, a small ventilator that you can maintain a PEEP, certain amount of PEEP, and then once you press, they get the PEEP above the PEEP. So that unlike bag valve mask ventilation, at the end of the inspiration, during expiration, the alveolar pressure doesn't get 0. Alveolar pressure stops around 4 centimeters where you set in the neopuff. So alveoli are kept open so that lung damage is less with neopuff. I think during internship, if you find that your unit is using neopuff, you need to get used to the neopuff, you're ventilating with neopuff. And then you can find your ventilation resuscitation is much more effective. And also, you said color is a subtle sign. Therefore, you need to check the saturation. If you want to check the saturation, you have to attach the probe to the right side, right limb, and not the left hand. While right hand is preductor, left hand is postductor. Therefore, always check the saturation of the preductor saturation, the right hand saturation. That is much more accurate than the postductal saturation. And also you need to keep on doing aeration or ventilation and chest compressions for about 1 to 2 minutes, and then when checked, if you think the patient can breathe or if you think patient circulation has come back, heart rates have gone about 100, more than 60 or 100, and the patient's color is okay, patient is crying, and heart rate is increasing, you can stop chest compressions. The patient is not breathing, you need to continue to ventilate. the baby is crying and establishes breathing, effective breathing, then you can stop ventilation. Otherwise, you need to keep on giving effective ventilation and chest compressions, and you may have to give some adrenaline to start the heart rate and call the neonatal intensive care unit. You send a team with the transport incubator to take the baby in. And make sure baby is not getting hypothermic during this process. Hypothermia is one of the main killers during this strategies, during these procedures. Therefore, you need to prevent the baby getting hypothermia. Okay, so I think that's we come to the end of the physiology lecture. So understanding physiology is vital, and then you can understand the next two lectures related to the newborn resuscitation, which is the term resuscitation and preterm resuscitation. So thank you very much.
My phone.
Yeah, good morning. Yeah, good morning. I'm Dr. Shama Bhatnagar, neonatologist at Lady Ridgeway Hospital. Can you all hear me? Is my mic on? Can you hear me?
Yes, madam.
All right. Okay. So now you have understood the pathophysiology behind birth asphyxia and why babies are born with no or low heart rate and no respiration. Then what are the reasons for that and how to resuscitate a newborn. So having that knowledge, physiology behind birth asphyxia, once you understand, it's very easy to understand the resuscitation. So we'll move on to resuscitation at birth. This is what most important practically in your day-to-day practice. Even though you know the theory, no point of if you can't handle a baby and resuscitate and rescue the baby. So we'll concentrate on this. Here I'm going to discuss the logical approach to resuscitation at birth. Right? Whenever you are called for a resuscitation, first thing you have to do is you need to go to the site and you have to introduce yourself to the obstetric team as well as the mother. Then prepare the environment. In preparation of environment, the most important thing is control the temperature. Sometimes AC may be quite, temperature may be quite low, windows may be open, fans are working. So you have to close the windows, switch off fans, and AC temperature to be adjusted about 26 or 27. So that's the environmental preparation. Then you have to get ready with your equipments. You can't go here and there finding for searching for equipments once the baby is born. So you have to be quite ready and equipped before baby is born. As soon as you go there, turn on the heater and put 3 towels on the resistor to warm. Then turn on the oxygen and air supply and check whether the suckers are working. Then wash your hands because those are dirty equipments. Wash your hands and put double pair of gloves. With the upper pair, you are going to get ready with the rest of the equipment. Once the baby is born, you have to remove the upper pair of gloves and accept the baby with sterile gloves. For any baby, the algorithm of resuscitation is dry and cover the baby and wet clothes should be discarded, then manage the airway and breathing. Then after assessing the heart, if needed, support the heart and check other parameters. That's the algorithm. Then we'll move on to see what are the equipments needed for resuscitation. These are two types of resuscitators. The types of resuscitator brands or make may be different, but every resuscitator has the same functions. A heater should be there, light should be there, APGA, that stopwatch, thermostat, temperature monitor, all these things are there. You have to be familiar with the equipment you have in your unit. So these are the equipment list. Clock or stopwatch, as I said earlier, most of the resistors has that. Right? Gas supply or suction supply, warm dry towels, plastic bags in case of a preterm baby or very low birth weight baby, and a firm stable surface to resuscitate the baby, ambu bag with a blow-off valve or a neopuff. In case of a preterm baby, a neopuff is preferred to ambu bag. face mask and tracheal tubes, Google airways, laryngoscope, functional laryngoscope. Before baby is born, you have to check the light and the size of the blade. Wide bore suction catheter, stethoscope to check the heart rate, and drugs, adrenaline, normal saline, dextrose, and scissors and tape to pick the tubes and lines. So those are the equipment you need to prepare those before baby is born. Then again, we'll go through the algorithm of resuscitation. Any baby, first thing is dry and cover the baby. Then keeping the head in neutral position, assess the baby. What are the things you assess? When you're assessing color, tone, breathing, and heart rate. There's a mnemonic CTBH. You remember in that way, color, tone, breathing, heart rate. Then once you assess, if baby needs support, attend to the airway. If baby is not breathing, support breathing with inflation breath. Again, once you do that, again reassess and check whether heart rate has improved. You would have learned in your previous lecture, if baby's lungs are inflated, the first sign is rise of heart rate. So if heart rate has improved, you can assume that you have inflated the lung. Once you have inflated lungs, if heart rate is still low, you can, after giving cardiac compressions, if the heart rate remains low, you can consider giving drugs, but very rarely babies need drugs. Most of the babies recover once you open up the airway and rest during the stage of inflation breath or cardiac compression, they improve. So what are the differences of a baby, newborn baby and an older child? These babies are small and they are wet. They get cold very quickly. That's why we need to dry the baby and then cover with warm dry towels before doing anything, because the hypothermia is the risk factor for mortality and morbidity. This is how you wipe the baby with warm towels. You wipe thoroughly, like when you are drying the face, head and back, you can stimulate while you are rubbing the back. Don't ever pinch, squeeze, slam the baby. That's torturing in order to stimulate. While you are drying, you can stimulate the baby. As soon as baby is born, you need to start the clock, then dry the baby and assess the situation. There you can decide whether you need help or not. If baby's heart rate is not there, baby is not breathing, quite floppy, that instance, you know, you need extra pair of hands. Then call for help. In any case, like if baby is not breathing, if you think you better to have another help, always call for help. Don't ever hesitate to call for help, because if you don't need the help by the time help arrives, you can send him back without any problem, right? So these are the things you assess in your initial assessment. Color. Color should be, if baby is like born healthy without any problem, you have seen babies are very pink. Tone is flex, moving limbs. But if baby is not in good condition, color may be pale blue, tone is very floppy like a ragdoll, baby is not breathing. If he is born quite well, regular breathing should be observed. If not, irregular breathing or apnea. Heart rate usually more than 100. If it is less than 100, that means baby needs help, right? We'll go through these scenarios quickly. This is a good tone baby. This is what we all expect to see. Good tone, breathing regularly, fast heart rate, baby. Then dry and cover and hand over to mom. This is the baby we would see most of the time. But if a baby is born with a moderate tone, breathing inadequately with slow heart rate, what would you do? Can you all participate here? Connection is there. Nimesh, what would you do? So if you all are not interested in answering, I'll go on. So if baby is breathing inadequately, you need to open the airway. That's the first step. When you open up the airway, most of the babies will start breathing once air enters the lungs. Then you have to reassess. Sorry, I forgot. Dry and cover is the initial stage for any baby. Then open the airway, and once you open the airway, if baby is not breathing, you have to consider whether inflation breaths are needed or not. If baby is not breathing, you need to continue with inflation breaths. So this baby is born floppy, not breathing, slow, very slow heart rate. What would you do? Again, dry and cover is the first step. Then open the airway, give 5 inflation breaths as baby is not breathing. Then reassess the situation. There you can decide whether you need help or not. When you reassess, if baby is not breathing and heart rate is the same, you have to, you can repeat 5 inflation breaths. Or if you have expanded lungs, you can go for cardiac compressions. So you can close these parts. In the unconscious baby, airway obstruction is usually due to loss of pharyngeal tone, not due to foreign material in the airway. Therefore, the suctioning of the oropharynx is not required. What is needed is to position the airway in order to open up the pharynx, right? Because these babies are quite delicate. Their pharyngeal tone is not there, so it tends to close in flex position. So you need to keep the head in neutral position and open up the airway. Right? Let's see how would you position the airway. Hold the head in neutral position is the first airway maneuver. When you are holding the head in neutral position, you have to keep the ears parallel to the surface, eyes parallel to the ceiling. For that, you can just lift the chin, right? This is how head is held in neutral position, right? So, in the same position, if baby needs inflation breaths, you can keep the mask in C and E technique, hold the mask in C and E technique and deliver 5 inflation breaths. If you can't, once you give 5 inflation breath, if you can't see chest expansion, that means baby's airway is not patent. Then you have to consider the second airway opening maneuver, that is jaw thrust. Here jaw thrust is given in this way. Actually, you can keep your thumbs over the maxilla, then it's quite stable, and push the jaw anteriorly. Not to overextend the neck, keeping the head in neutral position, you push the jaw anteriorly. Then you can give 5 inflation breaths and see whether airway is open. When you are resuscitating, first breath to be given is called inflation breath. Usually you start with air. Pressure. You all know when you press the, squeeze the ambu bag fully, you deliver 30 centimeter H2O pressure. That pressure needs to be delivered over 2 to 3 seconds. Then only this fluid in the alveoli get absorbed into the lymphatic. We all know in the previous lecture also they have shown you lungs are full of fluid immediately after birth. You need to get rid of this fluid and aerate and establish a functional residual capacity. That's what we are trying to do by giving 5 inflation breaths. After giving 5 inflation breaths, you reassess again color, tone, breathing, heart rate, and one more parameter, chest expansion. by looking at chest expansion, you can see whether your airway is patent or not. Give inflation breath, then reassess. What would you hope to find? If you are given good inflation breath, what could be the parameter first improve? Heart rate. So we expect to find an increase in heart rate. So how do you assess the heart rate? By using a stethoscope or pulse oximetry. We don't practice this palpation of the cord or the palpation of the precordium, right? If the heart rate responds, you can assume the lungs have been inflated. Sometimes in preterm babies, when you give high inflation breaths, it's difficult to see whether the chest expansion is there or not. Then when you auscultate, if heart rate has increased, that means lungs have inflated. If your heart rate is not increased, it may be due to two reasons. One is you have not inflated the lungs. The other reason, even if you have inflated, the heart needs support to respond. That means if the baby is in terminal apnea, you know, heart doesn't respond as just after oxygen goes in. Heart also needs support. So how can you tell which is true for your baby? For that, chest expansion is quite important. Suppose you give high inflation breaths, baby's heart rate is still remaining less than 100. Then you look for chest expansion. If you have a good chest expansion, that means chest have inflated but heart is not functioning. Then you need to go for cardiac compression. If chest expansion is not there, you have to go back to your airway opening maneuvers and reposition the baby and give high inflation breaths again. Excuse me. Hello. I'm doing a lecture. Give me a call. So, if the lungs are not inflated, like no chest expansion, you have to correct your airway opening maneuver and give inflation breaths again, right? Usually, inflation airway opening is always effective. About 95% of babies for whom help is called will recover within a minute or two once air enters the lungs. So, the learning airway opening maneuver, keeping the head in neutral position, jaw thrust, and delivering inflation breaths is very effective because most of your problems, 95% of the babies will recover just by doing that. If the chest is not moving, the lungs are not being inflated. Check airway and breathing again. You can do positioning if there are secretions, suck out secretions, and deliver inflation breaths again. This is how you give a two-person jaw thrust. One person is holding the head in jaw thrust and holding the mask in C&E technique. Other person is delivering the pressure through a T-piece device. If airway opening is not possible with these airway opening maneuvers, either neutral position or jaw thrust, you have to go for airway adjuncts. We can use Boodle airways to open the airway by this. To insert a Boodle airway, you have to look under direct vision. For that, you can use a laryngoscope, large bore sucker, laryngoscope or a tongue depressor. Then use a large bore sucker to suck out if anything is lying on the pharynx. And when you are sucking also, it should be under direct vision. Then only you are supposed to put the Boodle airway. When you are inserting it, don't rotate it. Just insert right side up. This is a post-mortem specimen of a baby who died of a meconium aspiration, thick mucus plug. Thick meconium plug is found inside the trachea. It may be mucus, blood, vernix, anything. So you have to suck it out before you push it in. Screaming babies have an open airway, so you know point of sucking and screaming, sucking a screaming baby. Floppy babies, better to have a look. Get rid of this too. So if the heart rate has increased and now it is above 100, but baby is not breathing, then what would you do? You have to continue with ventilation breaths. Heart rate has increased means we have inflated the lungs. Our inflation breaths have worked. So we need to continue with ventilation breaths. Ventilation breaths are given at a rate of 30 breaths per minute until baby is breathing well. But if the chest is moving but the heart rate is still slow, then consider giving chest compressions when effective ventilation is served. There are two methods of chest compressions. One is hand encircling method. When you have two rescuers, it's easier and it's more effective. And if you are the single rescuer, go for two-finger method. Both are shown in this picture. The landmark for chest compression is lower 1/3 of the sternum in the midline. When you are giving cardiac compressions, the ratio should be 3:1. 3 cardiac compressions and 1 breath. Depth should be 1/3 of the AP chest diameter. You should press downward about 1/3 of the AP diameter of the chest. You start giving cardiac compression when the heart rate is less than 60. So chest compression ratio 3:1. You can continue when you are doing ambu ventilation. If you have intubated the baby, you can go at your own rates. Somehow or the other, you have to maintain 90 cardiac compressions and 30 breaths per minute. Altogether, 120 events in 1 minute. You want to move oxygenated blood from the lungs to the coronary arteries. It's not that far and won't take long time. So, pressing 1/3 of the AP diameter is enough. Whenever you need to start cardiac compressions, consider giving supplemental oxygen. Then reassess again. Has the heart rate improved? If not, you have to go back to your airway and check the airway, check chest movements and check the quality of chest compression. After giving good quality chest compressions with open airway, if the heart rate is still slow, you have to consider drug. The drug of choice is adrenaline. The dose in the current guideline is 20 mic per kilo. Rarely you might need volume, dextrose, and even rarely you go for bicarbonate. How do you give these drugs? It has to be central line because baby circulation is collapsed. So you have to go for a central line. UVC is the easiest way. So insert a UVC 3 to 5 centimeter below the skin surface. When you see blood is coming back, you can give your drug. After stabilizing the baby, you have to do a pre-assessment. This is called stabilization assessment. This mnemonic is TOPS is used for that. S is sensorium, whether baby is active, crying, alert, or have fitting. Temperature, whether baby is maintaining temperature, oxygenation. If baby is in respiratory distress, check the oxygen saturation, perfusion, capillary fill time. It should be less than 3 seconds. If not, you have to give a fluid bolus and resuscitate. Blood sugar, if it is low, you have to give a dextrose bolus and resuscitate and correct it. Then once you stabilize, the other important things are you have to speak to parents and you have to maintain good record. Especially this communication is something we are weak in Sri Lanka. So you have to improve yourself when you are communicating with parents. Even a preterm baby, if you are moving the baby away from mother briefly, even if the baby is intubated, you can briefly show the baby to mother and say, I'm moving the baby away to NICU because baby needs respiratory support and so on. But once you are stable, you can come and have a look. And in case of a preterm baby, anyway, we are supposed to explain everything prior to delivery. Then mother is also aware of the situation, but make sure you show the baby to mother before you take the baby away. Then records keeping, again, we are not that strong in that aspect. So accurate, it has to be accurate and comprehensive. You have to use proper word, and when you are sharing information with parents, the most senior person in the team should involve in that. So after giving good quality resuscitation, if no heartbeat at here it says 10 minutes, but in the new guideline it says 20 minutes. If there is no heart rate, you can decide to withdraw, right? So this withdrawal decision also should be taken collectively. Everybody in the team, resuscitating team, should agree upon that, right? Because no point of resuscitating a already brain dead baby and result in a cerebral palsy. So that's basically newborn resuscitation. As you all don't participate in this lecture, I don't know whether you can understand or not. If you have any questions, I can answer. No question. There are special situations. If a baby is born with what's this group, by the way? HO, so register. What you don't know? Are you what part of your training? This group? Registrars, STARs, HOs, nurses.
They are pre-interns.
Pre-interns. So, did you all understand this?
Yes, madam.
Then I'm not going to discuss this therapeutic hypothermia outside labor wards because most of our deliveries take place in wards. We'll spend some time with the summarization. So it's actually good if you can ask questions if it is not clear, because this is the first time you are listening to this net. So in summary, I would say any baby, if you can remember the last bit, that's enough. If when you are attending a delivery in any baby, once the baby is born, you have to try and cover the baby. Okay. Then keep the head in neutral position. I told you how to keep the neutral position, right? That's just lifting the chin. Shall I put this video? Video? No. Here, for me to. Can you all see me? No.
Yes.
Right. So when you are just, I can't see my face here, so I don't know whether it's clear to you. When you are doing the chin lift, just with your two fingers, lift the chin like this. Don't overextend. And then baby's ears will lie parallel to the table, and eyes should be facing directly the ceiling. That's how you maintain the neutral position. If you can't open up the airway in neutral position, go for jaw thrust. with the angle of the mandible, you lift the jaw forward. Again, no overextension, forward. When you are doing that, you can keep your thumbs over the maxilla, then it's easier, right? Do they have practical sessions as well? No. So
Madam,
once you, sorry?
You might have to tilt the camera a little bit below, madam, because it doesn't show the whole face. Right. That's
Is it
better.
better? Yeah, so this is the angle of the mandible. You have to keep your finger here and lift the jaw anteriorly. Don't overextend the neck like this, right? When you are giving the doing the chin lift, just tilt it slightly, right? Then without practical sessions, I don't think you will understand this very well. There is a technique C and E technique. You keep your index and thumb over the ambu mask and other fingers over the body parts of the baby's jaw. Don't compress any soft tissue here. Then tongue will fall back and airway get obstructed, right? So keep the jaw C and E technique and give high inflation breaths. So if you can maintain an open airway and give high inflation breaths, your 95% of babies will recover with that, right? When you are giving high inflation breaths, it has to be like high pressure, sustained breath. You give 1, 2, 3, release. When you are counting 1, 2, 3, you squeeze, release, release, right? 1, 2, 3, release. 2, 2, 3, release. 3, 2, 3, release. 4, 2, 3, release. 5, 2, 3, release. Likewise, you give high inflation breath and then reassess. When you are reassessing, color, tone, breathing, heart rate, and chest expansion should be assessed, right? If chest expansion is not there and heart rate is still low, you go for airway maneuvers again and open the air. If chest expansion is there and heart is still low, you have to give cardiac massage. When you are giving cardiac massage, it has to be 1/3 of the lower sternum, compressed 90 per minute, right? There are two methods. One is hand encircling method, other one is 2-finger method, likewise, right? If you continue ventilation breaths, also go at a rate of 3 cardiac compressions, 1 breath. 3 cardiac compressions, 1 breath. Likewise, right? So if baby is not breathing, once you expand the lung, you have to continue with ventilation breaths until baby is breathing. If baby is not breathing for a long time, obviously you have to intubate this baby and connect to a ventilator. So most of the babies will recover with airway opening and inflation breaths. Very rarely need intubation and drugs. Right, cardiac compressions are also needed. Here in this inverted triangle shows dry and cover most of the babies, airway and breathing only for few, cardiac compression even lesser, drugs very minimal number of babies will require. So you can understand as beginners what you need is to master your dry and cover you should know, and airway opening maneuver and deliver inflation breaths and ventilation breaths, and cardiac compression of course you can learn. That's it. Any questions? Any questions? No. So always once you take a decision, act on it. After each and every action, you have to evaluate and see whether there's any improvement. Right? If you don't have any questions, I'll stop here. What's the next section? So your next lecture will be the management of preterm babies. There are also the same principle applies, but there are deviations in order to like prevent hypothermia. They are more prone to hypothermia. Their lungs are immature, so there will be certain different things than a term baby. Otherwise, the principle is the same. So once again, I'm asking if you have any questions, I can answer. No. Okay. Okay, thank you.
Thank you very much, madam, for that detailed lecture. I think there's a question, madam, saying, I think most probably you would have answered. Madam, if you don't mind, can you explain why don't we suck out secretion at the beginning? That's on the chat box.
Right. That's a good question. You should come out with those because earlier you may have seen, you may not actually, in your era, we had stopped suction at the beginning. But when we were medical students and HOs, they used to suck each and every baby at the time of delivery, right? So that has been the routine practice. I'll explain why it shouldn't be done. One reason is this baby airway airway is blocked not due to any blocking with any secretions. It is due to lack of pharyngeal tone. That's why you need to position the airway in order to open the pharynx, right? That's one reason. Other one, there are harmful effects of suctioning. One is you will stimulate vagus nerve and cause bradycardia and make the conditions worse. And you can create a negative pressure and you make baby to breathe more difficult to breathe, right? Baby can be apneic. Those are the reasons. Did I answer your question?
Yes, madam. Thank you so much.
Any other questions? Okay, then enjoy your next lecture. Thank you.
Thank you very much, madam, for that comprehensive lecture.
Thank you.
So next lecture is by Dr. Jitma Fonseca, neonatologist at Teaching Hospital Anuradhapura, NLS of preterm babies. Over to you, madam.
Thank you very much, Dr. Roshan. I hope you all can hear me.
Yes, madam, can see and can hear you.
Good afternoon. I'm going to talk about preterm delivery for the next half an hour. So I must say the preterm delivery, it's a challenge. It's slightly deviating for expert sides in managing of a newborn, but there are important things as a house officer you should follow. So we'll stick to basics and we follow the normal procedure with slight deviation and some added care for this preterm baby. Okay. At the beginning, we are going to discuss what happened if you didn't manage this preterm well. So if you mismanage this preterm, you will see some short-term complications such as and long-term complications. What are the things you can see as short-term? So baby could become hypothermic, hypoglycemic, and hyperoxic. So that is if you give more and more oxygen unnecessarily. And later on, so you might see they are with interventricular hemorrhages, chronic lung disease, we call it as bronchopulmonary dysplasia, retinopathy of prematurity. If you look at these complications, you will see those things have a lot of adverse effects, which will affect the baby morbidity as well as mortality. So our aim is to develop and discharge a stable preterm baby. So how can we proceed for that? Okay. So preterm babies, what is the difference between preterm and a term baby. Why we should worry about it? And are they really different from a term baby? And how can we approach, how can we change our approach for a preterm? Let's see what sort of preterm babies you can encounter. So as I mentioned before, some preterms, we know preterms mean any baby who is born less than 37 weeks. But some babies, like 34 to 36 weeks, they behave as term babies. So you don't need to worry about it much. So you can treat them as term babies. But if baby is 31 to 33, they might be good as term babies, but they might not. But definitely, babies who are less than 30 weeks or below, they are definitely different. So basically, your preterm approach mainly applies for babies who are between 33 weeks or below. Okay. What is this difference? So they are more fragile. So they get cold even very faster. So you need some measurements to prevent that. And their lungs are more fragile. They don't have enough surfactant. It may be not developed fully. So you have to take extra precautions when you're giving the respiratory support. And they don't know how to breathe effectively. So their respiratory centers are not well developed. So you might need to give support until they start breathing effectively. And their stores are filled. We know their stores usually develops during the 3rd trimester. So if they're born before that, they have fewer reserves for fighting against these complications. And their color, you cannot predict the color. So you have to apply the pulse oximetry. They are generally dark. So if they are cyanos, you might miss it if you haven't applied a pulse oximetry. Okay, so actually this preterm challenge is starting during antenatal period. So some informations are very important during the antenatal period. What is the gestational age? As we mentioned before, if it's an extreme preterm baby, like 28 weeks or below, then you have to be more cautious. You have to take more precautions. You might need more terms and multiple pregnancies. Again, the one person might not have enough, so you might need more people for the attempt to delivery. And steroids, the antenatal steroid, which has a lot of advantages. I have mentioned only one advantage here, that is intraventricular hemorrhage reduced by 46%. You can see this number. If you give the steroid, that itself reduces the intraventricular hemorrhage by almost 50%. So it is important to prepare the mother with steroids before a preterm delivery. So as a house officer, it is important if a mother admitted with preterm labor, then think about steroids and ask from your seniors whether this mother is indicated for a preterm delivery and then whether we need to give steroids. And antenatal magnesium sulfate, again, very good neuroprotective effect. So it is important to give this magnesium sulfate. And if mother comes with preterm rupture of membrane, so she is more vulnerable to get infection for the baby as well. So it is important to start antibiotics to prevent infection such as chorioamnitis. So as a house officer, you will encounter those factors and you can discuss with the seniors about the necessary steps. Okay, so place of delivery. We all know, depending on the facilities available, we might not be able to deliver all preterm deliveries at the center where they. If you have time, then it's better to transfer a baby, mother in utero. We call in utero. We are transferring the baby inside the uterus to a center where the facility is available. So if the transport preterm, if you transfer a baby after a delivery, especially preterm, during the first 48 hours life, there is high chance of having severe IVH. if you have a severe intraventricular hemorrhage, their morbidity and mortality is very high. So therefore, if you have time, please think about in utero transfer. Then antenatal counseling. Again, this should be done by the most senior person available at the unit, but as a house officer, you can make this mother comfortable because she's coming in preterm labor. She is uncertain about the situation. She might feel guilty, fear, anger, suffering, sadness due to separation because she was not sure whether baby is going to survive or not. So some mothers, they don't like this preterm baby because they know that they are going to get a very small baby. They may be scared about that. So the initial reassurance might be very important. That is by the available more senior person. Otherwise, the house officer can reassure this mother to a certain extent. So those are the key behavioral skills we discuss in APLS courses about the neonatal resuscitation. Know your environment. So you have to adjust according to the environment and prepare the environment. So we'll be discussing these topics on next slides. So skilled care at birth. So what is this skilled care? So it could be the neonatologist or pediatrician, or could be the senior medical officer, or could be an experienced NICU nurse. So if those people are not available, you might be the house officer. So try to get the knowledge and try to apply it until somebody comes to take over the leadership. So anticipatory preparation, that means you have to ready before the event, before the delivery, and organize a team. So you should have a team. You should need a doctor. You should need at least sometimes the ARV person and the chest compression, 2 people, and you have to speak to obstetric team. So you might be the new house officer. They might know who you are. So please inform that you are the medical officer attending for the delivery and call for additional help. Don't hesitate to ask for help. Always call for help, especially if baby is not breathing, call for help. And you prepare your resuscitation equipment and check those equipment before. For example, laryngoscope, you have to check it whether the light is working adequately. So those things are very important. And you have to use the pre-resuscitation checklist, that is important. And then inform the PICU and transport team, because by the time of delivery, they will be ready to accept your baby. So know your environment well. What is this? So we have to take all measures to prevent hypothermia. How can we prevent that? So you can switch off AC if you can, or you can set the temperature 26 or above. Sometimes you cannot switch off. And if there are fans, you can switch off those, close windows, turn on the heater. So by the time of baby's delivery, the heater is on and the resuscitator is warm. And turn on oxygen and check air supply. And then you wash your hands and you wear 2 pairs of gloves. You are going to check the equipment afterwards. So call for help. If you are the single person, if you are the house officer, always try to get help, because at the moment you are inexperienced. Until you get good experience, always call for help. And clearly identify a team leader, that is probably a consultant or a senior medical officer. And delegate the workload optimally. So don't try to do everything by yourself. Always divide your jobs and call for additional help when needed. So at delivery, so you might think about whether you need to give the active resuscitation or comfort care. So the resuscitation, that depends on the decision, depends by the consultant, because sometimes babies who are less than 24 weeks, depending on the baby's situation, we have to decide whether we are doing the active resuscitation or comfort care. There is a circular published in 2017 that defined which babies you need to resuscitate. Mostly very preterm babies, who need help with transition to air breathing. So that is, we are not calling resuscitation because we just supporting them. So what you have to do is careful assessment and gentle support. We should not panic. So being preterm, that doesn't mean they always need intubation. They always need chest compression. So it is probably the support for transition. So careful assessment and gentle support, that is very important. So there's another concept called cord clamping. So cord clamping, we are practicing for newborns who are not requiring resuscitation. So during that time, your baby should be all right, and you should be able to keep the baby warm. So you can cover the baby with towels. So what is the minimal duration? We say at least about 1 minute. So we are allowing more placental transfusion towards the baby. And during this time, we cannot just keep the baby. You have to observe the baby color, tone, activity, whether the baby is well during that 1 minute period. So this is how they practice the delayed cord clamping. You can see they have kept the baby lower level compared to the mother's level and allowing the transfusion for 1 minute. So this is very important concept for a stable baby. So what are the important benefits of this? You have early benefits. So this preterm baby, when admitted to the PBU, their hemodynamics, they have seen it is more stable. So they need less inotropes, less need for blood transfusion. Those are very good things for preterm survival. And later on also they have seen these babies have improved motor function at 18 to 22 months. So these preterm babies, if they are stable, you can allow for delayed cord clamping. Okay, this is the main challenge we are encountering in preterm baby, that is hypothermia. So you can do several actions to prevent hypothermia. So you can set the temperature at 26 or above in the delivery room, as I mentioned. So your radiant warmer is ready and you're using warm towels. So underneath the warmer, you can lay down those warm towels. So by the time of baby's birth, towels are warm. And you need plastic bag, that is to put the baby's chest, as this picture demonstrates. So that is very important. And you put a hat to the baby's head. Then by that also you prevent hypothermia. And apart from that, so transport, you use pre-warm incubators. So that's why you have to inform the NICU beforehand. So they can switch on it and they can warm it to keep the baby at the proper temperatures. And we use humidity. So by these measures, you are preventing babies' hypothermia. So those are the thermal ranges you will encounter. You can see the normal range, we all know, that is 36.5 to 37.5. So if it is deviating from that up to 36, we call stress. So that is a cause for concern. If it further go down, we call moderate hypothermia. So this is a danger. So you have to warm the baby immediately. But sometimes we get babies who are even less than 32 weeks, especially transferred from outside. If you don't maintain the temperature at the delivery site, then there is high risk of morbidity as well as mortality. So temperature is very important. Do all measures, as I mentioned before, to maintain the temperature. This is how you're going to collect the baby into a plastic bag. There are various types of bags practicing in worldwide. You can use plastic wraps like cling films or plastic bags. So it doesn't have to be sterile bag. We don't have the sterile bags at the moment in Sri Lanka, but we use the clean bag. You can use that yellow color bag we use in the hospital. or the grocery, the bags used in the supermarkets. So those bags can be used, and you put the bag up to the neck level. So oxygenation, that is very important. You fix the baby's the saturation probe onto the right hand, then you can get pre-ductal saturation. Why? The color, as I mentioned, it may be not very accurate. You can see that previous baby is very dark. So you cannot exactly say whether this baby's saturation is low. So hyperoxia, that also bad. So that is detrimental to many organs, that is at cellular and functional level. So if you have a saturation monitor, so you can titrate the oxygen level according to that. So this is how you fix the pulse oximeter, and you fix it onto the right pre-ductal saturation. So these are the saturation values, and if we have mentioned the 25th centile on right arm, so it takes 10 minutes to reach saturation of 90. So if you have the saturation probe, you should not panic. You know normal values, you can act on according to that. So the last message, it says, don't add oxygen if saturation is above 95. We know that saturation is normal, so no need of oxygen. So what are the harmful effects? It increases work of breathing, and it increases carbon dioxide production, create more free radicals, and which reduces cerebral blood flow as well. So no point of giving unnecessary oxygen. And even when you're doing the bag and mask ventilation, especially inflation breaths, we know these lungs are not fully developed. They are very fragile. If you give more and more high pressures, they cause damage. So this overinflation and their damage causing that, leading to inflammation and long-term morbidity. So this is the sequelae leading to chronic lung disease. So you should know what pressures you should apply. We should not panic. We should not give unnecessary high pressures. What is the lung protective ventilation you can do for a preterm baby? So if you have a CPAP device or the T-piece resuscitator, you can see the white color box with some meter devices, which is called the T-piece resuscitator. You can set that pressure, baseline pressure, for 5 to 8. We usually set at PEEP of 5. We call PEEP, PEEP for 5. And then if you give additional breaths, inflation, you set at 25. So you give PEEP of 5, PEEP of 25. So there you can control the pressures because you are the one setting up the pressures. But if you are using the ambu bag, you cannot control the pressure. So that is the disadvantage. But if you are resuscitating with ambu bag, you have to be gentle. Don't squeeze the ambu bag fully. Try to use it with 2 fingers rather than using your whole hand. So this is how they use the T-piece resuscitator. You can see the finger keeping at the top of this T-piece device, the blue color device, that gives rise the ventilation breath or the inflation breath additional pressure. So if you just keep that T-piece device on the baby's face, covering nose and mouth, and keep leaving that finger, not keeping at the top, then you are giving only the PEEP, that is the PEEP of 5 once you set it. So once your lungs are inflated, when you give the inflation, we know lungs get inflated. Then you maintain the ventilation with ventilatory breaths. That is the normal breath. So that is about 30 per minute. That is the normal resuscitation protocol, what we discussed since morning. So when you are doing this, you have to be careful, avoid excessive chest movement. So what is your task? You aim to keep your heart rate above 100. So this is how you can transport the baby with an incubator, ventilatory support, or a T-piece resuscitation. stops. We already discussed even on these previous lectures. What is this stops? S stand for sensorium, T temperature, O oxygenation, P stand for perfusion, and S for sugar. You transit into the PBU or during the stabilization period. If your baby is not improving, again, recheck those parameters. Probably one of these parameters are deranged. What is sensorium? How do you assess the sensorium in a preterm baby? Whether the baby is active. The sucking effect may be there. Tone, responsiveness, cry, movements. So this is how you assess the sensorium. And then activity. It could be normal tone, responsive, again, good cry, or look at the baby's movements, whether there are spontaneous movements. Lethargy means they are floppy. If you try to stimulate, if you try to handle the baby, very poor response. The cry may be poor. And activity, movements are less. So those babies we call lethargic. And temperature, we already discussed. It's important to maintain the temperature. And there are wet clothes maybe around the baby. So please discard these clothes and rewarm or apply new clothes. And when you're putting the baby into the bag, you are not supposed to wipe the baby. You just put the baby into the bag. So preterm babies, we are not doing wiping, especially babies less than 32 weeks and less than 1.5. Without wiping, you are going to put the baby into that polythene bag. So this is how you lose the temperature from the baby's body. There are various mechanisms. Radiation, if you keep the baby's head open, you can see. So there are a lot of temperatures you can lose from the baby's body. Convection, that's why you are warming the incubator. So try to prevent that. Evaporation, again, you are applying this bag. If the older one, you can clean the baby with warm towels. Conduction, you rewarming, avoid this conduction heat loss as well. So all these 4 measures you are addressing by taking appropriate measures. So you have to apply the cap, socks, gloves, and 2 layers of clothes when you go to the PBU. And oxygenation. So pulse oximeter is important. Look at the baby's respiratory distress. Recessions, grunting, respiratory rate, flaring of alveoli. So observe for respiratory distress. Perfusion. How do you check the perfusion? That is over the central, over the sternum. Seconds, we call prolonged. So in that situation, you might need to intervene for that. And heart rate, urine output, those things actually we are checking in the PBU. So sugar, so stops, sensorium, temperature, oxygenation, perfusion, the last sugar. So if your baby is lethargy, less active, look at this sugar as well. So if it is beyond the normal range, you have to act on that. Okay, so transport, we already discussed these parameters. Okay, so that concludes the lecture for the preterm. The important message, if it's a preterm baby, as a house officer, if you are working at Gyn and Ops unit, then inform the PBU, discuss with the senior about place for dexamethasone or the antenatal steroids and magnesium sulfate. And if mother is having pre-prom, consider giving antibiotics. And before they deliver, in advance, inform the PBU, reserve and PBU bed, get down the transport incubator and prepare the delivery suite appropriately and make sure all the measures for prevent hypothermia. Thank you very much. I would like to answer any questions if you have any other questions. Thank you.
Right. Thank you very much, madam, for that detailed lecture. So anyone having questions, we can take few minutes and answer questions if you all have. Right. You can use the chat box to answer, to type in any questions you are having. Right. Okay, if you all don't have any questions, thank you very much, Dr. Jitma Fonseca, consultant neurologist at TH Anuradhapura, for that comprehensive lecture. So we will break for lunch for half an hour. We will start at sharp 1:15. Right, thank you.
Now starting next lecture.
Right. I'm Dr. Dilani Dehigama, consultant neonatologist, teaching hospital Mahamodara. So during our next 30 minutes, we are going to talk about assessment of a sick baby and how we are going to proceed. So it's very easy to remember. We have a mnemonic called STOPS, and I will try to make it very simple for you. So this is regarding the rapid assessment and management of a sick neonate. So it's very important to identify a sick neonate from a well neonate. So you all are going to be with the neonates. So you will be the first contact. So, and it is essential to identify a sick from a well baby. So how we are going to do that? STOPS. So S stands for sensorium, T for temperature, O for oxygenation, P for perfusion, and S for sugars. And we'll take one by one and we'll discuss how we are going to proceed and how we are going to assess a ill baby. The first thing is a sensorium. So you need to assess whether these babies are active or in sleep, lethargic. How can you do that? So there are many observations and assessments that you need to do. So there are mainly 5 things that you can see. You can see how the baby is responsive to your handling, the tone of the baby. The tone, it can be vary from a preterm baby to term baby. So you need to handle the babies and appreciate the normal tone of a newborn baby. And how is the cry, whether these babies have a very poor cry, weak cry, or good cry, and how the movements are, whether this baby is having symmetrical movements or like less movements and lethargic, and about the sucking, whether this baby is having a good sucking or not. So those are the main 5 aspects that you can think of when assessing the baby's sensorium. And with this, you need to see, you need to make a judgment whether this baby is active or lethargic. So if you have any concern regarding a baby's activity or lethargy, you can't just have one assessment. You need to keep on assessing the baby frequently, sometimes half an hourly, until you confirm your clinical judgment. So active baby, what are the things? They have a normal tone, they are very responsive, they have a very good cry, and they have very good spontaneous movements as well. In comparison to that, lethargic baby, they are very floppy, they don't respond well, they have a very poor cry, their activity or the movements are not that great. So those are the babies who are lethargic. So we'll go through a small example. So this is, in this chart you can see, we have time. So this is 7 a.m., 7 p.m., 8 p.m., 9 p.m. And you are going to assess the baby hourly to check whether this baby is okay or not, right? And at 7, you assess the baby and baby is sleeping and you think that the baby is having like less activity, but the respiration and everything was good. And what you need to do is you need to keep on assessing the baby until you confirm your clinical judgment. But at 10 p.m. what had happened? Baby was very active, looking for feeds, movements are very good, and cry is very good. So that means baby had some sort of a period where the baby is not that active, but again afterwards baby was active, very good, and handling well. So these are the babies who are well. That means baby might be in a sleep, and in between baby is very active. But compared to that, in this chart shows at 7 p.m. you observe the baby. Baby is not that great, not having very good activity, floppy, not crying, not feeding well. But you kept on observing the baby. Throughout the period, the baby remains same. So these are the babies who are sick. So it is very important to differentiate babies from sleep from lethargy. So if you have concern more than 6 hours, definitely you need to evaluate the baby's vitals, because it could be sepsis, necrotizing enterocolitis, PTA, or else baby is very sick. Need urgent attention and treatment. So it is very important to observe and assess the baby continuously. But during your assessment, if the baby is like the same, less active, lethargy more than 24 hours, that means most probably this baby is may have severe brain injury, could be hypoxia-ischemic encephalopathy, intracranial hemorrhages, meningitis. So in that case, you need to consider further evaluation, further investigations such as lumbar puncture, for CSF analysis, imaging, and electrolytes, and so on. So this is very important to know, to identify a sick baby from a well baby. The second component is the temperature. First of all, we need to know what is the normal temperature of a baby. So that is 36.5 to 37.5 Celsius. Usually, well babies, they do have very warm hands and feet. So if you are concerned about the baby's temperature, what you can do is you can use your dorsum of your hands to touch the abdomen or the peripheries of the baby. If you still have concern about the baby's temperature, you need to check the temperature from a thermometer. Usually we take the axillary temperature. If the baby's temperature is less than 36.5, that means baby is hypothermic and need to assess the reason for the hypothermia. Right. Why it is important to prevent hypothermia? Because it can lead to many problems such as hypoxemia, metabolic acidosis, hypoglycemia, asphyxia. So this indicates a ill baby. And this is how you touch from your dorsum of your hand to feel the temperature of the baby. So what are the things that we can do if the temperature is low? So usually the room temperature should be at 36 to 38 Celsius. For that, we can use a room thermometer. And babies are high risk of having hypothermia if they have wet clothes and cold environment. So if the baby's clothes are wet, need to change it quickly and dress them. Clothe the baby well. So those are the initial things that we need to consider if the baby is otherwise okay. And when we are clothing the baby, to maintain the temperature, it is very important to have the caps, socks, mittens, and also 2 layers of clothes. So this picture shows a very tiny preterm baby with a hat, socks, and clothes. And if the baby is hypothermic, you need to assess after 15 minutes. After doing initial measures to prevent hypothermia. So active rewarming. Active rewarming. What does it mean? So if the baby is hypothermic, we need to rewarm to maintain the babies in normal temperature. For that, we have a good method called Kangaroo mother care. So I'm not going to go into detail in that because you have a separate lecture on that. The other thing is we have the radiant warmer. So this is the machine of the radiant warmer. You can see these radiant warmers in the neonatal intensive care units, labor rooms, theaters, because all the babies are we keep it here after birth or during our resuscitation. And after reassessment, so if the baby is hypothermic, we have done the clothing and everything, and we did the temperature check. Still, baby is hypothermic. What we have done was we put the baby under the radiant warmer. So we'll see what's happening next, right? So this is a radiant warmer. You can see. So there is a bar to indicate the heat output, right? Like this, right? If the baby is hypothermic, if you put the machine into the servo mode, the machine will increase the temperature automatically to maintain the baby's temperature. There are 3 modes actually: pre-warm, servo mode, and the manual mode. Usually we put the baby in the servo mode. And we set the normal temperature for the baby to the machine. So machine will adjust the heat output according to the baby's temperature. So what's happening? So baby is under the radiant warmer now, but heat output is now 100%. So all full bar is there, all 4. But still the baby is hypothermic. That means even though we try to make them warm, baby is still hypothermic. So we'll go to our chart again. So at 11 p.m., at 11 p.m. baby is warm and heat output is 0. So baby doesn't need much temperature to maintain the baby's normal temperature. At midnight, again baby's peripheries are warm and 25% of heat output. And there's no much heat output here to maintain the normal warm peripheries of the baby. So that means the baby is well and baby doesn't have any problem with regulating the temperature. What will happen in a sick baby? So at 11 p.m., baby's peripheries are warm. Heat output is 25%. But at midnight, you feel the baby's peripheries are cold and heat output increased up to 50%. At 1 a.m., again the baby's peripheries are cold and heat output further gone up. So that means during this period, baby remains to be cold and the heat output is constantly increased. So that means the baby is not doing well and baby needs urgent attention and stabilization. So if the baby is still cold, we need to evaluate the perfusion, we need to consider sepsis, need to start IV antibiotics and assess other parameters of the baby and need stabilization. The third component is the oxygenation. So before talking about the oxygenation, we need to know what is the normal saturation of a baby. So the normal saturation in a term baby, if it is more than 95, we are okay. In a preterm baby, saturation in between 90 to 94 is okay. So we need to know what is the normal saturation of a baby. And again, apart from that, we need to assess the respiratory status of the baby, whether this baby is in respiratory distress or not. What are the parameters that we need to assess? Respiratory rate, we all know. Well, we usually count for the respiratory rate. If the respiratory rate is more than 60, we call it as tachypnea, right? And apart from that, you need to assess subcostal recessions, intercostal recessions, grunting, flaring of LNSI, and saturation. So you have mainly 5 components to assess the respiratory distress of the baby. And when you are monitoring the saturation, you need to know about your saturation monitor as well. So before concluding this baby is having hypoxia or normal saturation, you need to know, you need to go and see what is this wave pattern. So this wave pattern should appear on the monitor before you conclude that this baby's hypoxic saturation is low or not. And also this heart rate should be tallied to the baby's heart rate. If this heart rate is 56, and if you don't have a good waveform from here, and if your saturation is 60%, that means your reading is not that accurate. You need to adjust the probe and see whether and try to get a good reading. And if the baby's saturation is low, what you have to do is you need to start with supplementary oxygen. And again, apart from that, you need to assess the respiratory distress of the baby. Sometimes babies need pressure to improve the saturation and also keep their alveoli open. For that, we can use a CPAP. So we have the delivery room CPAP as well. We usually call it as NeoPuff, or the machine that we are using for the resuscitation, but that is for a short duration of time. But if the baby is having significant respiratory distress, you need to admit to the baby to the neonatal intensive care unit for a CPAP. So from the CPAP, we increase the baseline pressure of the baby's lungs, and usually we start at the pressure of 5 to 6 centimeters of water. And even though we start with the CPAP, we need to continuously monitor the baby for the respiratory distress and the saturation, and also need to confirm the status of the lungs with the chest X-ray. If the baby is having persistent severe respiratory distress, if the oxygen requirement is going up, we might think of increasing a little bit. And failing, if the baby is continuing to have a significant respiratory distress and high oxygen requirement, we need to escalate the respiratory support to a non-invasive mode of ventilation as well. And if the baby is quite stable on the CPAP, oxygenation is okay, and the chest X-ray shows hyperinflation, we can even reduce the PEEP that we are giving through the CPAP. So after putting the baby onto the CPAP, you need to continuously monitor the baby's respiratory status. One thing, baby might need further escalation of the treatment, and sometimes if the baby is stable, you can bring down the pressures that you are giving also. The other component is the perfusion. So before going into detail, you need to know what is the normal perfusion and the poor perfusion. To assess the perfusion, there are so many parameters that we can check. These are the capillary refill time, heart rate, urine output, non-invasive blood pressure, and also activity and the peripheries of the baby. So we'll take one by one. We all know how to check the capillary refill time. Usually check the capillary refill time over the sternum or the forehead, and we have to count for 5 seconds. Usually we count for 1 in 1000, 2 in 1000, 3 in 1000, and you see the refilling time. If it is less than 3, that means if it is less than 1 in 1000, 2 in 1000, 3 in 1000, that means less than 3 seconds, that is normal for a neonate. Then heart rate. When we consider heart rate, first thing you need to know what is the baseline heart rate of that particular baby. They can have bradycardia or tachycardia. In a term baby, if the heart rate is more than 160, that is not normal. In a preterm baby, if the heart rate is more than 180, that is not normal. And if the heart rate is less than 100, we call it call it as bradycardia. Again, you need to know about what was the baseline heart rate of the baby. If the baby's baseline heart rate was around 120, all of a sudden, if it is go to 170, that means some problem is there. So you need to assess, right? Again, on the other hand, if the baby's heart rate is around 160s and if it is now like gradually coming down to 110, again, that is also not normal. Always know about the baseline heart rate of that baby. So the rising heart rate, what could be the reason? It can be due to hypovolemia or could be due to fluid overload, opening of the ductus and intraventricular hemorrhages, and there are so many other things. And bradycardia, low heart rate, it could be due to drugs, it could be due to apnea, electrolyte imbalances and acid-base imbalances. So if the heart rate is fluctuating or like tachycardic or bradycardic, you need to evaluate the cause and treat the underlying cause and stabilize the baby. And we'll go back to our example. So at 1 p.m., baby's capillary fill time is 2 and the heart rate is 134. But at 1 a.m., the capillary fill time is 3 and the heart rate is 148 and slightly gone up. At 2 a.m., it is capillary fill time is 4 and heart rate is 144. At 4 a.m., the capillary fill time 4 and the heart rate is now further gone up to 168. That means baby is having some sort of a problem, right? And what are the other things that you need to consider when you are assessing the perfusion? Blood pressure monitoring. Usually in most of the centers, we do non-invasive blood pressure monitoring. In acute setup, very critically ill babies, we do the invasive blood pressure monitoring also. But if you are using the non-invasive blood pressure monitoring, it is important to know about the appropriate application, appropriate cuff size, and when you are interpreting what are the blood pressures for a specific gestation. So these are the machines that you have in your units, and these are the different sizes of blood pressure cuff. So if you use a smaller one for a bigger baby and on the other hand a smaller one for a bigger one for a smaller baby, your measurement will be not accurate. So how can you correctly get the size? So you can see in this picture. So we concern about the bladder which is inside the cuff, right? So it should almost all, at least 80% should be covered around the baby's arm, and also it should be more than 40% of the upper arm length. So this is the correct size of a blood pressure cuff for a newborn. So blood pressure, this is a rough value. We know the adults, it is 122 and diastolic is 80. In a term baby, it varies. Commenting on the blood pressure, you need to know your systolic blood pressure, diastolic blood pressure, also above is normal for that baby. So when we consider the blood pressure, you need to check, you need to see systolic, diastolic and map also. So what will happen in shock? In early shock, systolic blood pressure will high, and in established shock, both systolic and the diastolic blood pressure will be low. So it is very important to get an accurate measurement to treat the hypertension of a baby. And the other component is the urine output. So usually babies, if they pass 1 ml per kg per hour urine, that is normal for that baby. To measure the urine output, we usually don't do the catheterization unless it is really indicated, and we do the weighing of the pampers or the nappies of the babies to check the urine output. So we'll go back to our example. So at 11 p.m., the baby's perfusion, we are happy, capital refill time 2 and heart rate 134. And at that time, you check the urine, baby had 10 ml of urine. But here at 2 a.m., baby's capital refill time was 4 and heart rate was 144. And at 3 a.m., baby's capital refill time was 4 and the heart rate is further increased compared to the baseline, that is 156. But the baby passed urine, 10 ml of urine. So how we are going to calculate the urine output for this baby? So if you consider 11 a.m. to 11 p.m. to 3 a.m., you have 4 hours. For the 4 hours, baby passed 10 ml of urine, right? So that means per hour, baby passed 2.5 ml per hour urine. Usually, we calculate it for ml per kg per hour. So in 4 hours, you have 10 ml, that means 2.5 ml per hour. If the baby's weight is 2.5 kilos, we have to divide this 2.5 from the 2.5 and it comes to 1 ml per kg per hour. So this 11 p.m. to 3 a.m. baby had 1 ml per kg per hour urine out, right? We'll further go down. So now the thing is at 3 a.m., 4 a.m., capital refill time is 4 and the heart rate is 168, which is not normal for that baby. And because of the poor perfusion, we have decided to give a normal saline fluid bolus. So at 4 a.m., we have given a fluid bolus and we have assessed the baby. Next hour, the capital refill time now 3 seconds. Heart rate gone down to 156. And at 6 and 5:30 again, in half an hour, we have assessed the baby because we have done some intervention. And at 6 a.m., the capital refill time 2 and the heart rate is 148. And at that time, we have checked the urine output and baby passed 20 ml of urine. That means if you calculate for the same baby, it comes to 2 ml per kg per hour. So if the baby is having poor perfusion, we usually give a normal saline fluid bolus, 10 ml per kg over 30 minutes. And afterwards, we need to keep on monitoring the baby, whether this baby, how is this baby's perfusion. If the baby remain to be having poor perfusion, we need to think of whether we are giving a fluid bolus or whether we go for an iron probes. We have several iron probes. Depending on the underlying cause, we can choose the correct iron probe for that baby. And the last component is the sugar, blood sugar. We all know we can check with the glucometer. In our guideline, if the blood sugar is less than 45 milligram per deciliter, we call it as hypoglycemia. If we have a hypoglycemic baby, first you need to examine the baby first. Assess whether this baby is symptomatic or not. If the baby is well, active, no symptoms, feed the baby first and you can do a pre-feed blood sugar and assess how the blood sugar is. And if the baby is symptomatic, if the baby is lethargic, poor respiration, convulsions, jittery, you need to start IV fluids for this group and monitor the blood sugars. So that is regarding the STOPS, rapid assessment of a newborn. In summary, what are the worrying points? If the baby is continuing to be lethargic more than 4 to 6 hours, yes, it is alarming. You need to assess the baby's vitals. Look for the underlying cause and treat accordingly. And if the baby is hypothermic, despite increased heater output in the radiant former, again, that is alarming. You need to stabilize the baby and assess the baby's respiratory distress, whether the baby is having respiratory distress with oxygen requirement. If the baby's oxygen requirement is increasing to maintain the normal saturation, that is also very worrying. You need to stabilize that baby quickly. Again, for the perfusion, you have several parameters that you can assess. You need to evaluate all these parameters and come and make the decision whether this baby is having good perfusion or poor perfusion. And at the same time, blood sugar is very important in a sick baby to check whether this baby is having the normal glycemia, hypoglycemia, or hyperglycemia. So these things are very important when you're assessing a sick baby from a well baby. Thank you.
Hello, this is Dr. Nimesha. Can I start the presentation? Or are we waiting for questions? Hello? Hello?
Can hear, madam.
Okay, can I start the presentation or are we waiting for questions?
Start now, madam.
Okay, right, okay. So good afternoon, everyone. So during the next 30 minutes, I'll be talking about hypoxic ischemic encephalopathy of the newborn, followed by identifying and managing neonatal seizures. So hypoxic ischemic encephalopathy in a newborn is a heterogeneous disorder and it's a clinically defined syndrome. And this is characterized by disturbed neurologic function of the newborn in the earliest days of life, that is the first couple of days life. In an infant born at or beyond 35 weeks of gestation. So we are not talking about preterm, very preterm, as well as extreme preterm infants in this situation. So this is manifested by features of encephalopathy. So that means disturbed neurologic function of the newborn. So this baby is present to you as reduced level of consciousness, maybe having seizures. They could often have difficulty in initiating and maintaining respiration and depressed tone and reflexes. What are the etiology? It could be maternal, it could be uteroplacental, it could be fetal. So mothers with an acute event leading to hypovolemia, hypotension, cardiac arrest, or severe hypoxemia. This leads to reduction in the uteroplacental circulation, leading to fetal hypoxia and ischemia. There can be some events happening in the uteroplacental circulation. Best example is your placental abruption, uterine rupture, and also with cord prolapse. And also if you use oxytoxic agents, which causes hyperstimulation of the uterus, that can also impair the circulation to the baby, leading to hypoxia and ischemia of this fetus. And also fetuses can also have fetal maternal hemorrhage. Again, this could be due to placental abruption and also fetal sepsis, which can lead to hypoxic ischemic encephalopathy. So what happens when there is a sudden hypoxia and ischemia. So remember, hypoxia means reduced oxygen level in the brain. Ischemia means reduction in the blood flow. So there immediately, within minutes, there is a primary energy failure. So there is a reduction in the cerebral blood flow, which leads to reduction in the glucose metabolism that happens in the brain, leading to cell death. This happens in minutes. We cannot do anything about this. And then the newborn brain goes into a latent phase where there is reperfusion. So the inflammation starts here. So this happens from 1 to 6 hours after birth. So this is where we are trying to modulate now with our management to avoid the damage caused by this latent phase activity of reperfusion. This is where we are aiming to manage the baby very well, aiming to reduce the damage caused by this primary energy failure. And then there's a secondary energy failure due to secondary mitochondrial failure, which can happen during 6 to 15 hours of life. So that is why this 1 to 6 hours after the acute insult, so that is birth asphyxia is the acute insult, and the initial 6 hours is very important for us. We have to make sure we are managing the baby properly so that we are avoiding further injury to the brain. So how would you identify that this baby, a baby is having features of HIE? We are actually looking at features of encephalopathy. So when you hear the term encephalopathy, if you picture an adult with encephalopathy, you can imagine, okay, this adult is in altered state of conscious level. This adult might not be answering the questions properly, not rational. Maybe there are changes in the tone. Some adults could even develop seizures. So the pictures is not very much different, although there are subtle changes. So in the delivery room, these newborns with encephalopathy, they usually, with hypoxic ischemic encephalopathy, they usually need resuscitation. So they are born depressed at birth. So we all know that at birth, we keep on assessing their color, tone, breathing, and heart rate. So they are depressed at birth. They don't start breathing spontaneously. They can be apneic or taking irregular gasping like breaths. Their color is blue or pale. They are floppy. They are not moving their limbs well even at birth. So they usually need resuscitation. Even in the postnatal period, they show you features of encephalopathy. So like similar to an adult, they will show altered level of consciousness. So usually we know even newborns, soon after birth, they are very alert. Normal newborns are very alert. They are active. They are looking for a feed. They are having neonatal reflexes like the rootling reflex, sucking reflex, grasping reflex. These things are not there. So they look very lazy, very lethargic. They are not responsive when you handle. You won't be seeing much of spontaneous movements. They look very floppy, poor tone, with abnormal posturing could also be there. They might not be able to suck well from the mother. They could have respiratory problems, especially reduction in the ventilation, reduction in the respiratory effort. So you check the primitive reflexes, mainly the Morose reflex and the sucking reflex, which could be absent. Some of these babies could have seizure activity as well. We'll look at the seizure types later in this presentation. So that is how you recognize, okay, this baby could be having HIE or hypoxic ischemic encephalopathy. And depending on the picture, you divide them into mild, moderate, and severe. So it is important for us to know. You see, mild degree of babies are hyperalert. They don't need ventilator support. They might have little feeding problems. They're jittery, but they don't have seizures. However, but luckily, they don't develop much complications later on. But in stage 2 and 3, they're lethargic. They generally need some support with the ventilation, they have feeding problems and their tone is quite abnormal, they can develop seizures and they are at very high risk of neuro disability. So therefore, it's very important to recognize babies who need active management following resuscitation. So if you attend any delivery where you had to resuscitate a baby, it is your and your immediate senior's responsibility to keep on monitoring these babies to looking for features of encephalopathy. So you can see those babies, so poor condition at birth, those who had seizures, those who had abnormal neurologic examination, or those who have a sentinel event, an acute event like a cord prolapse, meconium, all these, or low abgascos, they all need continuous assessment related to these criteria, to looking at their activity level, conscious level, state of their primitive reflexes at least 2 hourly, and document it in the clinical records to make sure that they are not developing these severe degrees of HIE. If there are any concerns, then you have to discuss with your consultants to see whether this baby needs admission to the NICU for further management of hypoxic ischemic encephalopathy. So there are specific criteria for cooling. You don't have to remember, but just remember, we look at look at 2 sets of criteria A and criteria B. In criteria A, we look at the evidence for hypoxia ischemia, and in criteria B, we look at encephalopathy features. So if you had to resuscitate a baby with abgas score less than 5 at 10 minutes, you are going to ask from your seniors whether there's a need for cooling in this baby, hence admission to NICU. If you had to resuscitate at 10 minutes, you are going to ask that question again. And then it's up to the seniors to decide whether this baby needs cooling or not. Definitely not your decision. But just remember, these are the things you are going to assess, whether there are features of encephalopathy, altered state, abnormal tone, abnormal primitive reflexes, or presence of seizures. So it's very important to document whether these things are present or absent in your notes. Right. Quickly looking at the complications of HIE. So we know that they can develop seizures. So not only it's the brain which is going to affect, you see, this hypoxia ischemia is going to affect rest of the body as well. So if the kidneys get hypoxic and ischemic, you are going to get acute kidney injury. This is important for us because we have to avoid further nephrotoxicity in this baby because we are going to use medications. They can develop coagulopathy. They can develop disseminated intravascular coagulation, PPHN, ischemia of the liver, bone marrow suppression leading to anemia, especially low platelets, and a lot of metabolic abnormalities, including low or high blood sugar. So the management, there are a lot of assessments that we do after the child is being admitted to the NICU. The specific management, of course, is cooling for 72 hours. The criteria we have looked at, you don't have to remember. And then we specifically look at the management of fluids, nutrition, and also providing antibiotic support, avoiding nephrotoxic medications like gentamicin. They might need cardiovascular support and also management of coagulopathy. Now, that is not where your involvement is needed. So your main involvement is needed to do the basic newborn resuscitation, calling for help when that is necessary, and in the babies whom you take to the postnatal ward to every 2 hourly until finishing 6 hours to assess and document the status of neurological status, the alertness, the activity, the primitive reflexes, and the tone of the baby. That is what is expected from you in the initial period. You won't be expected to manage this baby in the NICU setup. However, when it comes to long-term complications and management, again, your involvement and knowledge is important because you will be in our team who will be monitoring these babies in the clinic, in the pediatric or the neonatal or well baby clinic. So we need to know what long-term complications these babies can develop. So they can develop cerebral palsy, they can develop epilepsy, corticovisual blindness, sensorineural hearing loss, learning disability, and many behavioral issues. Therefore, when the baby has had or completed the management in the SCBU and now being transferred to you, back to you into the postnatal ward, it is your responsibility to ensure that these babies are properly followed up. So you need to talk to the MDT unit and get a date reserved, and also arrange the physiotherapy, occupation therapy, and the speech therapy, even while the baby is in the postnatal ward itself. Monitoring the growth is very important, and development, and also arranging hearing and vision screening for these babies is extremely important. Okay. So moving on to newborn seizures, again, this is a very common and an important problem that we see in newborns. So before we go into discuss about seizures, I want you to see one of the videos so that you can get a better idea. I hope you can see my screen. Can you? Can you see my screen?
Yes, madam.
Yes, I have taken this from the YouTube. This I'm using for education purposes only. So you can see this baby is having what you call lip smacking. Okay, so if you look at this the mouth, it is very important to note that this is abnormal lip smacking movements that this baby is having. Yeah. We have seen this type of subtle seizures. These are called subtle seizures being missed by doctors, midwives, nurses, until a senior is coming. So it's dangerous to miss this type of a seizure because we need to do early intervention for this type of babies. So these are very subtle seizures. Okay. Now I'm moving on to the next video. So what happened? Oops. Just went into the next one. We are going to see another video now. Now this baby is just keeping a tonic posture. See, this baby is not responding. The baby is looking at one side only. See, even though we are okay. See the eyes. So the baby is not responsive. People are touching, people are moving the limbs, but the baby is not doing anything. It's just keeping this arm in a very static position without even moving. Okay, so this is a tonic seizure in this baby. Okay, right, I'm going back to the presentation. So it's very important to recognize that these newborn seizures can sometimes be very subtle, and therefore the tendency for you to miss is very high. So it's very important to have a very low threshold to look at these babies and get seniors' opinion. Okay, so we can identify several types of newborn seizures. The subtle seizure is the one I have shown you initially, which could be lip smacking, abnormal lip smacking, repetitive blinking. Some babies will show you cycling-like movements of limbs. They are abnormal. Those who are having clonic movements can have slow, rhythmic, and repetitive jerks of limbs, face, or trunk. And in the second video, you saw a tonic, sort of sustained asymmetric posturing of the trunk with deviation of eyes and the head that you saw, the tonic one. And some babies would have more clonic or repetitive jerks. So sometimes some mothers will come to you saying there are abnormal movements that I see in my newborn. Can you see whether this is abnormal? So because there are a lot of other mimics of seizures that you see in newborns. Sometimes difficult to differentiate from seizures. So what are the clues for you to say some type of movement is normal and physiological, whereas the others are abnormal and could be seizures? So one such mimic is the jitteriness. So you can see babies getting jittery when they are exposed to cold, when they become hypoglycemic, and some babies of mothers who are taking, antidepressive medications and all that. So this jitteriness type of movement, when you touch the limb, actually the baby stops the jittering. So that's an important marker to differentiate between seizures and jitteriness. And also when you look at the baby, you see the baby is responsive, not like those babies you've seen before who is not responding for your stimulation. And if the baby is already attached to a cardiac monitor, as you have seen in the video, they showed that there are changes in the heart rate, there are changes in the saturation that you see associated with seizures and not with normal movements like jitteriness. The other movement sometimes the babies which gets confused with seizures is the sleep myoclonus. The sleep myoclonus is a brief jerk that occurs only during sleep in an otherwise healthy baby. So these babies, they never do it in the awake state. So those are the two types which are important to realize. So if you see such abnormal movements, always get the mother to record it. Then, and they are not in your phone, of course, get the mother to record it, the abnormal movement, and then you can even refer this with her permission. You can send this to your seniors or show it to your seniors and get opinion related to further management. So why do they develop seizures? So there could be a lot of causes why they develop seizures. Commonly, they can develop seizures due to metabolic and electrolyte derangements such as hypoglycemia. You listened to the lecture just a couple of minutes ago. Changes in the electrolytes like hyponatremia, hypocalcemia, and hypomagnesemia. You can see that babies born to diabetic mothers, they could be at high risk of developing seizures because all these things could happen in those type of babies. And those with infections leading to meningitis, encephalitis can get seizures as well. And as we discussed before, those with birth asphyxia, hypoxic ischemic encephalopathy, they also can develop seizures. And then those rarely, the babies can also develop hemorrhage, and even rarely some infarction of the brain, and also drug withdrawal is also something you need to concern these days. We see a lot of patients, mothers who have been using substances during pregnancy, and when they get admitted, the baby develops withdrawal symptoms. So one such withdrawal symptom could be neonatal seizures. And one other thing that I want to bring your attention is the acute bilirubin encephalopathy in severe decrease of jaundice, which is not managed well or poorly managed, or sometimes due to severe hemolysis, extremely high bilirubin levels, can also lead to newborn seizures. And there are some rare syndromes involved with newborn seizures as well. Okay. Whatever the cause, for the seizure, there is an algorithm that we follow when we are thinking about management for newborn seizures. So the main thing you can say is the most important thing is actually identification of these seizures, because most of the time what I feel is these seizures get outlooked and not recognized properly by the postnatal staff. So that's very important that you pick them up at the correct time. Right. So what do you do if you think the baby is having seizure? You ensure the airway is patent. You make sure baby can breathe well and has got a good circulation. You can keep the baby in the left lateral position, and first of all check a capillary blood sugar. If the sugar is less than 45, you need to give a bolus of 10% dextrose quickly via a peripheral cannula. And when you insert any seizures, baby with seizures, you need to have a cannula. So when you insert the cannula, send investigations, including electrolytes, a partial septic screening, including a blood culture. A gas, a venous blood gas, is also very handy and can give you a lot of information. And then if the seizure is persisting for more than 3 minutes, or you see more than 2 seizures within 20 minutes, then this baby needs treatment with anti-epileptic medication. Now, the first line anti-epileptic medication that we use in newborns is phenobarbital. So you can give 20 milligrams per kg of phenobarbital for the newborn. 2 things you need to remember when you are giving phenobarbital to a newborn. First of all, the reason is that phenobarbital can cause respiratory depression in newborns. similar to the kids, to the children. So therefore, it's extremely important that you keep the resuscitation equipment ready by your side. The ambu bag should be ready and working with oxygen attached with a proper size mask, or the neopuff should be ready. In case the baby stops breathing, you need to immediately start ambu ventilation for this baby. That's very important. And the other thing is this has to be given as a slow infusion over 20 minutes. That is again to avoid the respiratory depression happening. So these 2 points extremely important. Remember, you should never give it as a bolus, or you should never order the nursing officers, okay, please give this phenobarbital and then attend to another thing. You have to stay with the child. You have to stay with the baby until the phenobarbital is gone. And it's always better to discuss with your seniors and get the baby transferred to a newborn unit following that. And then if the seizures persist, you can always repeat the phenobarbital 10 milligrams per kg, and you can again repeat the same dose. And then there are a lot of alternative medications if the seizures are continuing, like levetiracetam, phenytoin, and midazolam. Okay, anyway, at that stage, the baby should be in the newborn unit, in the neonatal ICU care unit with experienced staff rather than in the postnatal unit. Yeah. So at your point, the most important thing is the identification, communication with your seniors, and starting checking the blood sugar and making sure that the baby is stable. And especially if you are to give a phenobarbital, to do it in a safe way. So those with neonatal seizures also, they are at very high risk of developing neurodevelopmental problems and epilepsy in a later part of their lives in the childhood. Therefore, these babies also needs to be followed up in your unit in the clinic for at least they complete 2 years, and they also needs to be followed up hand in hand with that MDT team. Okay, any questions? Any questions? You can put questions into the chat group even. Okay. All right, in the absence of questions, let me finish. So there's one. What type of seizures do newborns born to mothers? Yeah, they can develop any type of seizures. They can even develop excessive jitteriness. They can develop any type of seizure. There's no specific type. Okay. So I think my time is up. Yeah, 2:50. So thank you. Is there another question? Okay, right. Thanks.
Good afternoon, everyone. Can you all hear me?
Yes, madam, I can hear you.
Yeah. Right. So, so this is, I think, this is the last lecture of the program. Actually, not the least though. Again, I'm going to talk about two neonatal conditions. They are also very important. One thing is neonatal sepsis. You know that the neonatal sepsis is the third cause of neonatal mortality in Sri Lanka as well as in other part of the world, and it's still the same, and it takes a huge chunk out of the neonatal mortality rate. So it's a very important thing because one thing is it is treatable and it is preventable. So there are few definitions you must know. One thing is early onset sepsis, which is the sepsis in neonates from birth to 72 hours of age. Late onset sepsis is from 72 hours to 30 days of age. Nowadays, of course, the early onset sepsis is less because of this intrapartum antibiotics given to the mother and the very hygienic deliveries happening in hospitals. But on the other hand, late onset sepsis is on the rise, especially because there's increased survival and long-term hospital stay of especially of preterm babies. So they are being subjected to a lot of interventions and handling, and also later onset sepsis is on the rise. Just to get some idea about the causes for the risk factors for the early onset sepsis, because when you're seeing a baby with sepsis, you have to find out these factors from the mother's history, whether the mother has had chorioamnionitis, whether there was a PROM, and PROM is prolonged rupture of membrane, usually more than 18 hours in term babies and more than 24 hours in preterm babies. And whether the mother had maternal pyrexia, whether it was a preterm delivery, whether there had been multiple vaginal examinations, or was it an instrumental delivery, vacuum or forceps, or whether there was an evidence of maternal group B streptococcal colonization. And sometimes mothers can have UTI-like infections also, which can cause early onset sepsis in neonates. So on the other hand, what are the risk factors in newborn? Mainly prematurely low birth weight, fetal distress, and low ABGA needing resuscitation at birth, and multiple pregnancies. They are the risk factors mainly for the early onset sepsis. Late onset sepsis, we must concentrate more on the late onset sepsis, and these are the risk factors that we can find out. Whether there had been very invasive procedures. The babies are subjected to invasive procedures like frequent blood sampling, intubation, mechanical ventilation, and central venous catheters or peripheral venous accesses, or urinary catheterization like interventions. Or it can even be long-term use of total parenteral nutrition and reduced breastfeeding, frequent use of H2 receptor blockers, or any surgical interventions, and iron treatments during subclinical sepsis. That is also a risk factor to have late onset sepsis. And the other most dangerous thing or the important thing is that unnecessary use of antibiotics, because they are especially prone for fungal sepsis. And milk aspiration can also lead to late onset sepsis. But most of all, like more than anything, the common source is the hand contamination of healthcare personnel. So it is mainly us who give the infection to the babies as late onset sepsis. The causative organisms for early onset sepsis is mainly from the mother or maternal flora, or if the mother has had chorioamnionitis. And the infection can even cross the intact membranes, and it can be during or before labor, or it could even be transplacental. So most common ones are group B streptococcus infection, E. coli, and Listeria monocytogenes, especially in preterm babies with meconium passage. And there can be other organisms as well. For the late onset sepsis, the positive organisms are these. It's mainly hospital or community acquired, and mainly the staph, like coagulase negative staphs or MRSA, MSSA, some gram negative ones, fungal infections, or even viral infections can cause late onset sepsis in newborns. The clinical findings, very important, because you have to identify the sepsis as early as possible, because you need prompt treatment to prevent they from dying. So the problem is that most of those features are subclinical or non-specific, like lethargy, poor sucking, fever, mild fever, and the baby is not right. But still you have to have a very high index of suspicion, and until proven otherwise, think that this is sepsis. Those are the subclinical or non-specific cases. If it is very severe, which is very obvious, so it is the systemic, usually the systemic disease with multi-system involvement, like septicemia, or it can be even focal, severe focal infections, like pneumonia involving the lungs, umbilical sepsis, let me see whether I can can't find the there's a point. It's okay. Osteomyelitis or septic arthritis or necrotizing enterocolitis, they are local infections, but it can lead to systemic infection and cause septicemia and meningitis or even septic shock. Apart from those, the subtle clinical findings, any other system can be affected. So you will get the clinical findings involving respiratory system or cardiovascular system, GIT, central nervous system, skin, or in many metabolic derangements. So, but mind you that the highlighted ones, they are very like non-specific. It says something not right, like so undue tachycardia. Either hypothermia or hyperthermia, either fever or cold peripheries, or increased lactate levels in blood gases, or derangements in blood sugar levels, hypo or hyperglycemia. Those are like you can't assign those things to a particular disease as such. But when you find those things, just think whether could this be because of the sepsis. So have a very high index of suspicion. So you take a relevant history from the mother about the antenatal period, natal and postnatal period, and find if you can find definitive signs, that's fine. Or look for soft signs and diagnose the sepsis as early as possible. Then you go for the investigations. The baseline ones are blood culture, full blood count and blood picture, CRP and procalcitonin if available, and take swabs from ear, groin, and axilla. And then, depending on the symptoms, you may go for the nasopharyngeal aspirate or endotracheal tube culture if the patient is being intubated, and take swabs from any other sites showing inflammation. So those are the baseline ones. Then you may go for the optional ones like urine culture, chest X-ray, ultrasound, and lump puncture, depending on the site of infection. Then out of those infections, like you have to be a little careful about these tips. Blood culture, when you take the blood culture, if the blood culture is positive, it is diagnostic. But if it had been taken properly without contamination, there is a way of taking blood culture, and if it has been done by the staff, then it is diagnostic, obviously along with the clinical features. But the negative culture does not rule out sepsis, because it all depends on how you the technique of taking it and the amount of blood you have taken. So negative does not rule out sepsis. Some people do take tracheal aspirate, but there is high chance of colonization in tracheal aspirate, so you can't rely on the tracheal aspirate. In WBC, usually WBC levels are very high in neonates. It can even be 20 up to 25,000, which is normal sometimes, most of the time. But the other way, the leukopenia or neutropenia, they are more suggestive of sepsis, especially during the first 48 hours, and also the thrombocytopenia. So look carefully the WBC and full blood count. CRP, again, you know that it takes about 10 to 12 hours to reach the measurable levels. So negative result today doesn't mean that there's no infection, because tomorrow you may get a very high CRP. So that's why you need serial CRPs. You should have at least two CRPs at least 24 hours to say it is negative. And at the same time, there can be false positive in CRPs, especially with euconium aspiration. Procalcitonin, on the other hand, is more sensitive. It rises rapidly about 2 to 4 hours after exposure. and it's a better marker for early diagnosis of neonatal sepsis. But the problem is that the availability and the cost. Right, now you have taken investigations and you analyze those things and you are going for the treatment. So treatment is with antibiotics, right? The first thing is to tell is not to start antibiotics if there is no septic background. If there's no history, don't start antibiotics saying it's prophylactically. Right? Empirically means that with some suspicion, you start antibiotics. Definitive means that when there is a clinical and a microbiological evidence present, you start antibiotics. So indiscriminate use of antibiotics leads to resistance, that you know, and it's a huge problem globally. So for the empirical antibiotics for the early onset sepsis, the first line ones are penicillin, ampicillin with gentamicin, right? That is enough for the empirical cover. If you are suspecting a gram-negative meningitis, cefotaxime can be started as the first line. But don't use cefotaxime unnecessarily as the first line because there's high risk of invasive and resistant candidiasis with that. So always try to start very mild antibiotics and then escalate according to the response. Escalate or de-escalate. The second line ones are usually the cefotaxime and flucloxacillin with or without an aminoglycoside. The third line ones are usually the empirical ones are the very high-5 antibiotics like meropenem, vancomycin, piptaz, and even can be even antifungus like fluconazole. That is for the empirical third line. But always, if you are going for the definitive treatment, always go by the clinical features and the ABSG pattern of the blood culture or the cultures. And very important thing is by the microbiological input. Always discuss with the microbiologist when you are starting antibiotics or changing antibiotics, and it is very easy to manage thereafter. So the duration of antibiotics also depends. If there's clinical sepsis, I mean there's suspicion of sepsis, you can give 7 to 10 days of antibiotics depending on the response. And if the blood culture is positive, of course you treat for 14 days. And if there's meningitis with the group B streptococcus infection, 14 days is enough. But for the gram-negative sepsis, you need 21 days of antibiotics. If you're just suspecting sepsis, then you give antibiotics till negative blood culture for 48 hours. When you get the blood culture negative, after 48 hours, you can stop antibiotics. The other supportive cares are minimal handling. Don't handle the neonates so much, because you will introduce more infections. So optimal thermal care, respiratory support if they need it, and metabolic stability, cardiovascular stability. Then optimal nutrition during that time, and hematological correction with blood products if and when needed. Like in thrombocytopenia, you might have to give platelet transfusion. In coagulopathy, you might have to give FFP. Like that, you do the hematological corrections also. Those are the supportive care during the sepsis. But most important thing is the prevention, which is better than cure. You know that our hands are full of bugs. So hand washing is the most proven and the best practice to prevent infection, and which is cheaper in a way than giving very expensive high-fi antibiotics. So we have been talking about this hand washing. As you take a universal precautions, hand washing techniques, you must know in and out about these 7 steps of hand washing. And you have to take your time. You usually hand wash for about 40 to 60 seconds and you follow the steps. And you have to be a little obsessed about this hand washing when you're handling with patients. Apart from that, that is hand washing technique. This is another very important aspect. 5 movements of hand hygiene. Sometimes you forget this thing. again, you have to be little obsessed about this. There are 5 things. You wash your hands or hand sanitizer before touching a patient, before procedures. Usually you do those things. I mean, before touching a patient and before procedure, you automatically wash your hands. But the other things like after a procedure, after removing the gloves, you forget to wash your hands. Or and after touching a patient and after touching the patient's surrounding. So what when you're seeing a patient, okay, you go near the patient, you wash your hands and examine the patient. Then again, you have to wash your hands or use the hand rub. And then you write on the tickets or do whatever the things around the patient. And then again, before going to the next patient, you have to clean your hands. So these 5 movements are very important to prevent cross-infection. And hand sanitizers should be freely available near patients. And when you are using hand sanitizers or hand rubs, that is an alternative way for hand wash with soap and water. But if your hands are very soiled with suppose that it was urine or feces or some secretions, don't use the hand sanitizers. Always wash your hands with soap and water. When you're using the hand sanitizer, again, you have to use the 7 steps. Those 7 steps. You might take about 20 to 30 seconds, but have to follow the steps. The same techniques. Otherwise, your hands won't be clean enough. So these are very important things, especially in ICUs and very high dependency units. Right after you wash your hands, don't answer phone calls, don't touch your phone, don't scratch nose and eyes, and don't touch the BHCO pen. Don't touch anything around the patient. The only activity you can do is to touch the patient. So you have to be a little obsessed about these things. And no mobile phones. So you know that your phone is full of bugs, Toxacinobacter, this and that is there in the phone. And don't use the phone inside the patient area. That is one thing is that it is disturbing. The other thing is you can contaminate the patient area. When your hands are sterile, don't answer any phone calls. Suppose you have to answer a phone call, okay, then you go out and answer the phone call, and then again clean your hands with at least the hand sanitizer and come back to the patient. Using gloves also very important. You must know that hand washing should be done before wearing gloves as well as after wearing gloves. Don't just think that you are on gloves and your hands are clean. Gloves without hand washing and hygiene transmit germs. And no sharing. We should not share one patient's things with another patient. There should be separate items for each and every patient as much as possible. And before entering a special care baby unit or a NICU or PBU, you have to change the shoes, hold the sleeves of your the shirt or the frock, and then remove the watches and the bangles and rings, and avoid bringing your personal items like stethoscopes, and avoid wearing ties or if not just tuck them away safely, just to prevent contamination of the unit. This is also very important, handling the IV accesses, because that is also a way of transmitting infection. So even a small cannula should be handled very carefully as an aseptic procedure. Cannula, long lines or central lines has to be managed very carefully, because otherwise the infection directly goes to the bloodstream. These are some aseptic procedures you should be doing: intubation, peripheral line insertion, central line insertion, umbilical venous catheterization, lumbar puncture, IC tube insertion, and arterial punctures. That is related to the neonates. I wanted to just highlight on this intubation because it's again an aseptic procedure. You have to wash your hands, wear gloves, and use the sterile equipment, right? And have to have a sterile area close by. And you have to maintain the sterility, because after sterilizing the laryngoscope, you can't keep it here and there. You have to have a sterile towel or a sterile like glove cover or something close by to keep the used items, because you might have to reuse the laryngoscope for a second chance. So and also the sucker tubes and the ET tubes. So if they are not in use, you keep them on a sterile surface. Otherwise, they can get contaminated, then the patient can be and the germs can be transmitted to the patient. The other best practices are in a hospital setup, so maternity hospital setup, to have clean delivery and avoid unnecessary separation of the mother and the baby. Practice rooming in and bedding in concept. Keep both the mother and the baby in one room and one bed. Appropriate umbilical cord care. Clean the cord with soap and water only. Don't use any other thing to clean it. And use early enteral feeding and exclusive breastfeeding. No formula feeding. And practice kangaroo mother care. And omit IV fluids and IV antibiotics as early as possible. Use probiotics appropriately. Then environmental cleaning and general cleanliness according to guidelines. And if the patient is on a ventilator, to take all the precautions to prevent ventilator-associated pneumonia. Right. That is about neonatal sepsis. So we'll go for the neonatal jaundice. I heard that Dr. Kaushal has covered some of the things from this topic as well, so I can go through it quickly. So that is another important aspect with regards to neonates. So the jaundice means that yellow discoloration of the skin and the sclera of newborn due to the accumulation of bilirubin in skin and mucous membranes. It's a very common scenario. It's very common in term babies as well as in preterm babies as well as in term babies. It can be mild or severe, but you should not underestimate it or overestimate it. This is about the bilirubin metabolism. You know about it, so I'm not going to go through it. It's in your books. So there are two types of jaundice: physiological and pathological. Physiological jaundice means it appears between 24 to 72 hours of life, right? Maximum intensity is seen in 4th to 5th day in term babies and 7th day in preterm babies. Usually it is not that high, so most of the time it is less than 15 milligram per deciliter, and it's clinically undetectable after 14 days. It's common and it's generally harmless, and there are no underlying causes. Pathological jaundice, it's either the clinical jaundice is seen within first 24 hours of birth, or bilirubin levels are very high after 24 hours, or the rate of rise is very high, or the conjugated fraction is more than 20% of the total bilirubin level, or it is persisting. Jaundice is persisting beyond 2 weeks of age in full-term infants and more than 3 weeks of age in preterm infants. We call it prolonged jaundice. So if you find any one of these, that is pathological. Roughly about the causes of jaundice appearing within the it depends on the age, appearing within the 24 hours, mainly hemolytic diseases like blood group incompatibilities, infection, or any other appearing after 24 hours can well be above, as well as the physiological jaundice, breastfeeding, or you call it a starvation jaundice, which is very common, or it can be due to polycythemia, or concealed hemorrhages like cephalohematoma, or any metabolic disorder like galactosemia. So those are pathological causes. Prolonged jaundice. Prolonged jaundice, that is jaundice more than 2 weeks of age. So the baby is continuing to have jaundice even after 2 weeks of age. It can be prolonged unconjugated hyperbilirubinemia or can be prolonged conjugated hyperbilirubinemia. Unconjugated one, the causes for the unconjugated ones are the persisting sepsis or metabolic causes or persisting hemolysis or breast milk jaundice. And these are the causes for the prolonged conjugated hyperbilirubinemia. Have infections like even congenital or acquired infections, or some structural abnormalities like extrahepatic biliary atresia or choledochus cyst, or metabolic causes or total parenteral nutrition usage and inspissated bile syndrome. So when you see a baby, this is how you approach. So see what the gestation is, whether this is a preterm baby, because there is high chance of them having high levels of bilirubin and high chance of them going into connectors. And see what's the birth weight and the current weight to see whether there's a weight loss due to dehydration, lactation problems, and which is causing the starvation jaundice. Then see what's the postnatal age in hours, because your bilirubin levels are plotted according to postnatal hours, not days. So you have to know the age in hours. Then see whether the baby is clinically ill or well to see whether the baby is septic or not. Then what is the severity of jaundice clinically? Very, very mild jaundice or severe jaundice. So after doing this initial evaluation, then decide whether the baby needs investigations jaundice, because unnecessary investigation is not good. And whether the clinically whether the baby needs phototherapy or beyond that, exchange transfusion, or baby has any features on encephalopathy, which is a very serious complication with regard to jaundice. This is a rough estimation of severity of jaundice in milligrams per deciliter by visual perception. So if you see the jaundice only in face, it is more likely roughly about 6 milligram per deciliter. But if it is in feet, then it is 18 to 20 milligram per deciliter, which is very, very high levels. It's very high, most likely needing phototherapy. It's a rough guide, but you can go by that initially until you get the bilirubin levels. So these are the investigations. Okay, now you have a baby with jaundice. Now you have decided to go for investigations. So do the serum bilirubin with fractions, and then do the hemoglobin, reticulocyte count, blood picture to see any evidence of hemolysis. Then check the blood group of the mother and baby to diagnose whether it was an RH incompatibility or ABO incompatibility. Do the direct home test to see whether it is immune related, immune mediated hemolysis. And go for the septic screen also if sepsis is suspected. And check the electrolytes and renal functions, because if there is delayed establishment of breastfeeding, if there is a lactation failure, the babies can be dehydrated and they can have very high levels of sodium, hypernatremia, and high levels of urea. So check for those things as well. And after that, you go for the second line investigations as indicated. A little bit on kernicterus. Must know about this. It is a very serious complications of hyperbilirubinemia. It's because of the unconjugated bilirubin. It is lipid soluble, and it can cross the blood-brain barrier very well, and deposit in the basal ganglia and can cause chorioacetoid cerebral palsy, which is a very serious complication. But it is preventable. It's a preventable condition if you detect the jaundice early and you act promptly. You should not let the baby get kernicterus. That is the end of their lives. These are the features you can see with acute bilirubin encephalopathy, early kernicterus, lethargy, high-pitched cry, poor feeding, abnormal tone, opisthotonous posture, and seizures. But aggressive treatment can reduce the damage, leading to this chorioathetoid cerebral palsy and further complications. So diagnose it early and treat promptly. The treatment for jaundice, phototherapy is the main treatment for neonatal jaundice. And you go by the, you plot the total serum bilirubin levels in the charts, not the unconjugated bilirubin levels. You have to remember that you have to plot the total bilirubin levels. You know the mechanism. This is a lipid soluble thing. The bilirubin is a lipid soluble thing. And with photo oxidation, it becomes more water soluble and can excrete in urine and stools. And you use the blue light. And these days we use the LED lights. And you can keep the light very closer to the baby to give more intense phototherapy. It won't make the baby very warm. And if you can expose the skin, expose the skin properly by turning the baby prone and supine, then again you can give more phototherapy, intense phototherapy. So nowadays, of course, it's most of the time it is the LED lights that we use, but there can be some phototherapy machines with fluorescent lights. In which case, of course, you have to then keep the baby about 18 inches away from the light. And it can cause fever, and can cause dehydration. So you have to hydrate the baby well. And once the baby is under phototherapy, don't try to assess the severity, because the visual assessment is inaccurate after starting phototherapy, because the color changes. During phototherapy, you have to monitor the bilirubin levels according to the guidelines, right? And then the other point I want to highlight is that if the baby is 14 days of age or more, the charts you use are not the ones you use at the beginning. Like then you have to use the chart adjusted for the current gestational age. For example, if the baby was 32 weeks of age and you see the baby in 1 week's time and the baby is jaundiced, and then you plot the bilirubin levels at 32-week chart. But if you see the baby at say 2 weeks of age, so the baby is now 34 weeks, then you have to plot at 34-week chart. So after 14 days only that you change the type of the chart. So you stop phototherapy when the bilirubin levels are 5 small blocks below the phototherapy threshold, but you have to repeat it and see whether there is a rebound. These are the charts used in the hospital in the neonatal units. These are national guidelines for newborn care charts. It's available. The charts are available from 28 weeks to 38 weeks. And feeding and hydration during the phototherapy. If it is just single conventional phototherapy, you can even breastfeed the baby and give EBM cup feeding, and can have about breaks of about 30 minutes for nappy changing and cuddling. But if the baby is on multiple phototherapy, double phototherapy or triple phototherapy, we usually don't interrupt phototherapy for feeding. You give either IV fluids or enteral feeding via cup or NG while the baby is under phototherapy. You don't usually take the baby out from the phototherapy machine cover. But you need to continue lactation support to the mother during that time, because after finishing phototherapy, you have to restart breastfeeding. So you can support the mother with expression, stimulation, and breastfeeding counseling. During phototherapy, you change the posture from supine to prone, and to cover the genitalia and protect the eyes and maintain the temperature. There is some developed diarrhea temperature instability, fever or coldness, dehydration, rashes, change in the color. Then phototherapy is not recommended in conjugated hyperbilirubinemia because of the risk of bronze baby syndrome due to accumulation of porphyrin. And prophylactic phototherapy again does not offer any clinical benefit. So usually they don't now recommend to give prophylactic phototherapy. You have to go by the bilirubin levels, but of course then, it has to be reliable. Bilirubin, the report has to be reliable. Exchange transfusion is the other option for very high level of bilirubin. You usually do double volume exchange transfusion. Usually the blood volume is about 80 ml per kg, the baby's blood volume. So you use double volume exchange transfusion. It's indicated if the bilirubin levels continue to rise in spite of adequate hydration and multiple phototherapy. There is a rapid rise of bilirubin especially in preterm babies. So babies, really high risk babies, or if there are signs of kernicterus. So in these instances, you have to go for exchange transfusion. There's a way of selecting the blood type that, of course, I'm not going to go into detail. You have to always liaise with the blood bank. You have to discuss with them which type of blood, which type of plasma, and how to mix and that. So you have instructions from the blood bank and use that blood on the baby for exchange transfusion. Complications during exchange transfusion, there can be hypoglycemia, some electrolyte imbalances, coagulopathy, volume overload, and infection. There is a place for intravenous immunoglobulin also, especially for the immune causes. If the bilirubin levels are not coming down, or if there are signs of kernicterus, if there is a rapid rise, then you may use intravenous immunoglobulin. That again is sometimes not really available and very expensive. So that was all for the unconjugated hyperbilirubinemia. So conjugated hyperbilirubinemia means that direct bilirubin levels are greater than 1 milligram per deciliter if the total bilirubin is less than 5. Sometimes you will get a scenario like that. Or more than 20% of the total bilirubin if the total bilirubin is greater than 5 milligram per deciliter. So either it is other way it is conjugated hyperbilirubinemia. In conjugated hyperbilirubinemia, you have to look for the stool color and the urine color, because you can get pale stools and dark urine with that, and also look for hepatosplenomegaly. This is the diagram of normal colored stools and abnormal color, clay color pale stools. This is they are in the child health development record, CHDR in babies. We discussed about the causes for the conjugated hyperbilirubinemia earlier also. Infection, obstruction, metabolic causes, hormonal causes. These are the common ones. The investigations are done according to the cause, suspecting cause. So you first do the serum bilirubin level with the direct fraction. You have to see whether it is above that level I mentioned earlier. Then you can do the ultrasound scan abdomen to detect any structural abnormality in the bile system. And then have to assess the liver functions, especially the alkaline phosphatase levels, to see whether there is any obstruction. And urine for reducing substances is for the metabolic causes. And urine bile again can be high with obstruction. And UFRN culture for infections, UTI. Then you have to do the torch screening to detect the congenital infection. The most important thing is the extrahepatic biliary atresia. and it should be diagnosed as early as possible, within 8 weeks or within even 6 weeks of life, for better surgical and survival outcome. Otherwise, they will develop this liver failure, cirrhosis, and ultimately they die in early age. Not miss the biliary atresia. Thank you. That's all. Any question?
Can you see my slides and can you hear me? Hello, can you see my slides?
Yes, madam, can hear and see.
Yes, madam.
Okay, good. During next half an hour, I'm going to talk how to do the neonatal examination of a baby, newborn baby, and newborn screening. During this talk, I'm going to discuss what are the goals of routine newborn examination, examination in the delivery room, and how to do complete routine examination, then system-wise assessment, and what are the abnormalities and normal variants, and lastly, few facts about newborn screening in our country. Neonatal examination is a core component of child health surveillance programs around the world, and it is so all the babies who are born in our hospital must have a neonatal examination before they go home. Why we need to do neonatal examination? It is to diagnose congenital malformations and common neonatal conditions and advise about their management. Then we can screen for specific target conditions such as developmental dysplasia of the hip, congenital cataract, undescended testes, and congenital heart diseases. We can initiate appropriate treatment and arrange for the advice and follow-up where indicated. For example, we can start phototherapy for babies who are jaundice when you detect early and prevent a lot of complications in the future. Next, you can provide health education like breastfeeding advices and cord death prevention. We should address any parental concerns and worries so that we have less readmissions and early arrival to hospital if there are any serious conditions. Who should examine the baby? Should be a trained practitioner who should have time. We should spare some time to speak to parents and listen to their concerns. When we should examine these babies, we should examine them before discharge or within first 7 to 2 hours. That doesn't mean if the baby is going to stay in your ward and you should leave the examination till the day 7 of life. Examination in the delivery room. We don't have to do complete examination in the delivery room if you are attending the delivery, but all the babies should have quick assessment soon after birth. If only the midwife is attending, especially for these uncomplicated full-term deliveries, she should be able to do the examination. If you have been called to attend the delivery, you should make a quick assessment of the baby. This is to ensure the baby is clinically well and does not have major congenital abnormalities which need urgent attention. These conditions are imperforate anus, ambiguous genitalia, cleft lip and palate, spina bifida, and critical congenital heart diseases. What are the components of newborn examination? You should take a brief history and you can speak to mother and you can also get more details from maternal notes. Then you should do the complete examination. And after that, you can do health educations and clarify all the parental maternal concerns and worries. And if the examination is completely normal, then you should kindly let the mother know that the baby's examination is normal. Let's quickly go through the complete examination, and after this, I'm going to go through the do the system assessment. You need to get some background knowledge before you touch the baby and speak to the mother. You can get these details from the maternal notes: baby sex, what is the birth weight, gestational age, maternal age, and socio-economic background, and whether there is any significant family history of note. These things are very important when you counsel the mother. Next, presence of maternal medical conditions and their treatment is very important. Details of the previous pregnancies, which they are usually documenting in the antenatal record. If there are neonatal deaths and early childhood death, this is again going to be very important when we follow up these babies. You need to get information about the current pregnancy, what kind of antenatal period mother had, whether it is complicated or uncomplicated, and results of anomaly scan results. Next, you need to get details on labor, whether the mother, whether there was abnormal intrapartum monitoring, mode of delivery, type of anesthesia, and type of analgesia mother had during the labor. Conditions at the birth and details of resuscitation is again very important, including APGAR score. You should ask the staff about how the feeding is going. Then you should examine, you should introduce yourself to mother and explain her what you are going to do, and aims of your examination in simple language. You should first build rapport with mother, inquiring about feeding and passing of her spoo and feed. Then you can further review and confirm if you have any if you need any clarification about any abnormalities or any information you gathered from maternal notes. Then you should ask maternal concerns and worries, which you will be able to address at the end of the examination. While as you talk with the mother, it is very important to observe two things. Firstly, mom's attitude towards her baby, whether mother is confident and happy or whether she's tense and withdrawn. Then you quickly have a glance at baby to look, see what the color of the baby face is, whether there's abnormal faces, characteristic faces, breathing pattern, posture, and movements. Then you move ahead to perform formal examination. Before you touch the baby, hand hygiene is extremely important. So we discussed, I think you all learned during the previous lecture how to do the hand hygiene. If you can't, due to practical reasons, if you can't wash your hands properly, and at least use hand sanitizer, that is a must. Then remove the baby's clothes, but be mindful to let mother know that you are going to remove baby's clothes except the nappy. Then you should examine the baby systematically from head to toe. Therefore, you won't miss anything. And then from front to the back. Before you go do this system head to toe examination, if the baby is quiet and sleeping, it is very wise to feel the anterior fontanelle and look at the eyes and check the red reflex and auscultate the heart and palpate the abdomen. Because if you touch the baby and if he or she starts crying, and you won't be able to assess these parameters properly. You should leave the HEPS examination till the end of the examination, because definitely you are going to make him or her angry. After this assessment, initial assessment, then you can return to examine the head. You can start the examination from the head, examine the scalp and skull and measure the head circumference. You should compare it with the length and the weight, which I have seen which that is not happening properly, even in a unit where I work. Then you should check baby's eyes, ears, nose and mouth. Then move further down and check the baby's neck for lumps and examine the clavicles for fractures. Then examine the arms, hands, legs and feet. Then you should remove the nappy. Please tell mother that you are going to remove the nappy and see whether she is okay with that. You should feel the femoral pulses as well. But again, femoral pulses also, it will be difficult to feel if the baby is screaming. Therefore, at the time you auscultate the heart, if possible, you should feel the femoral pulses as well. Then examine the genitalia and anus. Turn the baby to prone position and check the back, spine and assist tone of the baby. Again, turn the baby to supine position and evaluate the nervous system by doing the primitive reflexes and assessing there are other parameters. Finally, check the hips, and you need to address all the concerns raised by mom and tell your examination findings. If it is normal, don't just leave the place and tell mother that your baby's examination is normal. And finally, even if you, after finishing all the examination, if you don't document properly, that is, your examination is not complete. Therefore, you must document. There are two types of documentation which you must perform at the end of your examination. Firstly, you can see this neonatal examination format, which is attached to mother's notes, which stays with the BHD and goes to the record room. And in the third page, you can see there is a part where you have to document neonatal examination findings. And the second, the third picture in this slide, you can see this page number 7 of the CHDR, which that is the place where you document. And CHDR, we all know that goes with we provide to mother on discharge, so that you can use these findings in the field setup. Okay, so let's do the systemic assessment. I'm quickly going through these slides, and if I'm too fast, please send a text to this chat box. All right, let's examine the skin of the baby. You should look for the colors, texture, and birthmarks. And then the birthmarks there are quite number of different types of birthmarks you might encounter during your examination. Most of the birthmarks are vascular and pigmentary lesions. Many of these are normal variants. So assessment of the skin color. So you discussed jaundice in the previous lecture. This is, I think you can see this baby is yellowish in color. This is jaundice, and it is very important to assess jaundice thoroughly and the presence of risk factor. This is something which we can prevent serious complications by early intervention. Then I think you can appreciate the one baby is red and the other baby is pale. These are twins, MCDA twins with twin-to-twin transfusion. The first baby who is red, this is called plethora, and the other baby is pale. A plethoric baby is very important to identify because these babies can easily become jaundice and can have other problems like glutinous, low saturations, like that. And in this picture, this is again an important physical sign you should be able to appreciate in your examination. Even though this rest of the body is not very clear, you can see this baby's feet are bluish in color. If the mouth is normal, and if the baby's hands and feet are only the hands and feet are bluish in color, this is called acrocyanosis, which is commonly due to cold environment. However, you should see other causes of acrocyanosis like IUGR babies IUGR and preterm babies can easily become can have acrocyanosis. It is very important to diagnose this central cyanosis, which indicates underlying serious conditions, especially congenital heart disease, if the baby doesn't have any kind of respiratory distress. Then let's review commonly seen birthmarks. This is you can see this birthmarks, which is in the baby's buttocks, which is like bruising-like appearance. These are called Mongolian blue spots, which can commonly be seen in Asian communities like us, and it disappears by first birthday. And hemangiomas are again, this is earlier they called this is strawberry nevus. Isolated hemangiomas will not cause any problems, small hemangiomas, but if there are multiple and the lesions in critical areas like obscuring the vision and airway can cause problems, need intervention. This picture, you can see this faint erythematous bluish mark on the forehead. This is again collection of capillaries. Again, it is a normal variant which doesn't need intervention. This is called salmon patch or stroke mark. These are congenital melanocytic lesions, and this the last picture. This is very important to know. This is called very port wine port wine stain. This port wine stain, it is affecting the ophthalmic division of the trigeminal nerve, may have underlying serious condition like Sturge-Weber syndrome, where there are abnormalities of the brain. Therefore, it is very important to get further opinion and evaluate this baby. Skin texture, this is the normal skin of the normal baby with normal skin. As you can see, this baby is nice and pink and has tight skin. This picture, you can see this baby's baby is like an old person. The skin is very loose. This is IUGR. This is an IUGR baby. This is the skin which you see in post-term babies where there are a lot of skin peeling. There are various different kind of skin rashes you might encounter. This is one of the commonest commonest rash called erythema toxicum. You can see these tiny papules, whitish papules surrounded by erythema. This kind of rash usually appears between 24 to 48 hours and disappears by day 5 of age. Doesn't need any intervention, but you need to reassure mother that there is no active intervention is required. And this is these tiny creamy papules called milia. This is again normal kind of baby rash, doesn't need any intervention. This tiny papules contains keratinized stratum cornea. I'm not sure whether you can appreciate this baby is having pinhead size blood macules on his face. This is a non-blanching rash. This is called petechia, which warrant in the if you see a baby with petechia, need to perform full blood count and assess platelet count. And sometimes it might be present only on face if there is a traumatic delivery. This is called miliaria rubra, again in a rash which doesn't need intervention, commonly seen in hot, humid climate. Transient neonatal pustular melanosis, again a normal kind of rash which doesn't need intervention. I have seen some babies have been started on antibiotics thinking this is a staphylococcal rash, but this is not. Usually this kind of rash we can be seen within first 24 hours of life. Okay, let's move to the head and skull examination. You should feel the anterior fontanelle for its size, shape, and you should check whether this is bulging or tense. Usually, this is the normal neonatal skull. You can see the anterior fontanelle, which is a diamond shape, and usually the size is 3 into 3 centimeters at its widest point. If it is larger than that, need further evaluation. In about 3% of babies, posterior fontanelle is open. If it is present, it is not larger than 2 centimeters. If the fontanelle is bulging and tense, it may indicate underlying cerebral edema, hydrocephalus, or meningitis. It is very important to differentiate this ridging of the sutures and craniosynostosis. When you feel, I think you will be able to feel the difference in ridging, which is commonly seen in babies due to within first 48 hours due to molding. You will feel this step up feeling when you palpate along the suture lines. Whereas in craniosynostosis, the feeling will be different. Ridging, this molding, which doesn't need intervention, but if you detect craniosynostosis, which commonly affect this sagittal suture, need neurosurgical intervention. Then there are scalp hematomas, which is very important to diagnose. Caput is the swelling of the presenting part, which is the edema of the subcutaneous tissue just after the delivery, especially after this vacuum delivery, which commonly resolves within 24 hours. And there are cephal hematomas, is bleeding under the periosteum, which limits by the suture lines and does not extend beyond the sutures. Whereas the subgaleal hematoma, which is the most dangerous or sinister type of bleeding, which can extend under the epineuritis, it can affect entire scalp, which is kind of very bulky swelling compared to this tense swelling, which is the cephal hematoma. This picture shows baby with cephal hematoma. I think you can appreciate this. This swelling has not extended beyond the suture lines. This subgaleal hematoma need close monitoring and observation, because this bleeding can extend under the whole entire aponeurosis, can cause massive blood loss, coagulopathy, shock, and death of the baby. Then measure the head circumference, occipital-frontal circumference, and plot it in the chart and compare with the head length and the weight of the baby. Next, examine the face. Move to examine the face of the baby. So there are characteristic faces you might see during your neonatal examination. I know all of you must have encountered a baby with Down syndrome. Then this is called asymmetric crying faces. This is due to absent depressa angularis oris muscle, which you should be able to differentiate this asymmetric crying, this deficiency of depressa angularis oris muscle from the facial nerve palsy. In this condition, the baby can wrinkle the forehead and can close the eyes, and nasolabial folds are preserved. Whereas in facial nerve palsy, baby will not be able to wrinkle the forehead, and there will be absent nasolabial folds. This picture shows infant born to diabetic mother. You can appreciate the cherubic faces of the baby. Yes, then there are low set. There are babies with low set ears. It may be isolated findings or may be a part of different syndromes. If you draw an imaginary line from the outer canthus to the occipital protuberance, the 1/3 of the auricle should lie above this line. And if it is below the line, it calls low set ears. These are the pictures of babies with pre-auricular tract and ear pit. If these lesions occur in isolation, only action you have to take is to assess the hearing assessment. And if there are multiple other lesions and other dysmorphic features, you should do renal scan. And examination of the nose, you should inspect the nose for general shape, width of the bridge, and this is the nasal bridge is flat, and then there is a wide gap between the inner canthi. If it is more than 2.5 centimeters, this is called hypertaylorism, may be a part of different syndrome, and sometimes you might see displacement of the nasal cartilage, which need ENT opinion. Examination of the eyes is very important. Part of neonatal examination. You should look for gross abnormalities, size of the eyes, slant, strabismus, and nystagmus. This is one of the common conditions you might encounter. This is called sticky eye. This is not an infection. As you can see, this baby's eyes are not swollen or red, and this is does not need intervention. In contrast to that, this baby have thick purulent discharge. Which need, and eyes are swollen and red, so this need urgent investigations and antibiotics. Could be most possibly due to ophthalmia neonatorum, due to gonococci or chlamydia. These are developmental abnormalities present as part of different syndrome. This is called eyelid coloboma, and this is iris coloboma. This appears like a keyhole appearance of the iris, and this is subconjunctival hemorrhage. You can see this bleeding in the cornea conjunctiva, which does not need intervention, only the reassurance of the mother. This is very important, as is in the red reflex. This is the most important part of eye assessment in newborn examination. You can see this right eye there is a right circular appearance in the right pupil, right side pupil. This is the normal red reflex. In the other eye, you can't see that pupillar red reflex. Absence of red reflex indicates congenital cataract or retinoblastoma reale. So congenital cataract is one of the leading cause of blindhood during childhood. Therefore, it is very important to assess the red reflex. Okay, let's examine the mouth next. You should assess the size of the mouth, micronathia, asymmetry of the corners mouth. There will be a lot of abnormalities of the mouth in neonates. Some are normal variants. This is the first picture is natal teeth, which is unerupted, and second picture is neonatal teeth, is erupted to tooth, which might cause feeding problems. Need removal of extraction of the tooth, and this is called Epstein-Barr normal variant. And this is a tongue tie, again does not need intervention at the moment. And this is something you should not miss. This is called posterior cleft palate. You might miss this condition unless you examine the baby's mouth properly. So a good time to examine the mouth is when after the hip examination, you can flash the torch and check for posterior cleft palate. Right, so examine the neck. You should palpate along the sternocleidomastoid muscle to look for any tumors, and then you might see webbing of the neck in babies with Turner syndrome. Then examine the chest and cardiorespiratory system. You should check the baby's chest wall for does not need intervention. Accessory nipples may be isolated finding, and widely spaced nipples may be a normal finding if there are no other dysmorphic features, or may be part of syndromes like Turner syndrome. Cardiac examination. You should palpate the chest precordium for thrills, prominent left ventricular heave. Might be difficult to examine these tiny neonates, not like older children. Then auscultate for murmurs. There are innocent murmurs and clinically significant murmurs. Innocent murmurs are usually grade 1 to 2 systolic murmurs commonly heard in the left sternal edge. Significant murmurs are a little bit louder, maybe grade 3 and above, and associated with clicks. Detected in left upper sternal edge. You should palpate for peripheral pulses. Abnormal pulses can be detected in the presence of patent ductus arteriosus. Respiratory system, you should assess the respiratory rate. Normal rate is up to 60 breaths per minute, and assess evidence of respiratory distress by looking for grunting, retractions, nasal flaring. Then move further down to check the abdomen. You should inspect the abdomen. You can check the cord if you are attending the delivery. Single umbilical artery is one of the normal, could be one normal variant or could be part of syndrome. If the baby is completely normal, you don't have to worry about that because some percentage of babies have single umbilical artery. With the association of other dysmorphic features may indicate underlying renal abnormalities. So this is the cross sections of umbilical cord with single umbilical artery. Look, check the abdomen, inspect the abdomen for distension, umbilical erythema. You might, so this is the baby whose cord has fallen, separated. Before discharge, during your neonatal examination, cord is usually intact, therefore look for any discharges. Then palpate the tummy. Usually you can palpate the liver up to 2 centimeters is normal. Spleen is usually, can feel the tip of the spleen, and if it is more than 1 centimeter, need further assessment. Ballot the kidneys and feel the bladder. If you can feel the bladder may indicate underlying posterior urethral valve in a boy. Don't forget to record the time of pus, meconium and urine because delayed passage of meconium may indicate underlying abnormalities. Move further down to check the genitalia. Male, in boys, you should assess the penile length. You don't have to measure the length. Usually it is up to 3 centimeters. And check the urethral meatus. There are various degrees of hypospadias you might encounter. Check the scrotum for rugosity and palpate the testis. This is again very important, and you might see babies with hydrocele. Again, does not need any intervention. A female genitalia, inspect the vulva. You can commonly see small hymen and mucoid cyst. And there are various degrees of ambiguous genitalia, which I'm not going to discuss here. If you find any abnormalities, always ask senior opinion. Don't forget to check the anus. And this is the normal position of the anus in girl and boy. This is the picture of a baby with imperforate anus. Always just separate the thighs and check the anal orifice. Sometimes if the baby has passed meconium, but at the time you do the examination, you might think, the anus is, okay, the anus is present, no need to assess, but please ask mother to clean the meconium and check the anal orifice, because baby may have passed meconium through a fistula. Check this next, move into examination of the spine. You should turn the baby into prone position, inspect the curvature, midline abnormalities, the skull, sacral dimple, hairy patch, or nevus. This is a simple sacral dimple. You should be able to identify simple sacral dimple from the dimples which need intervention. If the sacral dimple is within 2.5 centimeters from the anal orifice, and if you can see the base, that does not need any intervention. But if there are other associated abnormalities, need further investigation by a spinal scan. These are hairy patch and lipoma. These need further evaluation. Next, check the upper limbs. You should inspect the upper limbs for shape, posture, symmetry, and size. Check the hand for flexion deformity of the fingers. You might encounter different types of abnormalities like extra digits, syndactyly, polydactyly. Check the palms for palmar creases. Single palmar creases can be seen even in normal babies, but if there are other dysmorphic features, could be a part of, could present as part of syndrome as well. Especially here, you should especially check for arm movements. In third picture, as you can see here, there is upper brachial plexus injuries called Erb's palsy. Lower limbs, inspect the legs and feet for posture, symmetry, general size and shape, obvious deformities, and observe spontaneous or stimulated active movements again. This is called calcaneovalgus deformity. This is invariably due to fetal position, doesn't need intervention. And if you encounter baby with calcaneovarus deformity, when the foot is turned medially, you should perform this maneuver. If you can perform this maneuver, there is no need of intervention. This third picture, of course, need talipes equinovarus deformity, need orthopedic intervention before send the baby home. Hip examination is very important to assess developmental dysplasia of the hip, and you should perform Barlow's and Ottolani's maneuver. You should learn it when you start doing the neonatal examination, and I do not have enough time to explain it now. Finally, you need to do a neurological assessment. You can check the behavioral state by assessing the baby's sleep status and baby's cry, posture, movement, baby's movement, muscle tone and strength. And you can assess feeding and sucking. Finally, you should assess primitive reflexes, Morose reflex, Grass reflex, and asymmetric tonic neck reflex. There are some suspicious neurological signs, such as persistent failure of sucking, high-pitched cry, extreme irritability, abnormal posturing, frog position or generalized hypotonia, lack of spontaneous movement, including facial expressions, asymmetrical movements, and convulsions, which you discussed earlier in previous lectures. These abnormalities, if the baby presents with any of these abnormalities, you must do further in an assessment. Finally, newborn screening. There are various newborn screening measures which we are currently doing in our country. One is pulse oximetry screening for critical congenital heart disease. Hearing screening, screening for congenital hyperthyroidism by Hilbrick, and developmental dysplasia of the hip and congenital cataract. So you should have some basic idea about this screening neonatal screening as well. With that, my lecture is, this is the last slide of my lecture. Thank you very much for your attention. If you have any questions, send it in the chat box. Thank you.
Can you hear me?
Yes, madam, can see. Can start.
Yeah. Slides are moving. There is heavy rain here, so there is
Madam, we'll switch off the video.
Oh, 7% එකෙන් අපි දැන් ලියනවා. දැන් chart එකක් හදලා ලියුවා.
මේ වහිනවා මේසු.
to know whether my screens are moving. My slides are
Right. We won't be having today's last lecture because there's issue with the connection. So in that case, we will let you know some other time for that lecture. At the meantime, we will conclude today's pediatric session. So those who are unable to attend, submit their attendance. So try next time to submit in the particular time. And another thing is Monday we are starting with anesthesia. So join by 8 a.m. Right. Thank you.